Audible?
Sir,
Okay.
you're audible.
ఓకే ఈ కెమెరా పట్టుకొచ్చేమో ముందు వీడియో కంప్లీట్ చేద్దాం ఆ బాబుని గుడ్ మార్నింగ్ టు ఎవ్రీవన్.
Sir, your audio should be a bit louder.
ఓకే గుడ్ మార్నింగ్ టు ఎవ్రీవన్. కొంచెం నా వాయిస్ కొంచెం పెంచండి.
It is better now, sir.
ఓకే ఓకే థ్యాంక్ యూ. థ్యాంక్ యూ. ఫస్ట్ వెల్కమ్ యూ ఆల్ ఫర్ ద టుడేస్ second live surgical cochlear implant workshop, and also I'm expressing sorry for the delays due to the technical reasons. My main intention is to start this live surgical workshop to elevate the fear complexes in juniors and also upcoming ENT surgeons. Today I'm going to demonstrate the surgical steps from starting from the preparation of the patient and shifting to the OT. Why? Because most of the times we are observing the surgeries starting from sometimes the incisions or from the exposure of the part. First, basically, if you have to know the steps meticulously from starting point itself. Just now I will going to show the patient how to prepare the patient. First, you should know. Patient, please go.
A warm welcome to everyone to the second live cochlear implant surgery workshop being held at RR Specialty Hospital in Guntur. So Dr. Subbarayudu will be demonstrating a cochlear implant surgery and he wants to show from step A to step Z. So which is first he's going to just show how the patient is walked into the hospital, walked into the theater, and regarding the scans, and each step by step he's going to show meticulously so that it will be helpful for all budding cochlear implant surgeons. Over to you, Dr. Raidu.
After, from the point where we are starting is already we have defined the candidacy criteria, and also we have verified everything. The case, just display the case details in between, Rajgaru. First case.
Okay, sir. Okay.
First case, the age, just describe. Narendra? There in the pen drive.
So just want to confirm with you, the child's name is Y. Shravani.
Sharwani.
Y. Sharwani.
Sharwani. Describe
Okay.
చేయండి.
She's a 2-year-old female child diagnosed with bilateral profound hearing loss, congenital hearing loss, no associated comorbidities. There is no significant abnormality in the developmental history, and she has a reasonably straightforward medical history. The congenital hearing loss, previously no neonatal hearing screening was done. She was detected at the age of 1 year, 9 months. As there was delay in speech and language, she underwent further tests, and she was considered to be suitable for cochlear implant surgery. She was on the waiting list for the last 6 months. She was given hearing aids, and she's currently on hearing aid therapy, but not much benefit was noticed. She could only say a few words like Papa, Tata. No history of NICU care, no history of developmental delay, apparently normal intellect. So,
Okay, so
immunization, she was immunized for the age, no family history of hearing loss. So there was no mention here about consanguinity of parents, sir. Because this part of Andhra, there is most of the times there is history of consanguineous parents and associated with congenital hearing loss in children. She was investigated with CT scan and MRI, and she required a pediatric hearing evaluation, in which she was found to have bilateral profound hearing loss.
ఆన్లైన్ లో సిటీస్ అవి రావట్లేదు రాజు గారు.
So you had the CT scans. Okay. So,
Okay, sir. I will show the CT scans here. Just complete the history.
yeah,
Okay. We'll take.
So this is her hearing test. She had she had bilateral more than 90 decibel hearing loss. So these are the radiological findings, sir. Would you like to go through?
Okay. I will start from here. Okay. Thank you.
Thank you.
Thank you, Raj garu. Now we can see the patient. Preparation of the patient is the most important aspect in cochlear implantation and also the pediatric population. I will explain later on. First, we have to transfer the kid along with the parent to alleviate the separation anxiety. That's why always we'll take the child along with one of the parent to the operation theater. I will explain the preparation and all after coming into the operation theater. We'll take the child into the operation theater along with the kid. Then we'll start the induction agent. We'll hand over the anesthetist while keeping in the patient's father's shoulders only, or we can otherwise we can start induction. Induction in the father's shoulders. Just now what the induction agents we are giving, our anesthetist will explain clearly. Just is giving propofol to give the okay. Just after giving that one, we can transfer the patient onto the table. You can see, I will explain the preparation part now. Whenever you take the side of the surgery, it depends upon the audiological and radiological aspects also. If they're having the profound hearing loss both sides, we will go for the radiological aspects. Here, two key points you have to remember that. 2 key points only. Those are on the visual axis and trajectory. These two will play more in cochlear implantation. Simply now in the first case, I will explain only the needed points. I don't want to create any confusions regarding surgery. You can see this is the surgical roadmap for the cochlear implantation, not the MRI, CT scan. రాజు గారు ఇక్కడ మా కెమెరా చూపించేసేయండి, ఆన్లైన్ అక్కడ తీసేసేయండి. ఆన్లైన్లో ఇక్కడ ఓటీలో కెమెరా. ఓకే, there is a delay. Just see, I'm going to show the axial CT scan, and also these are the coronal cuts. These are the roadmap for surgery. MRI will decide some other issues we'll discuss later in radiological part. Here only I'm going to describe about the surgical issues.
Sir, can you ask the cameraman to focus on the film, sir? A bit more, closer.
But online is going only your screen, Raj Garu. Now there was a delay, a small delay. Otherwise, now you are seeing me. Okay. What I told the trajectory. Now our aim is to identify the round window niche through mastoid. This is a line that is called the trajectory and also visual axis. For that, we have to decide which side of ear is better. This is a well aerated mastoid. All anatomical structures are normal. We can easily go to the round window. This is about the radiological part. We will discuss in detail later. Now you can see the induction of the patient. All first we have to pre-oxygenate.
Raidu. Yeah, we camera, but again we the LC in new one LC.
Problems.
Yeah, to go on, you told that doc anesthesia.
Yes.
So by
Enlighten how to prepare the patients. Okay, next. First.
said
Okay.
you had to tell the how the sandbag, how things also make a
dose of ondansetron by 0.1 milligram per kg. Okay, that is one.
Dexamethasone, what is the dose, sir?
Dexamethasone is also around 0.1 to 0.15 milligram per kg, sir. 0.1 to 0.15 milligram per kg of dexamethasone can be given, sir. Dexamethasone, you need not repeat it at the end of surgery. Ondansetron only, we can repeat it just before extubation if you want. Main goal is to prevent post-operative nausea vomiting. Second goal is to create a surgical field for the surgeon to maintain the maintaining the mean arterial pressure around 60 to 70. 60 to 65 to be more specific. If you maintain the mean arterial pressure of 60 to 65, most of the babies doesn't have any bleeding from the side of anesthesia side. And third thing, which is main point, is a good post-op analgesia. If you take care of all these three aspects, 99% of the babies doesn't require any post-operative care other than just giving oxygenation. You can allow the mother beside the baby and just monitor for hemodynamics. That's all. Within 2 to 3 hours, in our center, we are able to send the baby to the room also. That's all, sir. Anything?
Thank you
anyone-
very much, sir. Very, very nice and detailed explanation.
Thank you, sir.
Madhusudan garu, any question?
Sir, to keep up the warmth of the child,
Yeah.
because all these operation theaters will have
Yes, sir.
air conditioning system or all these things,
Yes, sir.
do we need a heat maintaining blower systems, or
Acha.
a draping like this with multiple drapes is sufficient?
Sir, it depends on the place where we are operating, sir. In a
Okay.
place like Guntur,
Let us think
already-
that Nandyal, Guntur, Sahasra Medical College, all
already the
are
ambient temperature in our place is sufficiently enough to keep the
Okay.
baby warm.
right.
Moreover, we drape the patient with 3 layers of drapings.
Yes.
Apart from these things, if you want, you can give warmed IV fluids. That's all.
Right.
Warming blanket and blowers, I won't think this is required in our setups.
I also always observe now Dr. Raidu, how he is draping and putting the cloth, drape cloth, and 2 towel clips attached to his gown,
Sorry.
which prevents instruments. It's like an
Sir.
instrument stand also.
Sir,
Sir.
getting my voice?
Yes, we are very clear. We are able to get the
securing
picture.
the towel I learned from Dr. Madhusudan Rao Garu while he's doing singly in tonsillectomy surgeries without any assistant.
Uh,
This was very useful for us in all the ear surgery.
Focus is not there. We are able to hear your voice, but the overhead camera.
Sorry, sir.
Now
sorry for
we
that,
got it.
Sorry for that. That's
Ah,
why I
right.
have secured the towel from the table to my
Yes.
chest. I'm fixing this and also position. I will explain the next case, each and everything first step. I'm slightly going to start from the skin incision. Why? Because I already delayed. Patient was
Keep the mic
intubated.
closer to Raidu's mouth.
It was delayed and also intubated. Just I'm starting with the microscope camera.
Okay.
This is the position. I will explain the position later on.
Okay.
Here there are 3 movements. That is called the tilt, rotation, and also flexion, extension. How to get the neutral position of the baby, I will explain with the external camera. Sorry for that glitch. The external cameras are not working properly. Next case we arrange.
If you have a cordless collar mic.
Yes, sir. We are getting that also.
Right.
We have checked thrice. Yesterday and before 2 days also, sir. Everything worked perfectly.
Right.
But today, that is a
No.
problem.
All these technical inconveniences
Okay.
do happen each and everywhere.
Now also, first point is after keeping the baby in a position, we have to surgeon positioning also very much important. We have to keep the microscope in a way to adjust all the positions.
Sir, anesthetist, sir, keep mic closer to Raidu's so that
Okay. Table bit, yes.
you ask some theater assistant to hold the mic.
Rara Sampu. Sir,
No. Yes,
you.
very clear now.
Okay.
నువ్వు పట్టుకో బాబు దగ్గర
Okay,
పట్టుకో
okay.
రైట్
Sir, now we have to set up the microscope also like that. It has the free movements, upwards, downwards, forward and lateral also. All the angulations. This is the microscope position and also the surgeon position. We have to sit comfortably. Sometimes some of the surgeons are doing more than 2 to 3 hours or 4 hours also. We shouldn't hurt our back. That's why the position of the baby and our back also should be straight, and also our legs has to support a small table. for our leg support.
Sir, the cameraman has to focus on you. He's focusing on the microscope stand.
No one is there that is fixed to a stand. That's why.
Okay.
Now I'm starting the microscopic view on the microscope. You are getting the microscope picture?
Yes, sir.
Are you getting the picture?
Sir.
Microscope.
Yeah, we're getting, but it's still needs to be focused on the screen.
Okay. We are getting now.
We can see you, sir, not the mic. Yeah, we're getting now.
Yes. Okay.
Yeah.
Now I will starting from the incision. You can better fix it.
Now it is clear, sir.
Okay. You're getting my voice clear? Hello? 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 Is it clear?
Yes, sir. Yes, sir.
Now you're seeing the microscopic view. Magnification of 6.4. Take a microscope. Are you getting the picture clearly, Raju garu?
Yes, sir.
Now I'm going to start the incision. I have already infiltrated with a single point. Here the point I have given and also marked this one. Before starting the mark, templates, metal templates. Markers. We have to always mark the templates over the skin.
Are you able to hear me?
Yes, sir. Yes, sir.
Yeah. I think you are showing, you will prick at one point and infiltrate all around the operating site, I think. So instead of multiple pricks,
Only single point.
yes.
Towards and also the area where we do the receiver well, and also up to the tip. We have to always keep the thumb as a landmark and guarding the infiltration, not going forward and inferiorly. Sometimes it causes temporary paralysis of the facial nerve. That's why you have to always keep the thumb, and also you have to infiltrate like this side and that side, and also you have to compress.
So if you go below the mastoid tip, you may got transient facial nerve paralysis. You do not know whether it is due to the infiltration or because of this. Yes.
This is the positioning of the processor and receiver stimulator. We have to measure and also mark, sir.
If any delegates are having any questions, please come.
Also, sometimes
You can ask from here, or you can give it on a slip or pass on to us.
Sir, you're getting the Excel camera? It raval. Are you getting
now we are getting PIP. We are getting your external camera as well as the microscopic picture.
First, I will explain with Excel camera, sir. Let's go. Come to here. Fine light here. See, I have placed the template and also the implant. This is the processor.
No. When you want to show your overhead picture, let it be more this thing. The microscope picture, let it be PIP. You can alter the PIP. Now the microscopic picture is making almost 90% of the screen. Let the it just reverse the PIP. Now now we got your very good. Now you go ahead. You are now showing the two templates.
These are the processors, sir.
Yes.
You have to mark this and also template. Usually I won't, because of the experience, I won't mark all these things. If you mark also, it's fade away after draping. What the principle is, the processor and also the receiver stimulator should not each and one on. It causes pressure necrosis. That's why always you have to mark, or you have to keep away 2.5 centimeters from the external artery canal posteriorly. Then only can. That's why we have to make the flaps also like that. Now I'm going to start.
Any importance of angulation?
Angulation around 45 degrees to the external.
Yes, that's it. See that
orbitometal line. We have to make this like my scalpel. This is the 45 degrees angulation.
Yes.
Now I'm starting the incision. Are you getting the picture clearly?
Yeah. Yes, we are getting the picture now. You
Yes,
are giving
just
the
small
only thing is there is
classical lazy yes.
okay.
Just I'm starting just up to the skin only, not going deep, just skin. Just take a lazy yes incision going posteriorly because we are doing on left side. Retraction is main issue at the time. And also because of
Yeah.
infiltration, you can't find any bleeding in this area also. Now, after keeping a pulling the one flap posteriorly and just incising below the skin, not involving the musculoperiosteal layer.
Yeah, yeah. You again repeat this because this is most important, Raidu.
Yes, sir.
So lazy yes incision.
Lazy yes incision, and also just below the skin, I am giving an incision to separate the skin from the musculoperiosteal flap.
Okay.
Are you able to get the picture, sir, clearly?
Yes, yes, yes.
Now I am taking posteriorly, first elevating the flap. See, there is no blood at all. I am not using cautery. Usually, I don't encourage to use the cautery as minimal as possible. After elevating this one as much, and also take the scalpel back, dragger position. While adenidectomy, while doing adenidectomy, we use the dragger position. Just push below the skin, just 2 movements, up and down. Are you able to get the properly, sir?
Yes.
Just upwards and downwards movement, just like a dragger, to have the sufficient space for the receiver stimulator. That's all. We shouldn't do more and more. Like that also, anteriorly, just I am giving some incision subcutaneously only. Here, I will elevate the 2 flaps, not 1 flap. Just like in varia technique. Tomorrow, I will going to demonstrate the varia also. Just varia also. Here, we are practicing the double breasting. Just pull the tissue. Here, postoral area, we have so many layers. I will explain the lecture. This is called extensive postoral fascia. It has 5 layers.
So this is your second layer, sir?
This is the first layer. What I first is the skin. Yes, the second layer. What I am elevating the musculoperiosteal layer. This is anteriorly based flap. I will explain the use of for this. Are you getting the clear picture?
Yes, sir.
Just interrupt whenever you are not getting the picture.
Yeah, the
Just
picture
I-
is good. In between, there are few interruptions.
Okay. Just I am elevating. See here you can see this subcutaneous tissue. I have elevated the one layer. Again, I am going to elevate the posterior superior. That's superior based valva flap.
Can the cameraman focus more on the actual surgical wound?
Okay. Okay. Now you can see. Now you have to carefully observe here what I am doing. Here, after palpating the tip of the mastoid, I am giving a blunt horizontal incision over the tip of the mastoid. Is it clear?
Yes, sir.
Kept the scalpel and given up to the bony level. See, based on that, I am going posteriorly and then posterior superiorly, I will elevate the flap. See how my hand is going on. Just without elevating the scalpel, just go on the bone. Just go on the bone posterior superiorly as much as possible. See,
Okay.
you can see that.
Yes, sir.
This is the posterior. Sorry. This is the posterior.
Sir, can you do it through the microscope?
Okay. You can getting the microscope picture.
Yes, sir.
Just see.
It's very nice, very clear, sir.
Sorry, చెప్పండి నాకు తెలియదు. You can map. Just see. This is the posterior limb of the incision. Just I have given a horizontal incision.
Yeah.
And posterior superiorly I have turned this here up to on the bone.
Okay.
And also from the anterior mark, from this horizontal incision, again posterior, anterior superiorly to have the U-shaped anterior based valva flap. Up to here, we didn't use any cautery also. Have you noticed that?
Yes, sir.
Either monopolar or bipolar. Just.
So from the tip of mastoid, you're scraping it up.
ఎట్లా వెళ్తుంది అక్కడ రావట్లేదు అంటున్నారు నాకు బ్లూటూత్ హెడ్సెట్ ఎవరు అడిగారు చెప్పు బ్లూటూత్ హెడ్సెట్ తీసి పట్టుకోరు అక్కడ నౌ జస్ట్ ఐ ఆమ్ teasing the fibers from the mastoid tip, where I have given the horizontal incision, just teasing. If you have any doubt here, come superiorly, you can easily separate. Are you able to see that one?
Yes, sir. We can
You
see
can
the-
easily separate the layer from the bone. You have to apply the pressure over the bone, not on the flap, because this flap is very much useful. It has to cover the implant. It has to be viable. That's why I am only teasing, applying the pressure over the mastoid and also the tip of the mastoid. See, simply we can see after elevation of some point, our assistant, Srinivas, do that. See, the assistant will push the flap with the help of a small gauze piece, just like a banana, unripe banana.
So
You will
let's
get
say-
the pressure like unripe banana. Just peel it off
Muscular-
without damaging anything.
Musculoperiosteal flap.
This is the superior based musculoperiosteal flap, and also I have harvested the one anterior based flap to cover the flap. This is called the double breasting. This is not described in the textbooks. Now I am going to create some anterior flap while for suturing also. I am separating something here before elevating from the bone. This is the flap. After that, after seeing that, spend some time to delineate the mastoid tip section. Here I am teasing the fibers from the mastoid tip. After incision, I am not using the scalpel or the cautery. See that one? Just teasing, just like a small. I can describe here, anyone having the experience of in villages after delivering a small baby from the cow. Their nails like soft, we have to remove that with the fingers like that. The consistency also like this small. The mastoid tip not developed until the age of 2 years. That's be careful. After this, we have to elevate from the flap again anteriorly to expose the landmarks. This is the fovea mastoidea and also the antecanal wall. I will stop here. I don't elevate the canal wall anteriorly. Don't push them. Up to here, we can elevate. Then we can use how to place the instruments also. Till here, I have forgotten to explain the equipment. Show the equipment. These are the simpler equipments required to do the cochlear implantation, not more than mastoidectomy. Everything is required as a mastoidectomy. Very few instruments required. Those are provided by the companies during surgery. And also how to place the retractor. Just I am keeping a small gauze piece to prevent the pressure over the flap. I will take the 3 prongs mastoid, self-retaining hemostatic mastoid retractor to expose this area. See this.
Sir, can you do
Previously, you used
bit
to
of
use
white balancing, sir?
white balance. Not clear? Raj garu?
Very clear, sir.
Okay,
very clear.
now
Just
I have applied the 3 prongs mastoid retractor, and also I will apply a 2 prongs supero inferiorly. Antero posteriorly 3 prongs, supero inferiorly 2 prongs. These are the equipment is required for exposure of the part. Anything in ENT surgery, the exposure is the only important aspect. The surgical steps are very easier. How to get the part exposed? Here also to expose the round window is the mainstay of surgery. Up to this mark clear, I have exposed everything here clear. No neuroclips, no suturing, nothing. Just 2 retractors I have used. And also till that I didn't use the cautery. Remember that. The infiltration, if you do the infiltration in such a way, you won't get any bleeding.
To purposefully avoiding cautery?
Yes, sir. Yes, sir. Purposely fully avoiding. Why? Because
Okay.
nowadays I am seeing so many flap issues with the juniors and all. Inadvertently using the cautery causes the most dermal damage, healing issues, and also infections. Burbit.
Okay, okay.
After this, the technique of drilling. Now, my technique of drilling is
Tell me the secret to avoid cautery. You mean infiltration?
infiltration is the
time?
only key role, sir. Where we have to infiltrate, I will show and explain also. Now also I will explain something.
Okay.
We have to infiltrate the
Next-
extrinsic
For
postural
next case,
fascia.
you show the infiltration
I
signal.
will see. I will explain. We have to infiltrate above the periosteum, not the under the periosteum.
Okay.
Most of the times we hit the bone, we will infiltrate. We shouldn't hit the bone. We have to infiltrate above the periasteum. Then only the vascular supply lies in the
Uh-huh.
extrinsic posterolateral fascia. There is a mastoid fascia, superficial tibial fascia, deep fascia, tibial fascia, inoperative fascia. Like that, there are 5 fascias are described. The anatomical structures, arterial anastomosis lies in between this. That's why if you infiltrate in such a way, you don't get any bleeding. Now, after coming that, here also, this is my special technique. I always starts from the tip of the mastoid. This is fully aerated mastoid. I will tease the fibers from the mastoid. Previously, what I did with the periasteal elevator, now also, my aim here is to identify the small tip cell. If you find the tip cell easily, the surgery will go on very easily. See, I have entered in the mastoid cavity. Are all of you able to appreciate it?
Yeah.
Usually what the textbooks are saying, we will start from the attack of triangle, the McEwen's triangle, one line parallel to the external artery canal and also one horizontal line, one tangential line. We have to start here. Here also good, but sometimes the antral position may vary. Here, the tip of the mastoid, most of the anteriorly the tip of the mastoid formed by the squamous part of the temporal bone. There are no structures present here. If you study the CT scan carefully, we can able to know the structures what are there here. The entire part of this bone formed by the squamous part of the temporal bone. No vital structures present in this area. The important structures all are present in the petrous part of the temporal bone. The temporal bone formed by the 4 bones, not 5 for PGs. Squamous, petrous, tympanic, and styloid. Here I am drilling over the squamous part of the temporal bone. I am hugging to the curvature of the canal wall, just like a banana shape. I am going blindly, hugging the canal wall antero-superiorly. The burr is sharp burr. We are using the routine burrs, not special burrs. Previously, in starting days, I used to get the special from some America.
Hello. Hello. Hello, Raidu garu.
Okay.
Sorry, you told regarding the opening of the mastoid, you start at the tip. So you all go with the prayer city imaging. So if you don't have, in case of an anterior place sigmoid, where will you open the mastoid then?
And that's why I clearly mentioned that we have to study the CT scan properly before doing this. If you present in the anterior based sigmoid sinus or lateral based sigmoid sinus, we have to change the procedure also, not only drilling.
Yeah.
Sometimes you have to think about the
In case of
think
anterior
about
place
the
sigmoid, how will you proceed?
supramastoid approach or the varia technique. Now I am just hugging the canal wall. Do you know what? Just I am changing to the short burr. See this one. I am hugging the canal wall. Just I am going antero-superiorly following the canal wall. If you follow like this, in the meanwhile I am going some posteriorly also, you will easily access the antral air cell. No structures coming in between this area except the laterally placed sigmoid sinus. We already known from the scan, it was not there. That's why I'm going blindly, confidently, antero-superiorly. And also one more point, previous days and also most of the places they use it to explore the mastoid is very wide. This is physiologically functioning mastoid, so no need to explore each and everything, no need to follow the each and every cell. After getting this point, I'm removing this 2 prongs retractor also, prevent my way. Just only the retractor, 3 prongs. Here already I'm having the glimpse of the antrum. After reaching this, and also you come medial to lateral, not lateral to medial. And also following the same principle, hugging the canal wall. Here you can see my burr coming from medial to lateral. This is the antrum. I'm going for the higher magnifications, further higher. See, are you clear up to this point?
Yes, sir.
Pick. Now I'll explain the anatomy here. This part of the bone, total bone is the squamous part. This is the tegmen mastoidea, tegmen tympani there. Here, this is the this bone is called the scutum. The medial aspect of the external artery canal as the lateral boundary of the hiatus antrum is called the tegmen. Here you can see the first landmark. What is this is?
Dome.
This is the dome, lateral semicircular canal. The dome of the lateral semicircular canal up to the digastric grids gives a rough idea of the facial nerve length. The mastoid part of the facial length mostly around the 15 mm. The tympanic is 11 mm. Here, the first landmark, after seeing the lateral semicircular canal, we have to go for the second landmark. And also, most of the places I'm doing the juniors, I are drilling this one very smoothly. We shouldn't do it. This is the tegmen, separating from the middle cranial fossa to the mastoid. This is a very thick bone, very strongest bone. Here, middle is the junction between the, okay. Sorry, what's going on? Just I will explain, they will change the video. The plate of bone, tegmen mastoidea, or the tegmen tympani formed by the junction joint between the squamous part of the temporal bone, petrous part of the temporal bone. Majority of the bone formed by the petrous, which is the hard bone. That is the junction between these two called the tiguum. The tiguum is present. This is the bony projection. It is more useful to hold the electrode in a position. That's why we should not smoothen this surface. Always we have to keep this one like this. Then I am going to the second landmark to explore. This is a scutum. We have to drill here also from medial to lateral, and also the way to explore the posterior tympanotomy. To do the posterior tympanotomy through the mastoid. This size of mastoid is more than enough for me to complete syringe.
Sir, at what stage do you go to diamond burr?
Usually I'm not using diamond burr nowadays because of it causes more heat. In leading stages, in the early stages, because fear of damaging the facial nerve, we use it to use the diamond burr. It causes more problems.
What do you suggest to the new
It's
surgeon?
always slow and steady. See, I'm showing to show the dimensions of the mastoid now. See, that is 1.5 centimeters supero inferiorly, and also less than 1 centimeters anterior posteriorly. These are the dimensions. This small size of mastectomy is more than enough. Why? Because I will show, if time permits, I have done the case of explantation and reimplantation on my own case. If you limit the surgery of the small cavity, how the body reacting, how healing itself, and how the covering of the entire mastoid cavity during healing process. That's why we shouldn't make the wider cavities. Now I am changing the burr into a small size. Previously I used this one around 4 to 5 mm. Now I'm going for the 1.5 to 2 mm, not this one. This is 2 mm to explore the second landmark. Are you having any interruption in the video? Can I continue?
Yes, sir, it is good.
Can I continue?
Yes, sir. Go ahead.
Okay. Here the angle is some different. That's why I am drilling lateral half of the external artery canal to have the visual axis. Clearly I have mentioned the two important aspects are the visual axis and the trajectory. The visual axis, what we see here, the microscope will provide the three-dimensional view. Some of the surgeons are propagating the endoscopic ear surgeries. Those are also good, but the complementary. As an otologist, I always recommend to use the microscope only. Here we will get the binocular three-dimensional view. The third dimension was formed in the brain by the second eye, not by the instruments. The second eye, the second vision will provide the three dimension, that is the depth. Here I am drilling the scutum, just scutal part of the squamous part of the temporal bone to identify the second landmark is the incus. Just medial to lateral, just a strong bone. It always protects the incus. And at the same time, I am drilling medially to level. Now I am able to get the clear view of the body of incus. I will show the position. Now we can rotate the head. There are three movements. We can use the head to rotate. We don't have to have the sophisticated OT tables to tilt the head like this and that. We can use the patient heads only. Pick. Now we can see clearly. Rather clear up to this point?
Yes, sir.
This is the first landmark. This is the second landmark. This is the body of incus. This is the short fossa of incus.
Yes, sir.
This is called the fossa incudis or inguinal buttress. We have to make it. This is the line limits our dissection posteriorly to prevent the damage to the facial nerve. Usually in the textbooks, they usually says we have to always keep the facial nerve monitor to identify the facial nerve, and also most of the surgeons, in the Western surgeons, they will try to delineate the facial nerve entirely up to the stylomastoid foramina to find out the posterior tympanotomy. These are all, sometimes the anesthesia time is most important. This may takes more time. That's why I won't do that all. Simply, I'm exposing this issue also. And also one more, I'm here explaining the lateral inguinal triangle. This space is called the lateral inguinal triangle. See, the medially formed by the body of the incus and short process of the incus, laterally by the dome of the semicircular canal, and also superiorly tegment. This is the lateral inguinal triangle. Why I'm pointing this? If you have this much of inguinal triangle, here also the downwards, the triangle also same spaces, same dimensions, the more wider. Safely you can drill here. Roughly it gives the estimation of the size of the posterior tympanotomy. Posterior tympanotomy is the access to the middle ear through the mastoid. Here the boundaries. What are the boundaries? Postgraduates. Here also blindly we can drill hugging the canal wall to make a small space posteriorly without damaging the facial nerve. Always you have to look for any bleeding in this area. If you come across the bleeding, the means that is the we are entering the perineural areas. That's why. Just to delineate this one, then there are one cell is described that is called a Herald cell. Herald cell is nothing but a posterolateral outpouching of the facial recess. Here endoscopically they have described so many spaces based on the 3 eminences, 5 ridges and 4 spaces. I don't want to confuse to describe all these things. Just to see how simple to do the posterior tympanotomy. This is the line. This is the Rekha, Lakshmana Rekha used to sell by Masun Rao Garu. We should cross posteriorly to prevent the damage to the facial nerve. Here I am using a small cutting burr, not the diamond burr. Cutting burr.
The diamond burr which you are using now, I think it's about 4 mm.
Always I'm using only all the cutting burrs, not diamond burrs.
No. The burr, that's what I'm. What is
for
the size?
4. Now I
4
came to the
Now I think-
1.5. This is 1 to 1.5 mm
Mhm.
cutting burr. Here also gradually close to the external artery canal, and just like a gutter, small gutter, we have to find out the Herald cell. If you're able to find the Herald cell, it clearly gives the path to the middle ear easily. Now we can see this is the Herald cell. Pick.
Is sentinel cell and herald cell are both same?
No, sir. This is Herald cell. Most of the 44% of the people will have. The literature says that this is present here. This is the lateral extension of the facial recess.
Facial recess.
See, this is going like that. Water. Sorry, water.
The making of this gutter online.
If a fluid
from
movement
the
is
foci
present,
incudis, right?
if fluid movement is present, that means really we are going into the middle ear safely without harming anything. Just now I'm going more deepening also. Here you have to always careful here. Why? Because the second genu, the facial nerve transforms from the horizontal part to the posterior wall, medial wall to the posterior wall. Take the second turn anterior inferiorly around the lateral semicircular canal. Just like a gutter I am doing while observing the posterior part of my burr bit to prevent the damage to the facial nerve. Slowly here, millimeter by millimeter. There is no hurry to do anything here. Here that there are 2 structures. Already these are suffering with the hearing disability. We shouldn't create another disability for this patient. If you have any doubt, again, you can change into a small burr also to do this. Because of the confidence I'm doing with the 1.5 mm.
Sir, your assistant fills the external ear canal with betadine solution.
Yes, also build with a betadine. If betadine comes as a betadine sign, means we have injured the anterior canal, the posterior canal wall, bony canal wall, along with the skin.
So that that color betadine color helps.
Yes.
So
now for your demonstration sake, after that I am changing to a small burr to enter into the middle ear, small burr.
So I mean, so the external ear canal is filled with betadine before starting this procedure.
While draping also.
Yeah, while draping. So
Now,
any unintended injury to the posterior canal wall, the discoloration
I have
shows up
increased the magnification some more, 1.6.
and prevents us from going further.
Same size, Amma. See, there is a small bone separating the facial nerve. This is the facial nerve, pink color.
Sir,
Now I am going deep to this area to enter into the mesotympanum, millimeter by millimeter. After entering the mesotympanum, based on that, you can widen in a triangular fashion into the required dimensions.
sir, one small, sorry for the interruption.
Okay.
So in case if we
Fine.
unintentionally damage the posterior canal wall and see the skin, anything, do we stop there? What do we do to repair it, sir?
Canal wall, then we can repair it anyhow. The patient won't have the patient's child won't complain about the kidneys and all, because they are unable to do that also. That's why this is the entry into the middle ear. Pick.
So do you use any periosteum or
Yes,
anything
yes,
to cover it?
periosteum. So routine as adults we have doing that. That's one. Fluid, water. Now you can see we have delineated the mucosa also in the middle ear through the mastoid. You can see the movement of the water. Okay.
Yeah.
Now based on this, you can widen this one in a triangular fashion. Superiorly, the inguinal buttress, the vital area, and also anteriorly, superiorly by the chorda tympani, posterior-medially by the facial nerve. These are the landmarks for the posterior tympanotomy. Now see, I am able to see the round window directly, but for the demonstration's sake, first we have to identify the third landmark. The
I
first
think-
landmark is the lateral semicircular dome of the semicircle and body of incus and also short process of the incus. The third is the incudostapedial joint or the stapedius tendon. Here also you have to come from medial to lateral to create the incudal buttress. See, small bar.
You are at the 1.6 magnification?
Yes, sir.
Okay.
It's
Can you get it to 1.0? This is more comfortable.
Okay, sir.
Now, Raidu, when necessary, more go into this, you can go to 1.6.
No problem, sir.
Right.
Now I am seeing the stapedial joint also, IS joint and also stapedial tendon. You can see this. Without dislocating the joints and also without disturbing the anatomy of the ossicular chain, small section.
Suppose you are mentioning the injury to the incudostapedial joint, accidentally because of something, if you dislocate the incudostapedial joint, should we give any importance for that? Because sound is not getting transmitted to ossicular chain. Should we repair or we can
It
leave
comes
that?
under the, whenever you are going for the electroacoustic stimulation, that is called the hybrid implant.
Okay.
If you want to utilize the residual hearing, then only you have to take care of all those things.
Okay.
Anyhow, any anatomy we shouldn't disturb.
Yes.
That is my principle. And now you can see the IS joint pick. I will expose that one.
I think we are able to see nicely the stapedius tendon, pyramid,
Now,
incudostapedial
here,
joint.
these are two movements. I am seeing the superiorly, cranially. Now I am bringing the microscope towards caudally.
I think we are already able to see the round
Yes.
window.
That's why I told. Here you can small exposure of the facial nerve also. This we have to remove this one.
Facial nerve, Raidu?
This is the facial nerve, sir.
Uh-huh.
This is the facial nerve. Now we have to remove this bone at the fork, that is caudofacial angle. We have to drill from here also, from medial to lateral. I am attacking this bone in the V fork. Just water. And also one more thing, we are using the cold saline here while making in the posterior tympanotomy. We will use the saline kept in the refrigerator at normal 4 to 5 degrees centigrade to prevent the dermal injury to the facial nerve. Now I am able to see the round window niche properly. This is the pick. I am going for the higher magnification. Are you getting the clear picture, sir? Are you getting the clear picture?
Yeah.
Poimak.
Raidu,
Sir.
they are changing the new cable. Couple of minutes.
Okay.
There will be somebody you can we can hear your voice. No problem. You were mentioning about
I am keeping a adenal gel foam over the round window.
Okay.
To have the hemostasis. That's all. I'm not doing any more that. and also around mucosal incision. I will explain later.
Mm.
Adeline.
When the round window is very posteriorly placed and you are seeing the facial nerve already there, in such situations, still you need some exposure of the drilling. That is a very tricky situation.
Then we can use the anterior canal wall, the posterior canal wall. We can dislocate and push
Ah.
anteriorly to make the angle, sir. The visual axis, the main is the
Yes.
purpose is visual axis.
Visual axis.
We have to create the visual axis by pushing all those anteriorly, making the patient head towards our side. That after doing that, I'm packing with the gel foam to do the receiver well, to make the receiver well. After getting the video, just inform me, sir.
Raido, actually, once you drill and enter the middle ear, Raido is on in this year.
Pardon?
So Raido is a wonderful demonstration as
Sir,
well
sir,
as
sir.
you are keep on talking throughout your procedure. That's really good, actually. Able to hear me?
Yes, sir. Yes, I'm able to hear.
Yeah.
And also now we could have one point I want to stress. If you're getting the video, I will explain.
Yeah, we are getting the video. One question actually. So we're drilling and entering the middle ear. There is a lot of bone dust in the middle ear, as well as actually maybe sometimes actually all pediatric age group they have a middle ear infection. Do you wash with the antibiotic solution or any solution before enter into the down window, or
No.
just you?
We didn't practice till today, sir, because we are taking all the aseptic precautions. This is the sterile bone only, na? There is no infection. There is no glue.
What I'm asking, so all these kids actually have a allergic rhinitis as well as eustachian tube dysfunction. So they have some kind of infection in the middle ear.
Okay.
So anyway, we are doing impedance. Sometimes we open the posterior tympanotomy, we're able to find some glue inside. So do
Okay.
you wash with any antibiotic solution, or do you have any precaution before enter into the round window?
Okay, it has been taken good advice, but we not encountered that. We didn't follow.
So far.
That also better precaution. Nothing much better. Take the precautions are always better for the patient. We can do it also. Nothing
No,
harm.
Why actually, lot of case actually, so we prepare the case. Sometimes they used to post the case very late. At that times, we open the middle ear, we able to see a lot of edematous mucosa, as well as a lot of glue inside. So sometimes what I'm doing is sometimes used to pack with the.
Sir. Okay, always these are the point well taken, sir. I will also practice now onwards. Just take the antibiotic solution, prepare it, we'll wash. Monosef vial. What kind of antibiotic use, Anand? What can I use? Monosef, ceftriaxone?
Yeah, anything actually, just to wash with some diluted.
Ciplox drops
also.
are the only
Yeah.
injectable solutions.
No, some antibiotic ear drops. So we can.
You are
apply.
getting my external camera?
Yeah.
Are you getting?
Yeah.
Okay, now I'm showing the how to prepare the receiver well. Here also so many descriptions are there, pencil. Always to make positioning, measuring, scale. To keep a template, where to keep the template? That is the main question. Arun, are you there? Arun Kumar? Arun? No. Why? Because here the God has given everything. The landmarks are also given here. You can see the landmarks. Are you able to see the suture lines? Map. You can see the suture line. What the suture lines? This is the squamous part of the temporal bone. This is the mastoid part of the temporal bone. This is the parietal part of the temporal bone.
Ask the still camera, go very close.
Raidu?
Sir.
Yeah, the surgery is going extraordinarily well, but only thing is the video transmission is very bad. Can you stop the surgery for 1 minute?
Yes,
they can
okay,
change
we'll
the
stop.
cable.
They are doing alternative arrangements also.
Yeah.
Prior the surgery, we have trialed 3 times. We did the surgery also.
But the surgery is
But
going
because
very well.
what happened, I don't know. We did the surgeries also, some of the surgeries, trial surgeries. This time it's happened. Now it's clear. Excel camera clear or not?
But it's
It's
good.
clear,
Demonstrate, but the only thing is the key points were missing.
Which one is clear for you? I will focus on the microscope also. Which is clear to you? Tell me. I will.
Microscope
do
is
that.
better.
The microscope is
Okay.
better, I think.
Okay.
So external camera,
Yes, sir.
they have the light.
Okay, I'm going for the lower magnification. Go see the microscopic picture. Project the microscope. Please project the microscope. Are you getting the microscope picture?
Not at the video. The cable is.
Chinna bar,
I think so.
diamond bar. Till now, I didn't use any cautery, either monopolar, bipolar. I didn't use it. You have to appreciate that. And also, there is no bleeding at all. Here also, the bony bleeding. Just am I applying the burr. Okay, see that. Okay. Okay. Bipolar. Okay, are you getting the microscope picture?
Yeah, yeah.
Good.
Clear.
Are you getting?
Yeah.
That's why I'm waiting for your response, pencil. Here I'm explaining the landmarks now. See, the landmarks are we previously used to measure with the scale. Measure with the scale, and also the textbook says you have to keep 2.5 centimeters away from the mastoid edge. How to measure? Some of the surgeons will do this much bigger mastoid, some of the small mastoids. And also that's why I always follow the natural landmark. These are the suture lines. See, these are the zigzag suture lines. This is the projection of the parietal bone in between the squamous part and mastoid part of the temporal bone. This is always flat area.
Just right.
Always.
Try to wait. We didn't get any picture. They are changing, I think so.
Shauredi garu, please.
Now it's okay.
Okay. Are you getting the picture?
Yeah, yeah.
These are the landmarks already told now. This is a suture line.
But little illumination.
This is the U-shaped suture line. Always this bone is flat. Elevator.
Right.
Now I am elevating the periastium from that bone, just keeping the freeze elevator, just to tease like that. Don't just elevate and also push like this anterosuperiorly, small area. If you create a bigger pockets, it causes seroma or later on hematoma, it causes more problems. Now afterwards, after making these suture lines, we have to keep the template. We have to make the receiver L marking. See, this is the dummy silicon template.
Right. Just wait. We didn't get any signal. Yeah, now it's okay.
Okay.
Ah.
Just I kept that silicon template in the U-shaped. Already these are the suture lines, natural suture lines. Just mark with the pencil. The pencil is the good marker on the bone. No other markers will stay on it. Always I am practicing. This is a sterilized pencil. We will autoclave it. And also I am operating on the left side now. That's why I use the two retractors. The right side we can use the Kirtanes retractors, but here we cannot use that one. That's why I'm keeping two retractors to retract the skin to expose the part. Now also how simple to do the receiver well, I can show you. Small burr. Here I'm using a 1 mm burr. I use it to call a marker burr in cochlear implantation. Suction, bed the suction. If you follow, we shouldn't, our hand shouldn't move, always medial to the line what we have drawn. Are you getting by the tip of the burr?
Yeah.
Ravi garu?
Yeah.
Just vertical line medial to that one. We can make the small line as a big line, but we cannot make the smaller into big into smaller. That why it's always make a smaller cavities, smaller receiver well. If you require, you can make it easily very larger. See, movement of my burr and also my hand, and also always keep the hand in 3 positions support. Posterior superior marking I am doing. Whatever I draw on the bone, just adhering to the drawing, and also I'm doing this. This is called the marker. In olden days, where it goes to the fields where we have to make the water to the fields. That's why we have to make these ditches. Village atmosphere can teach so many things. If you make all these things, we can learn easily, we can do easily. Like that, we have to make the gutter. All around, I am making a gutter to do the receiver well. Because of the measurements not on the bone, it should be in the brain. After seeing the templates, from each and every time, we shouldn't keep that template to mark and see. We have to make a habit of what sizes it should be in the brain. See, metal template. I have made the implant template without measuring anything on based on the two drawings. See how exactly it fits. See. Okay.
Right.
After making this, and also we can change small dimensions. We can increase the size easily without bleeding also. Here I have to mention about the The child's skull is very thin. It has marrow content also. Tabula externa, media interna. Externa doesn't contain anything. Media doesn't contains the vascular part. That is the marrow content. Then we can use the burr bit. After making these island, we have to remove the bone easily. How easily I can see. We can go through any of the YouTube videos. Most of the surgeons takes more than 45 minutes to do this one. Here I am using a special burr. This is the dental burr, multifaceted dental burr, small burr. It can clearly remove this bone easily. Sometimes in the pediatric age group, this is also very small skin. We have to keep it like a island. We have to make the bony island. We can use this one, keep as a parallel.
Hello, Raidu, are you able to hear? Hello.
Okay. See, just like a butter, very soft bone. Within 1 minute, we can complete drilling of this one. After keeping a small thin layer over the dura, if required, we can make it an island. We have to keep a small thin 1 mm bone over the dura without injuring the vessels of the dura. Here also I am not doing any cautery. That is the point. Always I am pressing on that. The infiltration I will teach to you in the next and later on cases. Just I have completed the receiver well template. See how easily within 2 minutes we have completed everything. Here are the bleeding from the margins, not from the dura. Also, you can see the dural vessels template. This is enough to make this one. We have to make it a snugly fitting. Why? Because nowadays I'm not at all using any kind of stay sutures or stay things to secure the implant. The nature will take care of providing a thick connective tissue covering all. Hello?
Yeah.
You're
able to-
getting?
Yeah.
Just I have delineated the area, and also now I am attacking on the borders, angles where we are getting the bleeding. Here we shouldn't have the bony ulcers, like a tuberculous ulcers. We should have the 90-degree angles. To prevent the slippage of the implant outside, we have always make these walls 90-degree. At least 2 borders should be prevent movement of the implant. Thin size bar. Hello? Hello?
Yeah, we are able
Yeah,
to
able
hear.
to get.
Now I am making the walls into 90-degree angles, not the punched out ulcers. These are sharp borders. That's why I'm using a diamond burr here to have these borders 90-degree angles to prevent the slippage of the implant outside. Sometimes you touch the dura also, don't worry. Sometimes we will make a bony island also. That's why here I am separating the dura, keeping your suction over the dura. You can have the space to drill the margins. And also here also, always see my support of my fingers, my little finger and also the ring finger are supporting the skull, and I'm keeping this one. And also always you shouldn't do like this. Always these fingers should be like this to see what drilling we are. Now I am making the margins easily. It will complete the preparation of the bony well template. See the exact size of the bony well. See, are you able to see that, Ravi Garu?
Yes, yes.
Then here what happens nowadays, we are getting the central array electrodes. Now this is the older ones of the metal. It gives electrode comes from the lateral margin. These the clear cut demarcation stores. The electrode starts from here. We have to make the canal for the electrode pencil. This is the anti-recurrent track చేసుకో. See, from the margin of the receiver well, we have to make a canal for the electrode. Previously, they used to mark just like this.
Reduce your magnification so that we can appreciate.
Reduce the magnification.
Lower magnification only, sir.
Yeah, yeah, and now it's okay.
Okay, now clear?
Yeah.
Just from here, whatever the burr I have used now, just I will make a gutter to the electrode canal. Previously, they used it like a draw, they used to keep like that. That always it is better to make 1.5 to 2 mm gutter for the electrode. If I am doing, see my fingers, how taking the rest on the bone, just like a line, just draw like a pencil. This also instrument also apply the same pressure, not the much pressure. Either smaller pressure you can use, it come easily without damaging, without jumping here and there. Your fingers and also your hands are always steady, stabilized. You should move here and there. If you attacking one point of bone, just drill there only. Apply needed some small pressure to have the required depth. See, total my burr is submerging into the canal. It always gives well protection to the electrode array. Why? Because the children are used to play, the sharp objects hit the head, and also the round objects like cricket ball may hit, it damage the electrode. That's why it has to be protected all the ways by the bone. That's why it should have the enough coverage. I am making with the 1.5 to 2 mm burr bit, diamond burr bit. For your understanding, I am not changing the burr bit. I am going. Always my practice is here to take this electrode array into the cavity like protected by a bony bridge. I am making a bony bridge here. See, I am removing the gel foam what I have kept after making it. Just parallel to the bone, just go into it, keeping a small bone outside. You will enter into the mastoid cavity easily. See, my burr entered into the mastoid cavity. All of you appreciate?
Yeah, it's good.
Just here and there, this type of movements will give that one. If you have the more visualization, you can make smaller opening like this. You can clear cut path for the electrode array. This is the 45-degree angle is going into the mastoid cavity. You have to smoothen all the borders all around. This completes the 95% of the surgery. Now I will keep this template, silicon template within the receiver well to have the skin folds accommodate it, and also to measure the to covering of the implants. Previously, I'm applying this towel clip, this one. We have to cover by 3 layers. Skin, 1, 2. I will show all the layers. After this, we have to make the small covering release of the musculoperiosteal flap to cover the implant. See this one. The borders also snugly hugging. There is no movement for the implant, and also electrode array coming like this. There is no need of fixation. In olden days, my starting days, we used it to fix so many ways. Periosteum to the bone, bone to bone, different kind of materials. While doing the burr holes on the bone, we are hitting the dura and also causing CSF atoria or CSF leaks like that. We have faced so many complications. That's why now today I am not talking about the complications, just simply to develop the confidence to do the surgery, to come into the otological implantology for the juniors and all other senior colleagues also. Now, because of the incision, we have to go posteriorly. I gone anteriorly. Just I'm making small another coverage while to prevent tension while suturing it. That's why, see, without damaging the skin also, we shouldn't make any buttonhole on the skin also. That's why just I'm elevating simply another layer to covers without tension. While after suturing this one, with it pike lagama, with it pike this. This is called the cat's paw. Cat's paw, the skin will retracts posteriorly. I'm doing anterior retraction. I'm elevating small thing to cover entire implant. See, now we can pull this one. You can see without having tension, we can suture easily. Okay,
Yes.
is appreciable?
Yeah, yeah.
Oh, okay, now it's over. Now everything over. Now we come to the interest point of area. That is the round window. Already I have seen the round window. I have explored. I have kept the adrenaline soaked gel foam all around the round window niche area. Here that is called the niche area. What we are seeing while drilling the posterior tympanotomy, I have forgotten to enlighten some of the points. We are going through a narrow passage to the middle ear. Narrow passage. That's why small section. We are going through the narrow passage. While seeing a door keyhole into the room, what will you see directly? You can see the opposite wall. While making this posterior tympanotomy, angulation is the key point to visualize the round window. That is called the visual axis. Then we have to create the trajectory. The electrode has to go easily. Now I am using the metal standard electrode, means that is the longest electrode available in the market now. We have developed 33 also, not available in India. This is 31.5. Just now what we are seeing, that is the promontory. Okay. Pick. Here I can explore again the landmarks I will explain.
No, here you increase the
This is
magnitude.
the dome of the lateral semicircular canal, body of incus, fossa incudus, buttress incula, and also IS joint, stapedius tendon. Now what we are seeing, only the promontory.
Roy to focus is not clear.
Yes, I will focus. And also now, then we have to make a small movement of the head, the kid towards you. Now, retractor. Okay, awesome. We didn't have any retractors also on the skin, just the whole area. Now we can see the area, that is the round window niche. If you not able to see properly, that is not the round window, that is the subcochlear canal, inferior hypotympanic cell. It leads to the petrous apex.
Right, it needs more magnification there.
Sir?
It needs more magnification.
Yes,
there.
I'm increasing the magnification.
But I don't know why the color is a little bit darker over the screen.
Screen darker.
Yeah.
Here we are getting very good now, sir. In our my operation theater also I'm getting the same.
It's clear.
This is the hypotympanic cell. We shouldn't confuse with it. I will drill some of the bone in the cardofacial angle.
The depth perception magnification పెరిగే కొద్ది అలా వస్తుందా అట్లా లేదా
Clarity is not good for you, sir.
We are able to see it, but the color is a little bit difficult to appreciate. Yeah, now it is. Yeah.
Sharadi garu చూడండి ఒకసారి. Is it tendon? No, down. చూడండి ఇది కలర్ మార్పు వస్తుందంట చిన్న బర్ బిట్. See this, we cannot fit the 2 mm burr also into the my posterior tympanotomy. This is a smaller one, that is enough for me to introduce the electrode. 1 mm.
Does it need more widening of that posterior tympanotomy inferiorly?
Pardon?
The posterior tympanotomy what you made, it requires a still further dissection
Diamond.
lower down.
No. Here this point, you want to drill this one?
Yeah, that.
Yes, we can also do, but this is okay for me. Water without damaging the carda tympani or the facial nerve, we can drill it. Now we can clearly see the hypotympanum. That is the hypotympanic cell only. I will delineate the round window after drilling the superior bony overhang and on the inferior anterior lips. It is covered by the bony overhangs. Inferiorly bony lip. Now I am doing the delineating the round window by drilling the posterior superior part of the poyeddu decadron తీసుకోండి ఏం పోయి మాకండి. Now I have to reduce the speed of the burr. I am going for another magnification 1.6. Are you able to see the round window niche, Ravi garu?
Yeah, we are seeing that, but the technicians are arranging the color of the walls.
Okay, now just without touching the burr, the facial nerve, we have to drill this area. Here also medial to lateral. One. Drill, suck, drill. Chinna suction. That is the principle here. Drill and also suck the bony dust, and also again started drilling. Here the irrigation is doing with the decadron. Drill and suck medial to lateral to delineate the round window totally. Your movement should be perfect. You shouldn't have any tremor on your. Here, what we are seeing the facial nerve popping out. Now you can see the color is a dark gray color of the tympanic membrane. Most of the times it also covered by the mucous membrane that is whitish color. That is the middle ear mucosa also covers this niche. The whitish color here is not there. Picky ఏమన్నాకు ఓకే సార్ ఓకే పోయొద్దు 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 ఇప్పుడు పోయొద్దు. Now I am doing posterior margin of the niche. Now I am able to see that grayish color. I will reduce some magnification. If required, you can push this anterior canal wall and elevative. If obturing the visual axis, we can push this one easily anteriorly. Okay, just you can push it anteriorly. Now we can see this one clearly, the round window niche area. Now I'm drilling the post. Always textbooks discuss about the antero-inferior, antero-inferior, antero-inferior. Antero-inferior is to enter into the scala tympani. But to get the round window in a proper view, you have to drill the superior and posterior superior part of the bony overhangs. Then only you're able to visualize the total round window, 360-degree round window. The round window.
Can you make a camera very fine focus? Still microscope. Still it needs a little magnification and fine focus.
This is fine focus, sir. Okay.
Yeah.
Now you can see the blue color.
Yeah.
Pick ఇవ్వండమ్మా కొంచెం కరుడు pick.
I think you might have drilled that the lip which covers the secondary tympanic membrane. That means round window membrane.
No,
Am I right?
no, I didn't open that, sir. That is the facial nerve. That's why I'm apprehension to do that one. Just I am surrounding bony niche. I am doing this. Okay, but go. Are you able to see the blue color, small blue color area? Dark gray or blue. You can see that one. Now more visualized part. చొక్క. ఏమొద్దు అయిపోయింది ఏమొద్దు. ఇక్కమ్మ కరుడు. I am taking some time to demarcate the round window.
Little bit
Right,
blurred,
Jacob?
little bit blurred there.
Ro-
Requires more magnification, fine focus. The magnification okay, and make a fine focus there.
Okay.
The-
Okay, sir.
But little
Yes.
blur, okay, but still needs a fine focusing. కొంచెం ఫోకస్ చేయండి అంతా బాగానే ఉంది ఫోకస్ లైట్ గా ఆ ఏరియాలోనే
Okay, sir. This is the higher magnification.
Raidu, there is small adjustment in the camera lens actually. You can do it.
Camera, this is internal camera, sir. Microscope
No,
camera.
no, microscope, that's a lens cover is there, no? So you can, suppose you are using lens cover, you can adjust.
No,
the
sir,
lens.
I am not using any lens cover.
Okay.
This is the only layer of.
No, what is the advantage of using lens cover?
No. They have a lens cover. So
Now I have given incision over the See, you can see the round window niche.
Now we are able to.
Yes, that is
Yeah.
enough. Decadron. We'll make that one later. Then now we'll wash the entire area.
Now, Raidu, it needs a much fine focus.
Okay. Now we have already flapped the tympano entire area, and also I'm elevating taking some of the soft tissue to cover the round wind fixation electrode knife. I'm taking the soft, small tissues.
What you are going to do now?
I'm taking the soft tissue cover, sir,
Okay. What for?
to fix the electrode in the round window. After opening that, we have to seal the round window. Na? ఇక్కడ పెట్టుకోమా. Usually the periosteum is the ideal one. Sometimes we not got the periosteum properly, total proper periosteum. Some of the muscle, some of the fibers I am taking. This is the periosteum. ఇక్కడ ఎన్నికలాగమ్మా ఇక్కడ ఎన్నికలాగి పట్టుకో. Retract.
I do this periosteum for round window cover, correct?
Yes, yes, yes.
Oh, so do you make an incision in the round window membrane? Is itself enough? No, do you cover with the periosteum or any muscle?
Muscle also I can use some part of the muscle. Preferably periosteum is the better one.
Better, okay.
That's why just I don't incise also. Just I will
What's
separate from the process cochleariformis. That is the crista fenestra. Crista fenestra. I will separate the membrane from crista fenestra. I will show you. Okay, that soft is enough. We'll wash it. External camera. Are you able to see the external camera?
Yeah.
Wash. Fine light. I'm taking out this implant template and also thorough wash to clear the all bone dust. What Radhu sir mentioned about all the things to prevent infections, further infections. We have to thoroughly wash each and every bone particle. And also we are using the
external camera. Why don't you focus on the microscope camera only?
Okay.
Yeah, that's good.
And also we are using the antibiotic solution also to infiltrate to wash area. The antibiotic advised by the Raju. Now we are using the antibiotic solution also to make irrigate. Then we have to change the gloves. All the assistants, including the surgeon, has to change the gloves before taking the implant.
Raidu, audience are asking what type of antibiotic you are using, gentamicin or?
Now I don't use gentamicin. Here only ceftriaxone solution. What we are using the IV.
No gentamicin in
Okay.
this thing.
Not
Yes,
gentamicin. Are the Ciplax drops also enough? Ciplax
that's enough.
drops. Now, before going to the implant, we have to secure the bleeding. Everyone, all of you noticed that I didn't use the cautery till now.
Right.
Okay, no cautery. That's why. And also you have to secure the bleeding points, and also you have to wash and clear the bony dust, and you have to change the gloves. Entire
No,
team.
Raidu, before you are putting the implant, now there is no chance of dermal injury unless you think that it damages the facial nerve. What is the idea not using the electrocautery here?
No.
Electrocautery to prevent the flaps viable. The pediatric small age group children, we are producing 400 degrees for monopolar, more than 250 for bipolar cautery, degree centigrade.
Okay.
To devitalize the tissues and also vascularity. That's why the main aim.
Right.
Only the infiltration will take care of the bleeding. The main intention is to prevent the hypovolemia, volemic changes. Even the 10% of the blood loss also, children will have so many problems because they contain the less volume.
Okay.
These are the precautions to be taken in pediatric age group, the anesthesia, hypovolemia, hypothermia. These plays the major role
Right.
for the successful surgery.
Right.
After changing the gloves, we have to take the implant. See external camera.
Oh.
We have to transfer the implant into the table in a major way. Entire surgery depends upon the asepsis. We have to take care of the septic precautions always.
Right.
That's why you have to take the implant on the table, having that one, and also lock with the artery forceps. Lock. It won't fall down. If
Okay.
fall down also on the table only, not outside. We have to, the assistant has to open the outer foil. We have to take with the artery forceps, keep on the table.
Right.
On the table only, we have to see again the second cover, peel off it. After that, the metal implant, each company differs to take out also. If you take this one, you have to make it upside down, just a tap on it.
Okay.
It will releases from the lower part, then it goes out. And also don't touch the implant directly afterward also. After taking the outer, the second protective layer, take the saline to submerge the total implant with the saline. Why? Because these are the electrodes packed and transferred so many ways, and it has developed the static electricity.
Okay.
These are the delicate electrodes. We have to discharge the current from the implant before putting into the placement. That's why we have to keep that. And also the design, also the tray of the design, see the design. It was kept like this. There is a place here. Transfer of the implant from the table to the body also important issues. These should be learned. There we have to use our ring finger and also the middle finger to hold the implant, and also the ring finger and the little finger to secure the electrode length. See how I have taken into my hand. Are you able to see it?
Yeah, yeah.
Then you have to transfer gradually without taking the cover of the electrode. Then you have to place over the bone. Here, over the bone. Before that, we have to take the, for the documentation sake, we have to take this serial number. See, we have to document now. That's why this is a serial number. Medal Sonata TI 36154 serial number implant. Are you able to see?
Yeah.
This is the receiver. This is a coil. This is a receiver stimulator. These are electrode area. This is laterally projecting electrode. After that, already I have made a small towel clip to the flap. We can elevate the flap. Just gently push this implant. It has to go below the flap, periaceum only.
Okay.
See, huh?
Right.
After keeping this one, then only I will take out the protective sheath also. Before that, I have to make some work here. Retraction. Small section. Small section. I have to open, until this point, I don't open the round window membrane. I won't tear or open the round window membrane. You can just retraction. What? Assistant will retract. The small, always we have to use the small suction cannulas. Keep it ready. We shouldn't suck directly to the, with the lower magnification only I am doing now. Are you able to get the round window niche area? I have sucked it one. Now I will take the pick, straight pick, to detach the membrane from the margin, anterior-inferior margin of the round window niche. Sometimes the medial attachment of this membrane called the crista semilunaris, that is a small crescent-like bone. Just I am giving a small incision. At the same time, circular movement, I am smoothing the surface of the scala tympani, most lateral aspect of the scala tympani.
Textbooks describe the opening should be in antero-inferior manner to access the scala tympani.
Yes.
Yeah.
This is the
Oh,
crista semilunaris.
right.
Just I have made an opening. You can see the perilymph is coming out.
Not
For the
appreciated.
demonstration purpose, and the small opening was made.
Yeah. Bit
Just,
pulsating.
okay.
More focusing is needed. Fine focus we can appreciate. But still,
This is
we
the
are
fine focus.
appreciating the perilymph.
I am seeing on the screen only, sir. Here I am getting this clear screen on the screen. Here, for the juniors to have the doubt of inserting the electrode, that's why I am making the marginal widening of the cochlea. For that, I use special burr provided by the metal company. That is the conical burr. Just I will widen the margin antero-inferiorly. This is also called the marginal cochleostomy. See, with the right hand going directly, and also this is also called the trajectory. Just minimal speed drilling. Just I am making antero-inferiorly from inside out.
Trajectory.
to have the safe entry of the electrode. Why? Because most of the times I don't use any kind of instruments to insert the electrode. Always with the bare hands, with the hand pressure only, it has to go inside. That is my intention of doing surgery. See how I am making antero-inferior marginal drilling.
Dr. Raidu,
Ah,
sir, a very crucial step. If you don't mind just pulling up the microscope up and down just to see if there is any fine focus for the
just a
audience to
minute,
see.
just a minute. I will push this one anteriorly, then you will get the good view. Okay.
Any other fine
Now you can
focus,
see
sir?
that one anterior round window niche.
Sir, better, much better.
Okay. Now I am drilling. Srinivas ఎక్కువ లాగద్దు.
So there is a question from Professor Ravi Garu.
Now I am drilling small antero-inferiorly. I didn't enter into the scala also. Now I have entered.
Raidu can use a skeeter here.
Yes, skeeter is always the better one.
Ah,
But here what I want to make an impression of, everybody can do the surgery. I don't want to go to the higher equipment, higher terminology, higher words here.
yeah.
Skeeter, angle drills, angle ones, the ordinary microscope, ordinary drills, ordinary burr, and also the special burr anyhow given by the company. I am using this only, not newer things. Because you should do in your government setup. Government setup now are strengthening. I did in Kakinada also, where also with a small basic microscope. Geez, we have to able to do. That is my main
Right.
aim is like that only. Typical.
Raidu, superhuman like you is possible.
No, no, sir. Just I have made a small opening and also making wider with the pick. And also smoothing the edges to prevent the damage to the silicon coat of the electrode. See, already made. I also make the small antero, the superior trajectory. Here the overhang preventing this one. Record run. Now my work is complete. See, pick, curved pick. See the opening, perilymph is coming out. Previously used it to, I will just I am removing some more bone antero-inferiorly with the help of the pick only. Some of the surgeons also doing with the stapedius micro burrs, hand-held burrs. But it also causes damage here. Here, so many structures are there to discuss so many hook area, basilar membrane, spiral lamina, spiral ligament, so many blah, blah, blah. That I don't want to mention all those things. Just see how I made it. I made a small opening antero-inferiorly and how I will insert the electrode. Now only I am taking out the protective sheath from the electrode. I am holding with my hand. First pass under the bridge. Why the use of the bridge I can explain now. This bridge prevents the spring out coiling effect of the electrode coming out. It holds like another hand. It holds like another instrument or hand. I am slightly passing on. Sorry, if what it touches also, it changes its directionality. That's why I will go into the smaller micro magnification. Always insert with the smaller magnification.
Any questions from the
6.4.
audience?
Smaller magnification, it's going to see. I'm Lagamma.
Sir, everybody is appreciating
See.
your nice demonstration.
See what I'm seeing. I don't have anything. I kept in my between my thumb and also the index finger. You can see the niche and also opening of the round window. Just I am guiding it into the suction cannula or the kala. You can use the kala instead of that one. I have entered into that area. Just I will wait here for your understanding. I will remove my hand also. It stays there only. See, I have taken out my two hands, the electrode, the cannula, and also the positioning of the electrode. Now I am going for the higher magnification.
Yeah.
See that now I will take this kala. I can do with my bare hand also for your sake of understanding. This is the special equipment called kala. With this kala, we can push into the Scala tympani, millimeter by millimeter, millimeter by. Here you can take, you can chart to discuss the ba is no more. The Egyptian surgeon used to describe, if you push the electrode in a single push, it creates the pressure like tsunami. All of you know about the tsunami, how much it pressure creates. That much pressure created in the scala tympani, it damages so many things. These are all the tensile structures that what is the membranes, basilar membrane, and also the over the rhesus membrane. These are all the mobile structures are the very delicate. That's why you shouldn't push the electrode in a single go. It is better to have millimeter by millimeter, at least 2 minutes. I don't encountering any kind of pressure. The claw is easily going, and also see this is the round of the projection of the silicon is called the marker. Up to this area we have to enter. Then only it covers the entire length of the cochlea, that is 31 mm. Now just another more 2 millimeters. Then also otherwise you can chit chat or count the numbers up to 120, 120. Just another few millimeters, another few millimeters, another few millimeters, another few minutes, like that it has to go. While going inside, it will egress the perilymph outside. It provides the space, and also if going deeper and deeper, and after first and second turn, the scala tympani dimension will decrease. That's why the laster part of the electrode is 5 mm, outer part is the 8 mm. Okay, the base 0.8, not 8, 0.8 and 0.5 mm. Other implants are the sum of the 0.5 or 0.3 mm at the tipper area, this apical area. That's why I'm pushing millimeter by millimeter, millimeter by millimeter. There is no pressure at all, just with the small claw pressure, and also sometimes I'm guiding with my suction cannula. It's going inside, nearly reaching the total active electrodes are inside only by this time. Just the outer part is there. Here I'm encountering small pressure. That's why then you have to pull back and also rotate the electrode. Why? What happens? These are all lateral wall electrodes. While touching the lateral wall, it takes the turns. After going to the basal turn, it has to come to the second turn to the apical turn. Where it hits the lateral wall, it won't go. Then you have to pull the electrode out and rotate. How to rotate? See, this is the claw. Now it's going in this direction. Now I have to rotate like this. The tip take the other direction, then it easily goes inside. I have rotated here, and also I'm again pushing, it's going easily. Now it's already reached there, snugly fitting the round window niche without any perilymph leak. Are you able to appreciate?
Yeah, it's very good. Are there any marks
That is-
externally, Raidu?
This is the marker. See the sir, here we can. I will go for the another magnification. See here the round
It is
knob like projection.
Out of use,
Can you,
sir.
the
Can you send
microscope
the-
is little bit out of
Can you send
coverage there.
it?
Yeah, yeah.
1 minute.
Yeah.
I will pull out also. I will show you next otherwise. This is the marker.
Yes, sir.
Up to the round marker, ugly gone inside. That is the over. This is the electrode insertion. Without any much difficulty, we are able to do this. It was fixed there. There is no perilymph also.
Yeah.
Now, secondly, how to place these electrodes? The extra length of electrode we have to place in the mastoid epitympanum only. Why in the epitympanic area or posttympanum? Why? Because these are the chales. The mastoid tip will grow.
So,
The-
sir, what is the forceps you are using?
These are called the jewel forceps or watchmaker's forceps or AOI forceps. This is also called my technique. This is called the double jewel forceps. I will hold this part of the end with one forceps, another part and another forceps, and also simply pushing medial to the body of the incus. This is the correct position to place to prevent the movement and mobility. Just I will push into it. See, it's
Yes.
gone inside already. I have explained the tegmen mastoidea, tegmen tympani here. Why I have not drilled there to prevent the smoothing, I will explain now. See, if you keep this bony projections, it holds the electrode in a proper way without mobilization. If you keep this loop in the tip area, the mastoid tip will grow. It pulls the electrode also out from the scala tympani. That's why always this extra length of the electrode we have to keep in the tympanum, epitympanum or posterior epitympanum. After keeping this one, I will secure with the surgical piece, just like a cementing. It holds like this, it won't move at all. I'm keeping a small surgical piece over here. It has to be done all to be done after the testing, because I know 100% anatomically I have placed the electrode there. Now we have to check the neural functionality. Neural functionality means excitability of the artery nerve first time after the childbirth. For that, I'm taking out this one. I'm making the area to keep the stimulator over the receiver stimulator. Ready. External camera to the Narendra laptop. I kept over here, and also I will show focus on the just retract Rama. Just all of you observe. I focused on the stapedius tendon. Without having the ESRT also, sometimes the stapedius muscle will contract. 1 minute.
So do you do impedance to start with before checking?
Usually we are not doing impedance will start during impedance also you will get stimulation now. That's why the stapedius muscle will move. You can see I have exposed the stapedius muscle. All of you able to see the muscle
Can you
tendon.
can you make it larger, sir? The image.
Pick. This is the stapedius tendon. I have focused this the white point.
Yeah, yes.
See that.
Okay.
Okay. Start Narendra. Narendra is going to stimulate that one. He's doing the impedance. Okay. I will little adjust the. Okay.
Yes, sir.
Middle electrodes are showing high. You can see that one. That also settle down after a while closer also. He will do again. Now after impedance, he is going to check the excitability of the each and every electrode. Okay. See, you are getting the our external camera of the impedance testing.
Yeah, we are appreciating, but
Two screens, please. Two screens, Sakada.
Yeah, it is.
simultaneously we are seeing, but little magnification is it for the external camera to see that.
How much?
Yeah. Now
You can see the basal and apical electrodes are very good in normal impedances. Middle electrodes are some little bit high. They will settle down after closure also. Now you can, ESRT, yes, do one ESRT with the base electrode. Now all of you concentrate over the stapedius tendon.
Sir, stapedius tendon needs to be shown, sir. We're not seeing it yet.
Okay.
yeah.
We're not seeing the stapedius tendon.
White tendon is stapedius tendon.
Yeah, yeah.
Okay. See, all of you concentrate this area. Yes, there is a movement.
It has to be magnified, sir.
Magnified is a very, very clear.
small
1 minute, 1 minute. Okay, now okay.
Yeah, better.
Okay. Yes. Are you able to see that?
Yes, sir.
Good.
Clearly, we can demonstrate it again. Indra. See, all of you concentrate on that.
Not yet, sir.
Okay.
So
Yes. All are good.
So how many electrodes are there in this implant?
12 electrodes. 12 paired electrodes means 24.
Okay.
Okay. Yes, middle electrodes also got the movement. It gives what will get the information of ESRT? Yes, very nicely you can see that. Okay, now I've started closing of the area, but I didn't enumerated the surgical steps. Surgical steps are the skin incision, musculoperiosteal flap, receiver well, mastoid, fixing the electrode, neural telemetry or electrode response test, and also the fixing the electrode.
Right, sir.
Sir.
Right, sir. Actually, your electrodes are touching the facial now. So you
Electrodes are touching the?
facial now bulge.
Yes. I will adjust.
Yeah. You have to keep a little bit muscular.
I will adjust all the yes. The good point, good suggestion. I will always cover everything with this tissue.
Yeah.
Tissue. Okay. And also one more thing I'm going to show. This one is the initially I will push this gel foam all around. Why? Because to prevent the slippage of the tissues. Yes, see the telemetry, how the impedance are very nice.
Nice.
Everything settled down, everything are good. I will push this gel form into the hypotympanum, mesotympanum, epitympanum. What is the use I will show now. Now after that, I will push this tissue all around 360 degrees. I will fix the electrode. We have to fix all around 360 degree, not one area. Periaceum, preferably periaceum all around, and also the superior, anterior, medial, posterior. All the areas I have secured the electrode. Now I am using small gel. First layer is used. I have used the gel foam. Second layer is the tissue and periaceum. Inkoti. Tissue and periaceum. The third layer is the Surgicel. Surgicel. Now I am using a Surgicel as a third layer to prevent perilymph leak. This also all around. Nanda sir phone చేసి రమ్మనండి.
So do you keep some soft tissue on the exposed facial also?
I will cover the soft tissue with the soft tissue exposed facial nerve. I don't want to see the facial nerve, but it appears sometimes. Even meticulously we drill also. Okay, soft tissue. Now I'm sealing we have made the unnatural opening in the posterior tympanotomy. I usually use it to close everything. Tissue na చేతికి వస్తుంది. Now I can keep this tissue over the facial nerve loosely, not regularly. Then Surgicel. Phone చేయి. అలాగే సాయి గారికి కూడా. Surgicel. Here also I place some Surgicel to prevent falling of these tissues away. Surgicel has two properties. One, it has fixes the tissues in place and also prevents bleeding, hemostasis function. Now we'll come to the
Raidu,
sir.
is Surgicel mandatory or essential?
Not mandatory or essential, sir, but I have the better results, and also that's why I'm keep on practicing. Just what the Vijayendra sir says, I am doing since 40 years.
Yeah.
Like that. This is the thing like that.
His standard sentence is, you individualized your
Yes.
technique.
Your experience counts.
Yeah, counts.
Your own experience and your own patience. Here also, now you can see what I have told. If you kept with the round object also, it won't hurt the electrode.
Yes.
Here also I am keeping some of the Surgicel, the outer part of coming electrode.
This is soft tissue, kada?
Yes, this soft tissue.
Right.
And over that also I will place the Surgicel, sir.
Okay.
Sealing of the electrode. Surgicel long piece. And all around the implant, it prevents mobilization. It acts as a very good. Initially, you can take this long one. I will push like this. See how I am doing. I am pushing like this and also covering this one also. Next, one more Surgicel piece covers this one. One more.
Can we say that this is all modified Raidu's implant?
Yes, sir. Here you can see,
technique.
if you hit this one with the hammer also, nothing happened to the electrode.
Yeah.
Another one to protect
No,
this
that's
one,
the
sir.
confidence.
Okay.
The expression of yourself. Even if you hit with a hammer, it is so stabilized in the bony gutter. That's
yes,
what you had.
I am securing because I am not using any kind of sutures. Initial days with my mentors, I used it to put. After that, I have avoided. I didn't find any mobilization of my electrode or receiver.
Previously in Gleebout, the stitches, they used to make two small holes.
Gel foam,
going
antibiotic
on
gel
threading
foam.
that vicryl, and it will not come out. Again, you cut.
Now I am
Take
keeping
half an hour to just make that this thing.
Ciplox impregnated gel foam in the cavity.
Ciplox with decadron or plain Ciplox?
Plain Simplon. Already we have use irrigation as a decadron,
Yes,
sir.
yes, yes, yes.
After this, I have to close that one. Over.
Raidu, one small question. This patient, I felt there was more perilymph leak than usual. Did you feel the same or? is it-
Okay.
Dr. Raidu, can
sir.
you, this patient, I felt there was more perilymph leak than usual. Did you feel the same or is it normal?
It's normal. It's not abnormal.
Okay.
Normal only. Sometimes we'll have lesser one. This is a normal one.
Okay.
The gush is different. It fills automatically. If you suck also, it fills up.
Okay.
That is the CSF, the perilymph gush.
Hmm.
Then only we have to take care. After waiting some time, after reducing the pressure, we have to seal it a proper way.
Okay.
Or if you suspect prior, we can go for the different electrodes. Those having the stopper at the later end as a conical marking.
Okay.
Those who used to take the wines and all wine bottle cork like thing.
Okay.
Now I am closing. Just take, I am using only one suture material. That is a 40 vicryl, fast of the absorbable vicryl. Only one is enough. See this one. With this one, I will complete the total closure. Because we have to conserve. These are all scheme patients. We don't get much money. Not the money part also. We have to consume the consumptions also. Lesser means we are safe. We are saving more to the nation also. Now, first we have to make the suture to the inferior pole. Inferiorly, we have to suture first. Means it totally covers and also there is no pressure or tension over the musculoperiosteal layer. That is the principle. That's why always inferior pole. Where I have taken a horizontal incision, I will suture first the horizontal incision area, then the posterior, then the posterior superior, then the anterior. Why? Because if you have any lack on the anterior also, I have made a second layer that covers. All are present. The ARTs all are present. You can see in the external camera. You can see in the PIP cut. I'm using microscope. Under microscope only I'm suturing it. What is the time now? What time we have started?
Wonderful demonstration, Raidu. So very clear.
Thank you. Thank you. Thank you very much. But because we have missed the first initial part of preparation also. In the next case, I will show everything. After this case, we have a small, everyone having the coffee and snacks. Please serve the coffee and snacks there.
Yeah, we had it.
And also a small inauguration because our close friend and also president of IMA has a important function. Dr. Singari is there in the hall.
Who, sir?
Dr. Singari Prabhakar.
Prabhakar, sir, is not here yet.
If Prabhakar also should be there for the inaugural ceremony. We'll do it in between. Just make a call to him also, sir. Okay. See the impedances, how the impedance are improved. It's below 5 means very, very normal. You can call very normal impedance. Now I'm closing the posterior wall without tension. We have to close in a water seal tight. Yeah. See this one, posterior one, and also take care small at the level of the receiver stimulator. It has to be covered by at least 2 layers. Right. Why I have spent time to make this cover without without tension. Nanda. Okay.
So there is one short lecture by Dr. Raghavendra Reddy Garu.
Okay.
Once
Now,
you close, can we go with that in between?
okay. Well, no. Just complete everything for the having the junior ones. Just I am closing.
Yeah, after yours. After you close the layers.
After skin closure, after recovery time, you can start the lecture. After that small inaugural ceremony.
Okay, sir.
Raidu. Hello, Raidu. Raidu.
సార్ సార్ రవి గారు చెప్పండి.
So, Raidu, the audience, we have all postgraduates and senior surgeons and the junior consultants are also widely appreciating your surgery.
సార్
And
thank you.
it's, I think it's a blessing to us to demonstrate by yourself. And at the same time, our request is your services needed in the government setups also. Because
Okay.
by seeing the surgery, almost there is no extra equipment is needed. With
That-
the
sir,
simple, simply you demonstrated the surgery very well with the limited
Thank you, sir.
instruments.
Thank you. I have missed that part. I want to explain each and everything. Nowadays, what happening?
Oh.
Starting from my postgraduate days, whenever go for the workshop, after seeing the costly equipment, costly things and all, I used to think, oh, it's not possible for me. Oh, ammo, ఈ మనం
But
కొనలేము,
by
వల్ల
seeing your
కాదు.
surgery, it seems
That's-
to be very simple
That's why
and
this also
quite
very
tempting to operate at the government setups. But
and
maybe
also simple one. And
Yeah.
also always I will feel happy. Anyone invites for Cochlear, I'm always ready.
yeah,
Anywhere, anytime.
yeah.
Sir, can you reduce
That-
the magnification a little bit?
This lower magnification only, Raj garu. Okay, okay, it's clear now. Are you able to see the link? Now I am closing the anterior part.
Yeah.
Without any tension, I am able to close this one. The anterior part I am closing now. That's why. And also I'm not talking about all the complications. I can tag so many complications here. You will find the facial nerve, you have the sigma into jugular valve, carotid artery and all everything. It causes some psychological blocks to the juniors. That's why I don't want to create anything. The surgery means complications are there, but we should practice in a meticulous way, step by step. From the since after one, these steps are same for me. Sorry for that, I'm unable to demonstrate the earlier steps, how to pay positioning preparation. Here the positioning plays major role, Ravi garu. Keeping the baby in a position and taking the ear into the neutral position. There are three types of movements.
Hope in your next case you will demonstrate.
Yes,
for
I
us.
will demonstrate. If external camera is ready, I will demonstrate each and every step. How to bring the patient, how to keep in a position, how to drape and all I will show. Draping also important. I have used only the 50 rupees adhesive drape to have this much of comfort. Previously, they used to describe neuro clips, suturing, everything. Just two master retractors, routine burr, normal burr bits. We are completed the surgery.
It's great.
And also now we do. And also one suture material, one Surgicel, one gel foam, one Decadron. All are the simpler things. All are available anywhere. The main is we have to take care of the child. Taking the chair into the surgery, we have to spend more time, and also that is not a single man show. That is a team decision. The team, what is the team involved in the candidacy criteria? In the lectures, we can explain who are the members in that. The main member is the parent. Parent has to be motivated. We have to inquire about the patient's financial and educational strategies. Why? Because after reaching this stage, after completion of 800 cochlear implants, I am feeling very much bad and very unhappy. Why? Because we are doing most of the cases to the hand to mouth patients. They are unable to bear the expenditure later on. That's why we have to select the patient. Patient is the main key point, and their educational and financial status also. These are all equipment related issues. These are the costly equipment. These are all foreign equipments, not Indian made. Everything is costly FIR. That's why you have to think about it. If possible, we are requesting CEOs and also make so many changes in our implant system. Now I have closed the anterior one. Now I have created another flap to cover all the suture lines. Suture lines. See this flap. See this flap.
Yes.
ఇక్కడ పట్టుకోమ్మా. We have to delineate. We have to separate some more also. I'm not doing. This is the second flap I have created. It covers the entire suture area. Entire suture area. No,
What you are doing
suture
is
exposed
triple breasting.
afterward. This now I can it called as a double breasting. There in area clearly they will say we do double breasting, double breasting. Here also we can do the double breasting. Like this, I have developed that one. The extrinsic or intrinsic postoral fascia. I have told you now, the intrinsic postoral fascia means that is covered with the cartilage anteriorly. That is the intrinsic periastial fascia, the postoral fascia. This is the extrinsic postoral fascia. It has 5 layers. One is the superficial temporal, deep temporal, superficial mastoid and deep mastoid fascias, and also in between innominate fascia. In these, between these fascias only, the posterior auricular artery, superficial temporal artery, some are part of the occipital artery, makes a rich vascular anastomosis. Previously used to have a doubt of vascularity for the flap. Nothing to worry. These flaps have very much vascularity. You can take any kind of incision, any kind of flaps, they can survive until if you don't use the cautery. That's the main thing. That's why I didn't use the cautery. You can make it. Most of my cases are like that only. I don't use the cautery at all. The infiltration, I will show the infiltration technique also easily, simply. That causes not only in cochlear implantation, even in routine ear surgeries also, if you infiltrate in a proper way in this postoral fascia, you won't find any bleeding. See, this is the layer. Second layer, I am suturing. It also covers everything.
To all the postgraduate students, as you can observe, the layers of suturing are not overlapping. They're
Not
not on the
overlapping,
top
yes.
of one another.
We shouldn't overlap. The overlap areas directly causes exposure of the
Overlapping can cause wound gaping at a later stage. Like this, if you do without overlapping, there is enough soft tissue covering the implant.
just simple sutures. I am using a small one. See, whatever I have inserted, I am keeping in the same place and same position. You can get it covers the entire area. Where I have started incision, skin, subcutaneous tissue. Like that also I have closed everything in the same manner. See, these are the layers again. I have sutured the same way. See now. Now I'm going to close the skin. See the small incision. For your demonstrate, I have taken the lazy, yes. Otherwise, I can do with the normal C-shaped incision also. Then here I have to make the subcutaneous sutures. Why? Because these are the small kids. This is a lifetime surgery. If you spend 3 to 4 minutes extra, nothing wrong. After giving the subcutaneous sutures, the patient won't have any scar on it. Most of the times I'm seeing they're coming for the processor aberrations or some problems. I'm seeing on the railroad marks. It gives an ugly scar to the kid and also hair loss. One more point, Ravi Garu, if you use the cautery, the patient will have hair loss in that area. The hair never grows that area. Always they will have alopecia that area.
Right.
Even especially in the female children, it's a problematic. That's why it destroys the roots. We shouldn't use that one. Another point to not using the cautery in these patients. Just one suture, this much length also left over. I'm making subcutaneous sutures. I'm doing under microscope, but that's why it's taking time. Otherwise, I can do fast. After suturing, in between, you can start the lecture. I will show the completion of the suture, Raj Garu, if required. Raghavendra, I can start. You can see the.
Okay, sir.
You can keep the this one in the PIP. Shauredi Garu.
Okay.
You can keep the PIP and start lecture, sir. Narendra.
So second one is the pyramidal eminence. So visualization of the pyramid, yeah, so, and this round window membrane. Okay. So most of the times the round window membrane will also be there at the same level of the oval window. So this also we can notice the pyramidal eminence. So visualization of the pyramid medial to the facial nerve, it is also excellent landmark. So it can be used to localize the round window niche. So how it is oriented? The round window niche is parallel and anterior medial to the pyramid most of the times. So this also we can use to identify the round window in difficult situations. Yeah, and
Do you have that?
sorry, sir, I didn't include all those things. Yeah.
No, it's better to give us picture.
Yes. So yeah. So third one is the fustis. So it is a hard bone extending anteriorly from the styloid complex. So it comes into the mesotympanum. Most of the times it points to the anterior attachment of the round window membrane. Surgically, after doing posterior tympanotomy, the round window membrane should always be there lateral to the fustis. So this is also one important landmark while searching for the round window membrane. So we are talking about round window insertion. So in that, so the round window membrane. So always we should identify the round window membrane in each and every case to do round window insertion, that is soft insertion. So this can be done. So if you are not able to, if you have identified the niche, but you are not able to visualize the round window, then so simply you can irrigate some fluid and you can see the mirror image of the membrane where it comes, where we can localize it by seeing the mirror image to some extent. In all cases, by slowly drilling the round window niche, the overhang, that is tentaculum of the round window niche. So you can identify the round window membrane. So next is to introduce the electrode array into the cochlea. It is always better to see the lumen of the scala tympani. So if you are able to visualize up to the first turn of the scala tympani, so we can get the confidence to insert the electrode array safely into the cochlea. So all these things are important for a soft insertion. So exposure of the round window. So usually we'll get restricted view in some cases because of the overhang. Sometimes it will be covered by a pseudo membrane. A mucosal layer will be there. We can differentiate based on the color. So the mucosal membrane sometimes, most of the times it will be whitish in color, whereas the true round window membrane looks dark gray. So based on that, we can differentiate between the round window membrane and the mucous layer. So the overhang need to be removed to get exact axis for the insertion of the insertion into the round window. And the direction of the insertion of the electrode array, the safer thing is from the posterior superior to the antero inferior position. So thereby we can avoid damaging the crucial structures inside the cochlea. So you can see this exposure of the round window niche. And drilling of the operculum or the tentaculum of the round window niche before exposing the round window membrane. So the membrane is exposed all around 360 degrees. So you can see the enclosed epithelial joint pyramid here. So as discussed earlier, it is closer to Fustis. In the next picture, I will show you. So this is the overhang, sir, bony overhang over the round window membrane. That is tuberculum or tentaculum or the over the round window niche. So this is the incudostapedial joint here. Pyramid comes here. This is the facial nerves, level of the facial. You can see the horizontal segment of the vertical segment of the facial nerve, pyramid. So we are not getting the picture, boss. So now this is regarding the receiver well or bed for the implant. So as we have seen in the live surgery by the by Rayudu sir, so we have to create a clear-cut edges and the well for the implant receiver stimulator. So where in some of the children, engaged children, so the cortical bone thickness will be very less. In that cases, we can drill a island of bone and so that we can push the island of bone along with the dura medially to keep the receiver stimulator in place. So we can see the different receiver stimulator. So the template for the receiver stimulator here. So fixation of the receiver stimulator. For that, so as previously explained, so previously they used to drill holes for superiorly as well as inferiorly to fix the implant with the help of non-resorbable tie-down sutures. So which is a nowadays, I mean, few surgeons are following that. Care must be taken not to injure the fragile electrodes while fixing the implant. Damage to the dura or emissary vein can cause sometimes subperiosteal or even subdural hematoma also. So care must be taken not to injure these structures. These are the tie-down holes they have created here, and they will secure the receiver stimulator here with a non-resorbable suture. So coming to the cochleostomy, so it's always better to insert the electrode array into the widest and easiest accessible scala, that is scala tympani. Round window insertion. By doing this, we can save the residual hearing and the smallest. We can preserve the vestibular functions also. So margin cochleostomy. Some surgeons they do cochleostomy at the anterior inferior part of the round window niche. That is called margin cochleostomy. Some surgeons they do separate cochleostomy for the if there is difficulty in identifying round window niche. So atraumatic opening of the round window membrane using a small hooked instrument, especially in the anterior inferior direction, is very important. Not to open the superior region because basilar membrane is closely situated to the superior portion of the round window. Crista fenestrae, as earlier described, so it's a sharp obstacle during the insertion of the electrode array with the possibility of damage to the array, and it creates a lot of difficulty in insertion of the electrode array sometimes. So we can see the crista fenestrae here. So at the entrance of the round window. This procedure, this So we can finish the introduction of the array by seeing the endocochlear lining safely. We can confirm the soft insertion if you are able to expose the basal turn of the scala tympani. If you are able to visualize the first turn of the scala tympani. So you can see here opening of the round window niche, round window membrane. This is the fustis, which I was talking earlier. This is the round window niche. This is also one landmark for identifying the round window niche and the membrane. So as I described earlier, this points the anterior part of the round window membrane. So this fustis. So this is the vertical segment of the seventh nerve. This is the whole window. This is the pyramidal. Sorry, this is the promontory. Prevention of entry of blood and bone dust into the cochlea is very important to prevent complications like connective tissue formation inside the cochlea after insertion of the electrode. Slow and smooth insertion of the electrode array is also very important to prevent damage to the key structures inside. Fixation of the electrode array. So after confirming the position of and impedance, we can fix. Sometimes some surgeons they use fibrin glue as well as near the opening of the round window as well as near the posterior tympanotomy opening. So this is just to secure along with the temporalis muscle or fascia. Some surgeons they use fibrin glue also. Electrophysiological testing. I'm not going into the details as excellently demonstrated by Rayudu sir, this stapedial reflex and all. So these are important to know the position of the electrodes, whether there is full insertion is done or not. So we can know by doing this before fixing the electrode array. Closure also explained. So after 48 hours also, while discharging the patient, we can advise a wearing of a loose hat, cap, or loose fitting head bandage, especially for the children to avoid damage to the implant. So nowadays, minimal invasive cochlear implant surgery is, it is evolving. So what they do with the help of some softwares like Autoplan, so they design the trajectory. So you can see the facial nerve here, cauda tympani here. So they design the trajectory. So after designing this, they use with the help of robotic drilling, minimal keyhole they will make, and we can introduce the electrode through this keyhole. So you can see here the conventional mastoidectomy. It is done. Posterior tympanotomy you can see. So these are all evolving. So that we can drill a tunnel like this with the help of by some softwares like Autoplan. We can design a trajectory. In the trajectory, with the help of robotic drilling, we can directly approach the cochlea. So entirely robotic cochlear implant surgery. 24 it was done by Abari et al. So they have used Autoplan like softwares, as I have explained earlier, to design the trajectory and to drill a keyhole, and they have used auto drive for the safe insertion of the electrode. So we can meticulously at a constant lesser speed we can insert the electrode array into the cochlea. For that it is very much helpful. So cochlear health, importance of soft surgery. So cochlear health, what I mean here is to preserve the key structures inside the cochlea, not to damage them for certain advantages after the surgery. So importance is nowadays, as we know, the candidacy is including even for the severe. We are now doing cochlear implant surgeries, bilateral severe hearing loss cases also. So it means they have some residual hearing already. So to preserve that residual hearing, it is very important to do soft surgery, and it is helpful for preserving the residual hearing and for the speech perception in the noisy background. So after the surgery, to preserve the speech perception, especially in the noisy background, it is very important to retain the structures inside. So the vital structures, like we should not damage the basilar membrane, organ of Corti, or the spiral ligament, which is helpful for the vascularity of the cochlea. So these structures we should not damage. It helps for the vestibular function, to preservation of the vestibular function also. These are all, they have done a retrospective studies, reviews over the previous studies, and they have identified that. So with the help of, by doing soft insertions and all, we can preserve these things. So in this, we can see what are the risks, microstructures which are at risk while doing electrode insertion. So it is very difficult. So in this study, what previously they used to face many problems, like so obviously we have to study over the cadaver bones to see the structures inside by doing the cross section. So to preserve the soft structures, bony structures anyway, it will be preserved by doing cross sections and normal staining also. But to visualize the soft structures like basilar membrane, organ of Corti, the Reisner's membrane, these things, it is difficult to preserve these structures in cadavers while doing retrospective studies. So what they have done, they have developed a special, they used a special contrast, and they have studied the cochlea, the cadaveric cochleas by doing cross sections, and they have identified the key structures vulnerable for the damage because of the insertion of the electrode array. What we are seeing, it is the osseous spiral lamina here. These are all Rosenthal canals, and this is the basilar membrane. CPB means cochlear partition bridge. OOC means organ of Corti, and this is the basilar membrane. Seeing the scala media is very difficult. In this, they could visualize the scala media also. This is the spiral ligament. So after insertion of the electrode array, so these structures got damaged. So these things, what hypothesized or imagined are true. So we are damaging these things by not doing soft insertions and all. So there is a classification also. Eshragi et al., they have classified the cochlear trauma post insertion of the electrode array. So this is there available. So grade 1, no observable microscopic trauma. Grade 2, there is simple elevation of the basilar membrane. Grade 3, there is dislocation of the electrode into the scala vestibuli. That means the basilar membrane got damaged. Grade 4, fractures of the osseous spiral lamina, modiolus, or tear in the stria vascularis or spiral ligament. All these comes under grade 4. So in number of studies they have proved, so we can preserve the residual hearing, residual acoustic hearing, which is helpful after the, they are called hybrid cochlear implants. So we can stimulate the electrode array by electrical stimulus, as well as we can use the residual hearing by using the hearing aid, which are incorporated in the same implant. That is called hybrid implant. It is called electroacoustic stimulation. To utilize that, to use it, it is important to preserve the residual hearing. Careful, implant design is also very important for less traumatic insertion, and careful surgical technique is also important for soft surgery. And pharmacological agents such as steroids intraoperatively, postoperatively, also very important for preserving these functions. So here is a study where they have observed, where they have compared different techniques. here you can see surgical technique. If you take where they have compared various parameters. Surgical technique, if you take by doing cochleostomy or round window insertion, there is no significant difference in preservation of residual hearing. So if you make round window opening, if you are making a round window opening, if you are making a slit, or sometimes some people they make a slit, some people they wide open. So wide open is better when compared to slit opening. So insertion speed, anyway we know slow insertion is better when compared to faster insertion, but the speed of insertion is not is unclear till now. Coming to the electrode insertion, electrode type. So if you take a if you compare perimodular and straight electrode arrays, the straight array has got a significant preservation of the residual hearing when compared to perimodular array. Next, electrode stiffness. So flexibility is better when compared to stiff electrodes. Electrode length. So by using shorter implants, shorter electrode arrays, you can preserve. But with a full length insertion, post-operatively, you will get better speech outcomes. That is what this study says. So pharmacological therapy, hyaluronic acid they used to use, but it doesn't make any difference. Corticosteroids, either while insertion of the electrode or by giving short-term post-operative preservation of the residual hearing, but long-term usage is not proved. So next, activation of after surgery. So we know generally after 2 to 3 weeks after surgery, after confirming the complete healing of the incision site, we generally switch on the device. But they studied within 24 hours also, they have done switch on and they studied. So there is no significant difference. If you keep it after 24 hours, after 2 to 3 weeks, there is no significant difference in wound healing, in preservation of the residual hearing. This study says that. And coming to the this thing, so what we are doing actually by doing soft insertion, we are preserving the surviving spiral ganglion cell bodies. We are preserving the auditory nerve peripheral process. We are preserving the central processes, and we are preserving surviving neurons, inner hair cells, and supporting cells. So by doing this, we are able to preserve the cochlear health. So trials are there. Trials are there to prevent the connective tissue formation after the electrode array insertion. What they have done, they used drug-eluting, so which secretes neurotropins and some intracochlear steroids. So by using this also we can, it is proved in animal models that we can improve ABR after electrode insertion. So these are also under trials. So thank you for listening.
And thank you. Tell the program already have given in the group also. Now we are going to have a minimal inaugural session within 10 to 15 minutes. After that, we have a lunch, quick lunch. We have the quick lunch. After that, we have the live surgery demonstrated by Dr. Anand Raju from Coimbatore, one of our close friend. He will demonstrate his technique. Later on, next the Padma Shri, the first Padma Shri, not first, I think, second Padma Shri in ENT and also Padma Shri in cochlear implants. Dr. J.M. Hans will deliver a lecture. After that, another legend and also Padma Shri in ENT, Dr. Mohan Kameshwaran lecture. After that, Dr. Rajesh Vishwakarma speaks from Allahabad. Because of the physics and all, they're all speaking hybrid mode. They will give the lectures here. Tomorrow morning, we'll demonstrate one case that is a difficult case, and second case is a varia technique. The concept is everyone should learn all the techniques, everyone should practice at their easiest way and also minimal way. This covers the entire cochlear implants. There are other techniques also there that they are not routinely practiced, midcranial fossa approach and supramastoid approach. Basically, worldwide, these are the two techniques, mastoid and posterior tympanotomy, majority of the people will follow. Another is the varia. I will explain the difference also later on. First, we will forward with the just inaugural session. I will request our dignitaries for the dais. First, our state IMA president and also our close fraternity colleague and friend, Dr. Nandakishore Garu. Then my guru, just like I get the angry, is suppressed by Dr. Singari Prabhakar Garu. Please come over the dais. I had traveled with him. I stayed 2 days with him during Vizag conference long back. I have walked with him on the beach roads. How he shaped me, how to decrease the anger, how to not to react the situations, act to the situations. I learned from Singari Garu. I'm always thankful for him. And also our guest of honor today is Dr. Azu Anand. With the shortest relation, we have very deepest and strongest bond. Not only for me, his wife is Vishnupriya, she is also a gynecologist, and also my wife have the close relation. We spent past 10 days in Europe to celebrate our 25 years marriage anniversaries there. That's why the program was delayed. And also, guest of honor, our Dr. Sai Krishna, our state IMA branch secretary, and also our organizing secretary, Dr. Krishnamraj Garu, come over the dais, and also organizing treasurer, audiologist Narendra, and also backbone of my cochlear implant program, backbone. Really, we see in front of the program always behind the support from the audiologist and speech therapists. They will build up and strongly they will make the program by them only. And Dr. Radhika Rani, and also invisible support for in all aspects is my better half, Dr. Radhika Rani. Then prayer song. Song,
त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योति शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Now I request dignitaries on the dais to participate in the lighting of the lamp. Jyoti Prajalanlo ముందుగా Thank you. I request our chief guest, Dr. Nanda Garu, to deliver some things.
Good afternoon, respected Singer Prabhakar Garu and Anand and other dignitaries and Madhu Garu and our beloved ENT colleagues. So, actually, రెండున్నరకి నేను ఏదో తిరుపతి వెళ్ళాలి కాబట్టి టైం అయిపోయిన మీద ముందుకు జరిపారు. సారీ ఫర్ ద ట్రబుల్. సో వీఆర్ వెరీ హ్యాపీ ఎందుకంటే డాక్టర్ ఐడి ఈజ్ కండక్టింగ్ సెకండ్ కాక్లియర్ ఇంప్లాంట్ వర్క్షాప్. So 10 years before, the situation was different. Cochlear implant అంటే అదేదో అందరినీ ద్రాక్ష పండులాగా అక్కడక్కడ చూడటమే కానీ చేసేవాళ్ళు ఉండేవాళ్ళు కదా. ఆంధ్రప్రదేశ్లో ఒక మన భయ్య గారు అట్లా చాలా లిమిటెడ్ పీపులే చేసేవాళ్ళు. సో ఇప్పుడు ఆఫ్టర్ 10 years, so many people are doing. So this is one example how ENT is progressing. సో అట్లానే దీనిలో రాయుడు కూడా చాలా హార్డ్ వర్క్ చేసి హిమ్సెల్ఫ్ became a cochlear implant surgeon, as well as he trained many people and he is helping. So that is what we have to learn from our seniors. So you need to help your colleagues. ఏంటి వాళ్ళు ఉంటే వాళ్ళు చూసింది ఓపి మన దగ్గరికి వస్తే వాళ్ళ గురించి ఏదో ఒకటి మాట్లాడేయకుండా వీ హ్యావ్ టు ప్రోగ్రెస్ టుగెదర్. ఎందుకంటే ఇట్స్ వెరీ కాంపిటేటివ్ ఫీల్డ్. సో డాక్టర్స్ ఏంటంటే యునైటెడ్గా ఉంటేనే వీల్ ప్రోగ్రెస్. అండ్ మధు గారు, సో మెనీ పీపుల్ ఆర్ డూయింగ్ వండర్ఫుల్ జాబ్ ఇన్ అవర్ ఫీల్డ్. సో హోప్ వీ విల్ ప్రోగ్రెస్ ఫర్దర్ మోర్. అండ్ ఏంటి అంటే ఒకప్పుడు అంత చామ్ ఉండేది కాదు, ఇప్పుడు వీఆర్ బికమింగ్ స్ట్రాంగ్ డే బై డే. సో ఐఎంఏలో కూడా చాలా ఏంటి వాళ్ళు ఉన్నారు, అందరు జోకులు వేస్తూ ఉంటారు, మీరు ఏంటి ఖాళీగా ఉంటారు, అందరూ ఏంటి వాళ్ళే కనపడతారు, మధు గారు నేను అట్లా. సో అందుకని మన మీద అందరికి కన్నుంది కాబట్టి కామ్గా ప్రోగ్రెస్ అవుదాం. వన్స్ అగైన్ ఐ థ్యాంక్ రాయుడు అండ్ హిస్ టీమ్ ఫర్ ఇన్వైటింగ్ మీ ఫర్ దిస్ వండర్ఫుల్ అకేషన్. అండ్ థ్యాంక్స్ టు ఆనంద్ కోయంబత్తూర్ నుంచి ఆల్ ద వే కేమ్ టు డెమాన్స్ట్రేట్. And once again, thank you all.
Thank you, Nanda. Even though busy schedule, he is able to come and wish us for the surgery. Now, I request Dr. Singer Garu speak few words.
dignitaries of the dais, and dear colleagues. నేను యాక్చువల్గా ఈరోజు వచ్చింది నాట్ యాజ్ ఎ ఫ్రెండ్ ఆఫ్ రాయుడు. ఐ కేమ్ యాజ్ ఎ అబ్జర్వర్ ఫ్రమ్ మెడికల్ కౌన్సిల్ ఆఫ్ ఆంధ్రప్రదేశ్. ఐ రిక్వెస్ట్ ఎవరిబడి కైండ్లీ సైన్, బికాస్ మన వాళ్ళందరూ వస్తుంటారు కానీ సైన్ చేయడం ఒకసారి మర్చిపోతే మళ్ళీ అనవసరంగా ప్రాబ్లమ్స్ వస్తాయి. బట్ ఇన్ స్పైట్ ఆఫ్ దట్ వీ కెన్ హెల్ప్ యూ. బట్ స్టిల్ ఐ రిక్వెస్ట్ ఎవరిబడి టు సైన్ టుడే అండ్ టుమారో ఆల్సో ఇన్ ద రిక్విజిట్ ఫార్మ్స్. అండ్ అజాత శత్రు అంటే మన మధ్యలో ఉన్నటువంటి మధుసూదన్ రావు గారిని చూసి నేర్చుకోండి అని చెప్తాను నేను. ఎందుకంటే చాలామందికి అన్ని చోట్ల ఫ్రెండ్స్ ఊళ్ళో చాలా కష్టం శత్రువులు లేకుండా చూసుకోవడం. కానీ మధు స్పెషాలిటీ ఏంటంటే అంద్యాల్లో అందరూ ఈఎన్టీ సర్జన్స్ ఆర్ వెరీ 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 గుడ్ ఫ్రెండ్స్ ఫర్ ద మధు. సో నేను కూడా రాయుడికి చిన్న రిక్వెస్ట్ చేసిందంటే, రాయుడు యు ఆర్ వెరీ అప్కమింగ్ సర్జన్, నువ్వు చాలా బాగా చేస్తున్నావు, ఐఎమ్ వెరీ ప్రౌడ్ ఆఫ్ యూ. కానీ రాయుడుకు కొంచెం ముక్కు మీద కోపం ఉండేది, అది మాత్రం పూర్తిగా మాయమైపోయింది. మళ్ళీ మేడం గారు చెప్పాలి, లేదు మేడం ఇంట్లో ఉండొచ్చు ఒక చుక్క కానీ, బట్ మా ఈఎన్టీ సర్కిల్లో మాత్రం ఇప్పుడు బాగా తగ్గిపోయింది. అవునా? బట్ నౌ ఈజ్ వెరీ ఫ్రెండ్లీ విత్ ఎవ్రీబడి. I request Raidu to grow like that and take the example of Madhu and be like that. ఎందుకంటే unless we grow together, we can't achieve anything. మా ఫిలాసఫీ అంతా కూడా we have to grow together. ఆ విధంగానే నేను విజయవాడలో గ్రో అయ్యాను. మేమంతా విజయవాడలో కూడా విల్ బి వెరీ వెరీ ఫ్రెండ్లీ విత్ ఆల్ ఈఎన్టీ సర్జన్స్. మా దగ్గర సార్ చెప్పినట్టుగా కాంపిటేటివ్ వరల్డ్లో అన్లెస్ వీ గ్రో టుగెదర్ ఇట్ ఈస్ వెరీ డిఫికల్ట్. ఎవరైనా ముఖ్యంగా మెడికల్ కౌన్సిల్లో మనకు వచ్చింది ఏంటంటే చాలాసార్లు మనకు వచ్చే ప్రాబ్లమ్స్ అంతా కూడా బికాస్ ఆఫ్ అవర్ కొలీగ్స్. సో అందుకని దయచేసి ఎవరైనా మన కొలీగ్స్ పొరపాట్లు చేసి వచ్చినా కానీ డోంట్ క్రిటిసైజ్. ఐ ఆల్వేస్ సే దెమ్ పేషెంట్, దిస్ ఈజ్ ద 2 types ఆఫ్ ట్రీట్మెంట్. ఆ డాక్టర్ గారు చెప్పింది కూడా కరెక్ట్ కావచ్చు, బట్ ఇఫ్ యు ఆర్ వాంట్ ట్రీట్మెంట్ బై మీ యూ కెన్ ఆల్సో ఫాలో దిస్ ట్రీట్మెంట్. ఇట్ ఈస్ యువర్ చాయిస్. అది తప్పు అని నేను చెప్పను, బికాస్ మెడికల్ స్కూల్స్లో మేము చండీగఢ్లో పీజీ చేసేటప్పుడు ఆల్వేస్ వీ యూస్ టు హ్యావ్ 2 things అకార్డింగ్ టు ద యూరోపియన్ కల్చర్ అండ్ అకార్డింగ్ టు ద అమెరికన్ కల్చర్. యూ కెన్ హ్యావ్ 2 types ఆఫ్ ట్రీట్మెంట్ అని మేము డిస్కస్ చేసుకునే వాళ్ళము. సో వీ నెవర్ యూస్ టు క్రిటిసైజ్ దిస్ ఈస్ ద ఓన్లీ ట్రీట్మెంట్ వీఆర్ గివింగ్ ఆర్ దిస్ ఇస్ ద ఓన్లీ ట్రీట్మెంట్ రైట్. సో లైక్ దట్ don't criticize other ENT colleague or other doctors, and we grow together. I wish you all the best for Raidu, because I see each and every ENT surgeon in a given town should do cochlear implants. That's what Raidu used to say. So I congratulate once again Raidu and his team, and thanks for calling me for this occasion. Thank you.
Thank you, sir. Thank you. We'll follow the suggestions. Really, now also, I'm sometimes like that only. Don't misunderstand because of the initial fire. My father-in-law used to tell, అదే నా కోపం అనేది తాటాకు మంట అనేవాడు. ఫస్ట్ నాకు అర్థమయ్యేది కాదు, అది అట్లా అంటుకొని ఆగిపోయింది. తర్వాత నాకు మా అబ్బాయిని తిడితే కూడా వెంటనే నవ్వు వచ్చుద్ది, పక్క తిరిగేవాడిని. మా ఆవిడ తిట్టేది, వాడికి ఇంకెక్కడే ఉంటుంది, నువ్వు ఆ తిట్టిన వెంటనే నవ్వుతావని. ఆ తిట్టడం వరకే, తర్వాత అంత మర్చిపోతాను. అందుకని ఎవరైనా హట్ చేస్తుంటే మాత్రం ఓపెన్గా ఐఎమ్ ఆస్కింగ్ ఫర్ యువర్ అపాలజీస్. థ్యాంక్ యూ. నౌ ఐ రిక్వెస్ట్ అవర్ క్లోజ్ ఫ్రెండ్ సాయి కృష్ణ, అవర్ బ్రాంచ్ సెక్రటరీ, టు కమ్ ఓవర్ ద డయాస్ in the dignitaries list. Now I request our guest of honor, Dr. Anand Garu, say a few words.
Good afternoon. I'm not a very big man, so Dr. Madhusudan is there actually. So he's also one of my groom. I used to meet him in every conference. So already morning I told, so when Madhusudan is there, so there is no problem for any conference. He will moderate the whole conference without any hesitation and any problem. As well as Raidu is my close friends. Actually, we have been friends for the last 1 year. So he's a very straightforward, very strict and disciplined. So the correct time food, correct time sleep, correct time work and everything. It's very used to. He used to advise me to proper sleep, because actually I used to travel so Coimbatore and Chennai so frequently. So he used to advise me take rest. As a brother, he is taking care of me. So I really jealous about him actually. So I'm mainly doing cochlear implant and sleep. So we used to conduct a lot of hands-on workshop in sleep as well as implant. So I really proud of Lloyd. So this is a very good. Actually, you saw the surgical demonstration. No, very clear, no hesitation, no any problem. There's a disturbance in the surgical field. Actually, you used to continuously talk. So even not even as a very good surgeon, they have a ability to continuous talk throughout the procedure. So very good demonstration. There is no problem throughout any single step in the surgery. So very clear actually. So this, I used to conduct a lot of workshop in Coimbatore. Recently started in Chennai also. The purpose of doing workshop is to not to advertise ourselves actually. So teach the juniors. So I do have a lot of fellowship in my hospital. So teaching the students is so one way of learning ourselves actually. So at least we teach one of you. So definitely we have this what is this a pleasure inside us actually to we taught one that's a really so very useful because I learned all from my guru Mohan Kameswaran. I was with him for 5 years. He taught me a lot of things actually. So how to be a simple human being. So the thing is, actually, I so far I did a 600 cochlear implant. Really thank you to Roy as well as Radia for me this chance to calling me here and to demonstrate a surgical demonstration. I think so. I'm really afraid of doing a cochlear implant after Raidu. So he demonstrated very well. Anyway, so if there is any problem, kindly excuse me. So probably next surgery I'm going to demonstrate. So keep on ask some questions. So if people are not asking any questions actually. So once you ask question, definitely we will learn from the question. So a lot of questions is there still lot of questions still not answered in the cochlear implant about radiology, about trauma to the cochlea, so the type of incision, so how much time you take. A lot of questions are there. That is a little thing. So doing a surgery is very simple. So cochlear implant not a major Himalayan task. It's a very simple surgery anyone can do. The thing is actually post-operative follow, pre-operative selection of cases and candidacy all is important. It's a teamwork, not only by cochlear implant surgeons, audiologists, as well as pediatrician, all our surgical staff, all they go to do a combined work. Then only we can give a great success. So don't think a cochlear implant is a major surgery. It's a very simple surgery. Even the first graduate, postgraduate, so third year postgraduate can do a cochlear implant. So do attend my Guru used to tell at least 20 temporal bone dissects, then only I will give a chance actually. I assisted him for 130 by cochlear implant. After that, he gave me only one case of incision. So that's why, so he used to tell me, so incision is very important actually. So you can do cochlear implant, but the outcome must be very great actually. So outcome, the patient able to sing a song, that is a real success of your cochlear implant. So that is the thing. So try to attend a lot of temporal bone workshop and try to come actually. So the student is there in Salem. So he used to come every Sunday to the hospital actually. So every Saturday, Sunday, supposed to come and watch the surgeries. So free time come to Ride Hospital. He won't charge anything for your. Won't charge anything for observation. Okay. So come and observe cases as well as go to, so a lot of our senior ENT surgeons are there. So you just ask them, they will really welcome you. So go and watch surgery. Seeing 10 surgeries equal to doing one surgeries. So that is an important thing to learn actually. So like that, you have to develop your own thing. If there is any workshop you have to attend, it's a Saturday, Sunday. I think we will ask our IMA president, suppose you give an instruction to all medical college, suppose the high number of attendance of any conference, you have to give a, what is this actually? Points, as well as the lack of attendance is a very important thing for the PGs to apply the exam, because I had the faced the same situation. During my PG, I got only 60% attendance. So only Mohan gave the permission to my HOD. So because I attended Mohan conference during my second year and third year, so he asked my professor to clear for my exam. That's why I got my results. Otherwise, they made me to wait for one more year to write the exam. So that is the requisition I'm asking. So give a postgraduate exemption for this high number of attendants in the conference, you give a exemption for the clearance for the exam. Thank you so much. I'm going to demonstrate this my own way. It's not think about Roydo's own way. So, so I will demonstrate a little bit. There is a lot of, so I practice in Chennai as well as in my Coimbatore. So learn from Mohan. They have all high sophisticated instrument. So with the Skeeter only, he used to advise enter the cochlea. I don't know whether Skeeter is there here. No, no problem. So no, we can do anything with anything, so no problem. I think so. Probably I'm going to face problem in the theater anyway. So Roy is there, so we can do it. Thank you, but keep on ask some questions. So with your questions, so ourselves we learn as well as you can learn. So thank you so much for the wonderful opportunities. Thank you, everyone. Thank you so much.
Thank you, Anand. Anand is always moving. One day in Coimbatore, one day in Chennai, in between abroad. Even though the hectic schedule, he has come with suffering with laryngitis. Thank you once again. I request our Secretary of IMA, Guntur, to speak few words.
Good morning, everyone. At the outset, I feel it's a privilege for me to stand before such an august audience and talk, and on this too, on a great occasion. I think you can understand Telugu, sir. Coimbatore people can understand Telugu, I think. Now I'll speak Telugu. కాక్లియర్ ఇంప్లాంటేషన్ అంటే ఇప్పుడు హైదరాబాద్లోనో చెన్నైలోనో లేకపోతే బాంబేలో జరగాలి. గుంటూరులో జరుగుతుంది, అది కూడా డెమోన్స్ట్రేషన్ చేస్తున్నారంటే ఇట్స్ ఎ గ్రేట్ థింగ్. అది మా అండ్ సెకండ్ థింగ్ ఈజ్ అవర్ స్టేట్ ప్రెసిడెంట్ అండ్ అవర్ బ్రాంచ్ ప్రెసిడెంట్ బోత్ ఆర్ ENT surgeons. సో ఇట్స్ అ వెరీ గ్రేట్ ఒకేషన్ ఫర్ ఆల్సో. వన్స్ ఇన్ వైల్ మాకు స్టేట్ ప్రెసిడెంట్ గుంటూరులో 15 ఏళ్ళు అయింది. నందకిషోర్ తర్వాత మళ్ళీ అవతారలేదు తెలీదు. రాయుడు గారు కూడా ఇదే సేమ్ టైంలో ప్రెసిడెంట్ అవడం, ENT సార్ అవ్వటం, మళ్ళీ మాకు ప్రెసిడెంట్ అవ్వడం, అది మా ఐ థింక్ ఇట్స్ ప్రివిలేజ్ ఫర్ అస్. అండ్ ఐ స్టాండ్ యాజ్ అ స్మాల్ పర్సన్ ఇన్ ఫ్రంట్ ఆఫ్ యూ. And I feel it's a privilege for me, and he has given a privilege for IMA to participate in this great conference. And I wish the conference a great success. Thank you very much.
After coming into the IMA, accidentally I came, but Sai is working very well. He's creating the CME sessions very interactive, very interesting also. Previously, I used to see all the elder people used to come to the IMA. Nowadays, we are crossing more than 100, all are youngsters. Yesterday also, we had a CME on how to read CBP, just how to read the CBP, complete blood picture, and also skin care, hair care. I've seen a lot of youngsters to come like that. He's also making the IMA more live. Now we request our organizing secretary, Krishna Raj Garu, say a few words.
Respected dignitaries on the stage, off the stage. I'll make it very short. First of all, I'd like to congratulate Dr. Raidu for organizing such a lovely workshop. It takes so much zeal and interest to organize workshops to make everyone learn. And he's very eager, keen to show what he's learned he struggled so much. I know he struggled in the last 10 years to become a cochlear implant surgeon, and he wants to impart that knowledge to everyone. I congratulate you, Dr. Raidu and Madam, for all your efforts. And I'm namesake organization secretary. So because all the hard work he's done, I was just invited because I'm in Visakhapatnam. There was not much I could do to help him, but he's done very good job. One good thing about Dr. Raidu is very approachable, particularly for all the juniors. If you are starting your program, and I know Raidu for the last 5 years, but I have known as a person for the last 3 years. As sir was saying, he's improved both surgically and also personally quite a lot. And Raidu, I wish you reach great heights. Your zeal is very much appreciable. So please keep the same zeal, keep the same interest in teaching all the juniors. You learnt it the hard way, and you made cochlear implant surgery very simple. So we did about 72 cochlear implant surgeries and in our hospital, and he's the mentor surgeon for us. And I learnt a lot from him. So every time I call him, say we have these 3-4 implants for this week, he's always ready. I'm sure he's given the same olive branch to all the ENT surgeons around Andhra Pradesh and also in Telangana. So all the best to you, Raidu, and keep conducting lots of workshops, keep teaching. You'll excel in everything you do because you take keen interest in even the finest detail. So all the best to you.
Thank you. Thank you. Now I request Dr. Madhugar say a few words. I am a student for him. My post-graduation days, I went to see his lectures. I used to sit in lecture hall during 2001 and 2 years. Thank you.
Only 60 seconds. Dais and delegates. I am a senior citizen in ENT, but president of Nandyal IMA, president of Guntur, president of the Andhra Pradesh state. There are, I think, 4 ENT surgeons in Andhra Pradesh. Elur, Srinivas Raju. Miss, oh, sorry. So 4 IMA branches are headed by ENT surgeons. Indriyanam Nayanam Pradhanam. I say that Indriyanam Shravanam Kuda Pradhaname. Not that vision is not important, but among all 5 special senses, now only hearing is being replaced by the technology. None of the other senses are being replaced. Second point I would like to stress upon. Prashninchandi. Ask. Silence from the delegates will not make any conference or a workshop to go ahead. This is a forum, this is a dais, this is a congregation where you have to rectify your doubts. If you are shy, pass on the question to the moderator or to the surgeon by yourself. With these 2 words, Nandyal is a small place, about 2.5 lakhs population, and Monday we are celebrating World Hearing Day, completion of 150 implants in a small place. My son, Dr. Manideep, has done bilateral implants also, and he has a big relief for me because otherwise I used to do all these surgeries. Bhaiya Srinivas Rao and Dr. Raidu. These 2 people are the mentors, and the whole credit goes to them. For Nandyal, I don't know in India, less than 3 lakhs population towns. Guntur must be about 20 lakhs, 10 lakhs. So a small place, credit goes to the mentors like that. Raidu is a spoon feeding surgeon. He will be very patient, very cautious, very diligent, and very standard, simple, secure, safe teacher. I can say that he makes the person feel confident. Even if that step is there, no, I am there. And I feel that I am not like you. I am jealous of you, Raidu. But it's a positive jealousy. Don't think that jealousy is a negative word. Thank you for giving me this an opportunity.
Thank you, sir. Thank you. Masoon Rao Garu, since more than 20 years, I think 25 years, he's training all the juniors. He's always taking care of the juniors to do the all surgeries with the minimal required equipments, entire basics, his concept. And also, thank you very much. He's always ready to accept whenever I conduct anything. He's ready to come and also he'll entertain all the people. Thank you very much. And also, I'm requesting you to join for a lunch with a quick lunch as soon as possible. Come back. We'll start the case. Now we're going to demonstrate from the first step how to prepare the patient, take to the theater, infiltration techniques. All I will show. Then from surgical steps by Dr. Raju Anand. Please go have it. Yes, everything in detail I will tell from the theater. Thank you. Join for lunch. Thank you very much. Thank you once again for our Dr. Nandakishwar Garu and all the dignitaries, Singari Garu as a MCA observer, and Sai Krishna Garu and Krishnan Raju. Thank you. The lunch is opposite side building. Go to the down floor and just see. There is a Radhika Cosmetology Clinic. There you can have the lunch. Okay. Thank you very much. And also toilets are at the second floor. Male and female toilets are there. The signboards also there. If anything required, just call 971-971-9449. And also We చెప్తానండి. We have Wi-Fi password. You can scan the password. Everyone will get the Wi-Fi signals. And anything, just ask. Don't keep in your mind. Just keep on asking. Thank you. మాట్లాడతాను. నాకు కేబుల్స్ కేబుల్ ఎక్స్టర్నల్ కేబుల్ వేసుకుంటారా పైకి? దీనికన్నా అదే బాగుంది అంటున్నారు సార్ అండి. ఎక్స్టర్నల్ కేబుల్ లాగా చూడు ఈ టైంలో. We can arrange external table. ఎక్స్టర్నల్ కేబుల్ ఓకే. ఒకసారి శివరెడ్డి గారు పైదానికి ఒక ఎక్స్టర్నల్ కేబుల్ వేసుకొని చూడండి. పైదానికి ఒక ఎక్స్టర్నల్ కేబుల్ వేసుకొని చూడండి. ఓకే, నౌ గుడ్, థ్యాంక్ యూ. ఓకేనండి. పైన అంటే కింద ఓటీలో. ఓకే, ఇది ఉంటే పర్లేదు. నాకు కెమెరా కావాలి తర్వాత, ఎక్స్టర్నల్ కెమెరా చక్కగా చూపించే కెమెరా నాతో పాటు తిరగాలి. ప్లస్ ఒకసారి కేబుల్ కూడా దానికి వేసుకొని చూడపోయారు బయట నుంచి. దీనికన్నా అది బెటర్గా ఉందంటున్నారు. అవునండి, ఇంకొక ఆ పిన్ తీసేది చెత్త కేబుల్ కదా, మనకు తెలిసిందే కదా. బయట నుంచి వేసుకోండి. అదేముంది ఊరికి పైనుంచి సిస్టమ్ అక్కడ ఉంటారు. సిస్టమ్ అక్కడ ఉంది, టేబుల్ పెట్టేస్తారు. కాదండి ఒకసారి బయట నుంచి వేసుకోండి కేబుల్. బయట నుంచి వేసుకోండి, ఏమైంది మళ్ళీ
కేబుల్ హీట్ ఎక్కుతుంది, దాని గురించి జామ్ అవుతాడు. అలా కాదు, పవర్ వస్తా పోతా ఉంది. అంతకుముందు కూడా మనం స్విచ్ చేసి తాగి వస్తా ఉండేది.
అవునండి, మెయిన్ దానిలో సమస్య కల్పిట్ అవుతుంది. ఆ కేబుల్ వరస్ట్ కేబుల్ లాగా అనిపిస్తుంది నాకు. ఒక్కటి బయట నుంచి వేసుకోండి కదా.
ఈ సైడ్ నుంచి అటేసుకోవాలి.
ఇదే
అదండి, అది సమరం లేదంటే ఆ ప్రొజెక్ట్ కేబుల్ అది అలావుది షార్ట్ త్రూ ఉంది.
ఏదో ఒకటి ఒకసారి పెట్టుకొని చూడమ్మా. నిచ్చిన తెచ్చుకొని, నిచ్చిన ఎక్కడ తెచ్చుకొని తర్వాత ఇందులో ఒక ముందు వీళ్ళు వచ్చేలోపు తయారు చూసుకోండి. ఆడియో ఓకే, ఇక్కడ పెట్టుకోవాలా?
పెట్టుకుంటే
నేను నా పొజిషన్ చెప్తాను. అవును, ఇట్లా ఉంటుంది. తర్వాత ఆయనకి ఇవ్వాలి. ఓకే 1 2 3 4. నౌ ఐఎమ్ గోయింగ్ టు డెమాన్స్ట్రేట్ సర్జికల్ స్టెప్స్. ఓకే, బాగుంది, గుడ్. హలో 1 2 3 1 2 3. The mic for you because that is very disturbing. Otherwise, okay, thank you. It's working well. Charge పెట్టండి లోపు. ఛార్జ్ పెట్టి ఈ లోపు నాకు ఒకసారి బయట ఎక్స్ఎల్ కేబుల్ వేసుకొని చూసుకోండి. ఎక్స్ఎల్ కేబుల్ మధ్యలోంచి పైకి వెళ్ళిన పర్లేదు. కాసేపు అందులో పెట్టారు మళ్ళీ చెక్ చేసుకొని
హలో 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 ఇప్పుడేం ఆగదు మళ్ళీ వాళ్ళు వచ్చిన తర్వాత మన కరెక్ట్ టైంలో ఆగిద్ది అది తెలిసిందే కదా. తర్వాత ఈ ల్యాప్టాప్ ఆ బ్లూటూత్ పెట్టాం కదా, ఆ బ్లూటూత్ ఆన్ చేస్తే పోద్ది కదా, ఇది పక్క పోతే రావట్లా. ఆ బ్లూటూత్ దివు. నిన్న దీనికే సచ్చారు వాళ్ళు లాగడానికి. ఏమి లేదు, దీనికి తీసుకెళ్ళి ఆడి పెట్టి ఆడి నుంచి ఎటు లాక్కొచ్చుకుంటూ పోద్దాం. ఆడ పైన పైపు కట్టేసి ఆ స్పీకర్ కట్టేసి తీసుకురా సరిపోద్ది. పొడుగుందా? పొడుగు అయితే కెమెరా తెద్దాం అందుకు. అని కాదమ్మా, ఆ రిబ్బుకి
కనెక్షన్ చేసి అక్కడ పెట్టేసుకుంటారా?
బ్లూటూత్
వారికి క్లిప్ ఆన్ కనెక్ట్ అయింది.
పైదేనా? 80% బ్యాటరీ ఉంది.
ఓకే, కనెక్ట్ అయింది.
మాట్లాడు.
మాట్లాడేది వినపడాలా?
అది పైది కనపడుద్ది కదా, ఇది ఆయన ఆడ పెట్టుకోవాలి లెక్క అయితే. వాళ్ళు మాట్లాడేది వీళ్ళకి కనపడిద్ది. ఇక్కడిది పోవాలంటే ఎట్టాను కదా,
కిందకా?
ఇక్కడ బయటికి పోవాలంటే
ఇక్కడిది.
ఇక్కడ వినపడాలంటే
ఇది వినపడాలంటే ల్యాప్టాప్ లోది. ఓకే,
ఇప్పుడు మనం మాట్లాడింది బయటికి వెళ్ళాలి.
మనం మాట్లాడేది బయటికి వెళ్ళాలా?
అక్కడ కూడా అదే ప్రాబ్లం కదా. అక్కడ ల్యాప్టాప్ పెట్టేసి దీని ల్యాప్టాప్ పెట్టేసి వెళ్తే ల్యాప్టాప్లోకి వెళ్ళిద్ది. హెడ్ ఫోన్స్ చెప్పు, నేను పెట్టుకుంటా, నీకు అర్థమైద్ది అంతే. హలో హలో, సౌండ్ బాగానే ఉంది ఇది. హలో హలో హలో, మై టెస్టింగ్. కాదు మళ్ళీ అక్కడ ట్యాగ్ అయ్యి పైన వేసి ఆ లాస్ట్ స్పీకర్ కాడికి తీసుకెళ్ళు, అది సరిపోద్దా? వైర్ చూడవచ్చు, లేదా ఆ వైర్ మార్దాం. ఎటు కాదమ్మా, అక్కడికి తీసుకెళ్ళు, ఆ కట్టినప్పటికి వెళ్ళిపోద్ది.
రెడ్డి గారు
ఆడన్నా బాబు, ఎక్కడా ఎక్కడా?
ఓటీలోనే. మీ వాయిస్ బాగా వినపడుతుంది.
వాయిస్తా
మామూలుగా డీజే సౌండ్ వచ్చింది ఇప్పుడు.
బేస్ వచ్చిందా?
లేదు లేదు, బాగుంది, క్లారిటీగా ఉంది వాయిస్.
అదే మరి, దగ్గర మైక్లో పెడితే నువ్వు నోరు వినపడిద్ది అట్నే.
చాలా క్లియర్గా ఉందండి.
ఏంది మీరు తినరా?
తింటే పని చేయలేమండి.
ఓ నాయన, మే పొద్దునుంచి అందుకే టిఫిన్ కూడా చేయలా.
మీరు చేయాలి, మీరు తినాలి, మేము తింటే పని చేయలేం.
మళ్ళీ అది వస్తుంది అది.
హలో,
రావట్లేదు, అదే చెప్పేది. ఇక్కడికి రావాలి కదా, దీంట్లో నుంచి బ్లూటూత్ నుంచి రావాలి కదమ్మా. మాట్లాడు. సాంగ్ వస్తుంది. ఈ ఆడియో ఎక్కడదో. మళ్ళీ కానీ మళ్ళీ ఏమైరమ్మా, అది తీసుకో, అది డిస్ప్లే అటు నుంచి ఇయ్యమ్మా. ఈ వైరు అటు దివు. అర్థం కాల పిల్లగాడికి, అర్థమైందా? దీనికి నువ్వు పైనుంచి వైర్ తీసుకొచ్చి వైర్ ఇవ్వాలి. అందులో తీసి కెమెరా పెట్టు కొత్తగా తీసి అయిన వైరల్ ఆ వైరస్ రెండు తీసుకెళ్ళి పైకి పెట్టా అదే పైన వాళ్ళ ఉందా కలిగి ఉంది అది వైరస్ ఉందా దాని వైర్ ఏమన్నా మీకు మీకు నువ్వు పైకి విలువని తీసుకున్నావు వైరు ఏది అక్కడి నుంచి అదే పైన చెప్తున్నాయని ఒకటి అలవాటు అదే అయితే బాగాలి ఇది టాలెంట్ గురించి పోయిందా అదిగో మోత్కొచ్చి దగ్గర పెట్టు ఆ బయటకి ఎలా ఉంది తిరుపతి ఇంత ఎక్కడ మీద మళ్ళీ పెట్టు ఫాలో పెట్టు దీన్ని జరిగెట్టుకోవచ్చు కదా ఈ మొక్కకి ఇది ఎక్కడ తిరుపతి పై చేసుకో ఈ పైన వేసుకుంటే అక్కడ వెళ్ళి అంటాడు బెల్లిడికే పోయింది అయ్యింది చాలా ఉన్నాయి కదా కుప్పలో తెలిపోయింది ఏదైనా విషయం ఇంతవరకు సరిపోవడం బా
ఇంకో తీసుకెళ్తున్నాను ఇది 95 ఉంది
అవి పని చేయవు కెమెరాకి ఎక్కడ వెళ్తుంది
కెమెరా అది ఆల్రెడీ 2 బ్యాటరీ ఛార్జింగ్ పెట్టాను
ఇది వాడుతున్నావా అది వాడుతున్నావా అదే కదా అవి పడేది లేక పట్టుకోకుండా ఎక్క మాకు ఎప్పుడైనా నేను పడ్డానికి సరిగ్గా వేసుకోమని అదే అన్నట్టు ముందు పక్క ఒక సేఫ్టీ పట్టింది తిను దొరండి
పోయి నెంబర్ పంపించాను Brain combo.
డెడికేషన్ ఆఫ్ వర్క్ అన్ని మనం చేయాలని అనుకుంటే అయ్యే పని చాలా పెట్టారు బట్ వర్క్ సోమవారం వరల్డ్ డ్యూటీ ఉంది కానీ
Yeah, sure, sir. Sure.
2 minutes.
Just sorry for the interruption. I got a call from CM office. Okay, now now we are going outside to the patient. Okay, just see what you should know. The patient has come to the operation theater means our theoretical evaluation over. Theoretical evaluation means pediatrician, cardiologist, neurologist, audiologist, psychiatrist, everything over. We'll admit the patient prior the day of surgery, and also we'll keep the cannula opposite to the ear. If you keep the cannula one side means we are going to operate on the opposite side. We also paint. We'll also paint the head at the side of the surgery, and also we'll make the shaving. You have taken so many precautions during the shaving also. We shouldn't use the blade. If you use the blade, if any scars forms, it leads to infection. That's why we have to use the shaver, and also either 0 or 1 number blade has to be used. After painting the thing and also after over, we'll give antibiotic. Prior antibiotic 1 day, night before 1 dose, also 1 hour prior the surgery. After that, we'll take the patient. We will change the dress for the attendant, also the patient, and also we'll use the drapes for the different colors. See what these colors are, the cement colored drapes, gowns, everything is different for cochlear implantation. Why? Because this is purely depends upon the asepsis. This is a foreign body. We are keeping a foreign body means there are so many issues, formation of the biofilms, infections and all. We have to minimize, prevent all the things to take care of the exposure of the implant to get rid of infections. That's why all are different. The colors are different. Now, after taking the patient, we have to take the patient along with the father. Along with the father only, we'll take him to the operation theater. Why? Because the child, he is unable to hear anything. He doesn't know anything. He's only observing with the eyes. That's why he has so much anxiety. To prevent the anxiety, that is called the separation anxiety. It was clearly seen. My pet also, my pet dog, whenever I leave the house with the suitcase, it was very much depressed. Like that, the child also behave like that. He has to take into the theater along with the father or any one of the parent. After taking into the theater, we have to induct. Induction also on the shoulders of the parent only, just we will give an injection. See, our anesthetist, Dr. Mahesh, is very efficient and senior. We didn't have any problem of these many, more than 500 cochlear implants in my institute in this table. Initially, we have some of the issues. He corrected everything. Just he is inducing the patient. And also one more thing I want to show you. Always you have to use the workstation, if possible, with the ETCO2 monitor. Most of the times we have faced problems with the saturation. Most of saturation probe will show the 100% saturation, but the carbon dioxide will pent up in the lungs. That is called hypercapnia. It creates so many problems during reversal. That's why it is better to have the ETCO2 probe to monitor the CO2 levels. After giving the induction, he has to oxygenate at least 2 to 3 minutes. Pre-oxygenation is very important. Most of the times anesthetists are very hurry. They will take the patient, they put the tube inside without giving proper oxygenation. Because while intubation will take some time, there is enough oxygen should be in the blood. That's why he has to oxygenate. And also, already I have explained the cannula and side. And also we have to arrange the equipment in such a way, the microscope always opposite to the surgery side. Surgeons opposite to the microscope, OT table at the head side, and also the lobby X-rays. While doing the surgery, we shouldn't face any difficulty. The X-ray lobby is visible to the surgeon always. Sometimes while drilling, we have to see the surgical sites. See, I will explain the radiology later on. Now we have seen the positioning of the patient, arrangement of the table. Table also very simpler. No need to have so many equipment. Our assistant, Ms. Srinivas also, he is very much caring, and sometimes he will put more of the equipment. These much are also not required at all. And also see the colors of the drapes and colors of the gowns also are different color, because we'll do normal surgeries, and also my wife is gynecologist. The drapes sometimes mix. That's why to prevent the mixing of the drapes for other surgeries, we always separate everything. Color coded. This color is different because after doing it was fade away, but these colors are the different colors, totally fade away like that.
Raidu, sorry for the interruption.
Sir.
And what are the pre-operative vaccines you had
Yes,
advised before?
the protocol we will cover in the also. Vaccinations always, in these days, the children are given total vaccinations in the vaccination schedule.
Right.
Here we have to take care of the meningococcal and pneumococcal.
Right.
These are the two things.
So it needs to be meningococcal and even pneumococcal. Pneumococcal vaccine as well as meningococcal, right? Yeah.
Hello? Ravi garu, I'm not getting your response.
Yeah. I'm hearing.
Clear?
Yeah.
Vaccines, two vaccines you have to take care. Meningococcal and pneumococcal.
Right.
These are all, I told you now, these are all the foreign bodies. Foreign body. Very big foreign body we are keeping inside the skin. That's why you have to take care for the further infections also. Why? Because the middle ear connected through the insertion tube. The child may get upper respiratory tract infections. The route of entry always goes in the middle ear is insertion tube.
Right.
But to prevent that, at least 2 weeks, after 2 to 3 weeks, the total implant covered by the connective tissue of the patient. The nature is great. It will take care of everything. It creates a total barrier around the implant. Up to the time, we have to take care of the infections. That's why we have to give. In our hospital, our protocol is we'll admit prior day, injection starts antibiotic, and up to 2 to 3 days, we'll keep in the hospital. After third day onwards, we'll switch on to the oral antibiotics.
Does
That is the
it
thing.
requires any speech therapy pre-operatively?
Always speech, not the speech therapy, the conditioning, condition of the baby, because he doesn't know how to wear the process of speech process. That's why we have to use the hearing aid. That is the must. 3 months or 2 months prior training of the kid, and also the parent. Parent should have much responsibility, and also he has to know the total process of therapy. How to bring the patient to the institute, he has to wait for him, and also travel, other expenses. We should know the attitude of the fathers and the parents. By this time, 3 months time, we'll get acquaintance with each other, the surgeon, patient, and also the speech therapist and audiologist. For that is called the conditioning of the patient and the family. The recipient's family should understand the difficulties to bring daily, and also child should wear the hearing aid over the ear. It's also a thing for foreign body, na, he will always take it out and throw away. After the process is the costlier one. The hearing aids we use the cheaper ones. The process is the costlier one. Apart only process costs around 4 lakhs. That's why we have to condition the kid. That is very much important thing. Valid question. We have to condition prior to the taking into the surgery also. After that, he has pre-oxygenation. Sir is going to intubate. For the documentation sake, I have taken a photograph. See, while doing the anesthesia, while doing intubate, always surgeon should be away aside from the patient. Sometimes he needs some minimal help to assist the larynx. I think we are ENT surgeons, we know the anatomy very well, equivalent to the anesthetist. That's why we have to assist. Here you can see tube. And one more important point is always use flexo-metallic tubes. Not only cochlear implantation, open it. Cochlear implantation, and also in during tonsillectomy, it is more useful. This is the flexo-metallic tube. There is no compression at all. We can change the positions also, especially during tonsillectomy. We'll move here and there. Sometimes the blade will kink and pressure applies, and also the ventilation will go reduced. You can see the saturation levels equally on the monitor, but the flow of the air is very low. Mainly expirationary flow will prevent. That causes hypercapnia. That's why we are used to practice these. These are available from how much? 2 size or 2.5? 3 and above, we are getting the bulb with the bulb, flexo-metallic tube. These are all more useful. We are using this one.
The
He
company?
has applied the,
Raidu? May I
Sir.
know what is the company?
sir,
What is the name of the company?
Company.
Flexometallic.
Churan, company is Churan. The basically flexometallic. So many companies are there. Now we are using the Churan. Is very good. It is also not expensive. Costs around only 750 rupees. And also in India, as an Indian, we can reuse it. Okay. We have used that one. And also we have to fix the, are you able to see that one,
Yeah, yeah.
Churan?
Yeah, sure.
We have to fix in any corner of the mouth. Always better to away from the side or the side of the mouth to have the draping. He has applied and secure the airway. Why? Because I said that the movements of the head also important by positioning of the patient. That's why we'll turn here and there. I have the sophisticated OT table. We can have any kind of positions, but most of the times we don't have this one. While starting days also very ordinary 25 to 35,000 table I am using. Now we have upgraded this one. To achieve the proper visual axis, we should have the angles. That's why we should be able to rotate the head here and there.
No, just I want to praise Dr. Mahesh. I think he is the son of Dr. Ravindra Nasris. Raidu? Yeah. Raidu? Hello, Mike? Yeah. Yeah, Raidu?
Sir.
Hello. May I know Dr. Mahesh Padre is Dr. Ravindra sir?
No, sir. Dr. Sahasra garu, Amara Sahasra garu, pathologist,
yeah.
doctor's X-ray. He used to have doctor's X-ray with bias in also premises.
Right.
Now I am explaining the position of the patient. Positioning of the patient. See, this is the table. Always keep flat. See the size of the head and body of the patient. Size of the head is bigger than the body of the patient. If you turn like this, you don't have the parallel position. See my hand. Like this, he has like this only. Are you able to appreciate? Hello? Ravi garu?
Yeah.
See my hand. Now he is like this. We have to make him a straight. Straight, and that is called a neutral position. This movement is called the tilt, upward and downward tilt. This is a flexion and extension. This is a rotation.
Okay.
We have to make these positions. Now we have to bring the patient's head into a neutral position and also always take the.
Yeah. We're able to hear. Carry on.
Hello. Raidu. Hello. Are you able to hear the voice?
Yes, sir. I am able to hear your voice.
Right.
Whenever I'm going for the Bluetooth, you are not getting my voice.
Okay. There must be.
I'm trying to explain with the Bluetooth. Okay, ready? Otherwise,
Mahesh, the tube is carbon dioxide sensor, that this side small tube and the catheter mount, I think. That which you are holding.
This is the side stream
Now-
ETCO2 which we are
Okay.
monitoring the ETCO2.
That will go to the monitor. Okay, right. CT scan.
We have two types of ETCO2 monitor, sir. One
Okay.
is the mainstream ETCO2 and the second one is the side stream ETCO2. This is
Your
the-
voice, keep the mic much closer to your mouth.
this is the
Okay.
side stream ETCO2 which we are using.
Okay.
And our monitor is Mindray monitor.
Okay.
Okay, sir.
Okay.
And you can see on the screen the vitals which we are monitoring are the green one is the pulse rate, ECG, pulse oximetry, NIBP, and the yellow one is the 24. Yellow one is the end-tidal carbon dioxide.
Am I audible?
Yes, we are very much.
Apart from these four, we can monitor the temperature of the patient also if we have the facility. In this monitor, it is there, but we are not using it. That's all.
Okay, now you can see the position of the patient.
Yes.
As much as possible, without falling down, we have to take the edge of the baby to the edge of the table. Now see, to make the neutral position, I am keeping a shoulder bag covering the both shoulders, not one shoulder, on both sides, and also turning the head, rotationary movement, turning the head towards opposite side, away from the surgeon. See, this is the position.
Is that pillow or this? It should be always a round.
Not pillow, sir,
Sheet
it's a
is made
folded
into a
towel.
round pillow. Can we just make it into a flat pillow also?
Flat pillow means sometimes it's maybe larger. Always better to have up to the shoulder blades only, sir. In the pillow also smaller and softer. The main intention, I already told you, na, this the line is the parallel line to the body.
Yes.
The parallel line and also the axis also.
Height of the chest and the operating side of the ear should be parallel.
Yes, sir. Now, this is the position. This is important. This is the neutral position. Now I have rotated opposite side more than 70 to 80 degrees. Now I will infiltrate. Previously, we used to wear the gloves and all, everything for infiltration.
Right, before you are proceeding to the marking and all those things, can you explain the CT of the temporal bone?
I will explain later, sir. After that,
Okay,
the
okay, then,
patient
okay
will go for draping.
Right,
We'll
right.
have the time.
Okay then.
Just I will scrub with my sterilium
Okay,
because we have the palpatory sense also important here.
right.
That's why while infiltrating, I don't wear the glove.
Oh,
Solution. Solution is what we are infiltrating here is the previously Madhu sir told 10 10 10 formula for infiltration. Now we have modified 10 5 10. 10 cc of xylocard. Here one caution is here. Always I'm using xylocard. That is IV preparation. Xylocard. Xylocan contains the preservative. It may cause the allergic reactions. That's why I'm avoiding using that. Since my day one of practice, we are using the xylocard mixed with the 5 drops of adrenaline. Clear. Now I am draping, cleaning posteriorly. Here also one thing, so many small 2.5 gauge needle. After cleaning with the sterilium, always we have to palpate the tip of the mastoid. This is the child age is 2 years, 2 months. He already mastoid tip developed. We have to mark. See, I am pressing with my nail. We got the mark. From here to the, usually I used to do with the C-shaped incision only on the right side. You want a lazius?
right, okay.
Lazius. Usually I use it to practice with the C-shaped incision, just 0.5 to 1 mm, 1 centimeter away from the groove. Here sir asking for the lazius. This is the mark where I kept as a mastoid tip is the lower limit. From lower limb, this is the 2.26 gauge 1.5 inch needle. This is the bevel tip. I will mark just over the skin. I will take a curvy linear incision and also lazy yes towards upward. This is the marker. Why? Because any kind of marker you use in the market, it will fade off after draping. It stays after draping also. We can see easily for the incision site. There, then you can observe all of you, mostly postgraduates. I told you the fascia, post-oral fascia, that is called the extrinsic post-oral fascia. This is also very small needle, 26 gauge, 1.5 inch. Previously, I used the half-inch needle to mark. This is the 1.5 inch. Then you can go just a small poke into the subcutaneous area. Just make a small bleb on it. See. Are you able to appreciate?
Yeah, well.
Just after bleb, this is called hydrodissection. You can push the drug and push the needle towards the tip of the mastoid. I have kept my finger. I shouldn't cross that one. It causes temporary facial paralysis. Like this, we have to infiltrate without taking out the needle. After this, one maneuver needed. Just pull out some out, not totally. Go to the foot end. Go to the foot end. Again, change the direction, giving something. Change the direction of the needle without taking out. Then again, hydrodissection. You can follow my suture line. Just again, above the periosteum, I'm infiltrating, and also the area required to drill out. Receiver drill well. See how beautifully it's coming out, demarcating out. Okay. The total 10 to 12 cc of solution, I will give it. I will infiltrate. See the total projection, the bulge of the injection. Then we have to spread this anesthetic solution within the planes.
Okay.
Okay, just I am compressing this one to spread all over the areas.
Okay.
What I did before washing only, I did this one. Then you can see how less bleeding will be present during surgery. Last case, I didn't use the cautery at all, starting from the incision up to the closure. That is the beauty of the infiltration. You can see this. I have spread everything equally all over the area. Now my assistant will take care. The incision presents up to the draping also to give the clear understanding. Why? Because after giving the infiltration, the landmarks will change. The pinna goes more anteriorly. Sometimes you may reach the groove of the postoral groove. That's why before giving infiltration only, I will mark it.
Okay.
It ends the positioning, infiltration and marking of the patient. Now we'll come to the CT scan. Our assistant will go on draping before come washing. Come over here. Either of chinna needle, chinna marker. Ah, yes. Yes, sir. Unko mic. Ah, it's hard to say. Scan. Already I explained in the morning, CT scan is the roadmap for surgery. Roadmap. MRI gives so much information related to other things. These are both complementary. We should have both.
No,
Surgeons
Raidu, which imagology you prefer to go? CT
Pardon?
or MRI? So all bony areas, they require CT
are
only.
required to decide the implantation candidacy criteria. Both are required, sir.
Okay.
Only one thing gives one information, MRI gives one information. But as a surgeon, for the surgical roadmap, we need CT scan in the OT,
Okay.
not MRI. These are the axial cuts, these are the coronal cuts. See how we practice in our area, very minimal thickness, 0.65 mm thickness CT scan, starting from the top to the bottom, from cranial to caudal end. This is called the bird eye view. Bird eye view. I think the radiology will cover later. First, main salient point I will explain. While coming from upside downwards, first we will come across with the superior semicircular canal. It is divided into two. This is the cobra head appearance. Then this is the
Raidu, your voice seemed to be a bit low.
subarachnoid
Try to
artery.
Yeah.
Subarachnoid artery. These are the two superior semicircular canal. After later on, come down one. The main, after getting the CT, what I will see is, I will show to you easily. This is the axis.
Yes, yes. You
See,
make a much closer.
Clearly.
The magnified
Are you
view.
able to see clearly, sir?
Yeah.
This
Yeah,
is
yeah.
the round niche, round window niche. That is the superior part. This is the mastoid. Through the mastoid, in the posterior opening, we are entering with the middle ear. With a small opening, it's very good, well-aided mastoid, well-aided air cells. You can easily go off this one. This is the posterior wall of the mesotympanum. This is the posterior wall. Posterior wall contains so many structures. It is the bony wall developed from the Richter's cartilage. The rest of the bone is the Peter's
Yeah.
part. This
Yeah,
is the
yeah,
Richter's
yeah,
cartilage.
just-
That is branchial arteries. It develops from them. That is a thyroid complex that is called. Here we can easily enter into the mesotympanum through this posterior tympanotomy. I will assess if you have this one, we can do easily cochlear implantation. There is no hinders and obstacles. We can drill here, we can daily reach and here also. This is the facial nerve complex. The facial nerve lies posterolateral to the pyramid.
Is it visible there?
This is the pyramid and stapedius muscle.
Is the facial nerve visible?
Facial nerve clearly visible, sir. This is the facial nerve. I can show you the facial nerve starting from the starting point. We are operating in the right side now. You can come across, you can see here, you can see this is the internal artery canal. The part of the facial nerve is geniculate ganglion. See this one.
Yes.
After this cut, you can see this facial nerve parallel to the tensor tympani muscle. Then you can come, this is the lateral semicircular canal. It's going below the dome of the lateral semicircular canal. Again, this is the facial nerve part. You can see clearly parallel to the body of incus. Then it comes to the posterior wall. This is the facial nerve. The cell also clearly visible. Then this is the facial nerve. This is the pyramid, stapedius muscle. The posterolaterally is the facial nerve. Sometimes you can see the cauda tympani nerve also here. This is the cauda tympani nerve. Branching lower levels. This is the lower parts. Like that, we have to see. This is the axial cuts. In the coronal cuts also, we can see the facial nerve easily. This is the swan neck appearance. This is the lateral semicircular canal, superior semicircular canal. Just like a small eye-like thing, we can find out the facial nerve. Here we can see this is the facial nerve. This also trajectory can easily reach. Where here, this is the less like operculum, reversed kuja laga untadi ikkada. Basal turn of cochlea, reversed. You can see we have to reach here to introduce the electrode. This is about the CT. We can discuss entire CT and radiology in a separate session. These are the required things. This is a well aerated mastoid. You can see this one, and also reconstructed ossicles also you can see clearly. This is about the radiology. The positioning also, my stent also draped well. Here you have to see the draping, how we do. Sir, will you do the draping? Or we can do the. Yes. Just give the gloves.
You want to do the wrapping? Yes, yes.
So what are the solutions used? Betadine, Savlon, Spirit? Hello, Raidu? Hello?
1 minute. 1 minute, sir. Without your sizing. Yes, I want to show the draping also. That's why I'm wearing the gowns only, not the gown. Gowns. Always. Sepsis is the major enemy for us. That's why you have to take care of everything. Now, use the plenty of towels. All are tailor-made small towels. We don't use the routine towels, small towels. Ready prepared for the surgery. Cochlear implant surgery. We can assistant will hold the head upwards without touching the area. Just keep a towel in 2 layers. Just take care of one fold upwards, and second is in this direction, exposing the ear only. Next, the other towels, just square like area we have.
Is there any need to monitor the facial nerve pitches
Fix this,
when you uncover the eyes and mouth also?
Sir?
Would like to watch the facial twitchings.
No,
facial nerve twitching. No need of it.
Because of the experience and everything.
Probably because of experience only.
We should have facial nerve monitor and everything.
Oh.
We don't have that. Now I am draping.
No, facial
Just
nerve
we have to
monitor.
square this.
Raidu.
Sir.
So Krishnan Rao is telling that as per the government norms, facial nerve monitors are required.
Yes, not only government norms, facial nerve, theater, cautery, and also laser. I don't know why they put the laser also. Should have the laser. That's why I am 10 years away from that cochlear implantation. At the time of starting procedure, we have to invest more than 1 crore to get everything. I don't have that much amount at that time. That's why 10 years, 1 decade away from the cochlear implantation. That's why those are all not required at all. Every center are doing. Now, I want to mention about the special drape. This is the self-adhesive drape. I have folded the article anteriorly. Just paste it and remove it. You will have the beautiful area of coverage. I didn't use the towel clips. Just I have draped everything and applied this one. Why? Because after draping only we have to apply this one. Before you apply, the towels will move on here and there. It causes disturbance, and also it comes onto the field. Now this is the field. This is the position. Now I'm hand over to the Anand to start. Thank you. Thank you.
Right. Well demonstrated.
Able to hear me?
Yeah.
So almost Raidu finished everything. He won't allow me to do anything. No. It's really happy to see all these things. So from infiltration, wrapping, everything is taking care, the position. So we have a lot of juniors. Actually, the final part only we will come, but he's showing everything. So I've learned a lot of things from him today. So thing is, I'm going to demonstrate my technique, but it's not my technique. It's always everywhere. Everyone is practicing the same technique. Okay. So this is very clear. Almost this is taking care of this auricle. Actually, otherwise we go to pull the auricle and we go to put a stage suture. So this is very clear. It's okay. You are very. You have to raise the table. It's okay. Okay. My voice is clear.
No, not yet. Still, it needs a little bit.
Pardon, sir?
No, still it needs a little bit louder.
Louder, okay,
Yeah.
okay, I think, yeah. So the incision, actually, you know that the postauricular incision, there's a lot of type of incision is there. One is lacy S, one is C, another is actually, so one is straight incision. So nowadays, a lot of people are, according to their convenience, they're practicing a lot of incision. So but lacy S, for beginners, the lacy S is one of the very useful techniques. So we got to start from the mastoid tip and goes up to this level. Then again, the laziest, actually, suppose you make a very acute turn, the chance of infection is very common. This incision should avoid from the inner incision, actually. So the two incision not in the same line. So to avoid the post-operative skin flap necrosis or any infection. Actually, that is very important. So another 1 minute we'll start.
Yes.
So not like, I don't know why Raidu is against cautery, but I'm the cautery lover. So if there is any bleeding, definitely I use cautery. So he's totally against cautery.
It needs publication regarding the using of cautery and non-using of the cautery.
Okay, right.
Publication is near.
Yeah.
Yeah.
Understand. Yeah, perfect. Yeah, yeah, okay.
So it's better to use the cautery only.
So now we are going to make an incision. Yeah, so I want to put
Right.
towel, but it's okay. It's always a little difficult in operating in a new setup, but this setup looks so it's more practical. Yeah. So 22 blade. So okay, it's okay, no problem. So you have a pen.
రాజు సార్ అది థిన్ ఫిల్మ్ కవర్ చేశారా లేకపోతే
So because of our experience nowadays, we
Draping
won't
low.
mark like this thing. Normally, this is the postauricular sulcus. So always, were a lot of actually now there's a lot of kids actually they used to come the receiver bed is somewhere like this, but this is actually aesthetically is unacceptable. Always it must be here is actually under the hairline actually, so it's not visible nowadays. Actually lost the single unit processor available, so it's almost completely actually not visible under the hair actually. So that's why we have to plan. So not over here, so exactly over here. That's why this template is there for PG purpose, postgraduate purpose. Yeah. So we are doing on right side. Okay, so to mark it here, so your be like this. So your position of your this receiver coil must be over here. Okay, the incision we're going to make lacy yes. So always avoid the acute angle over here. Suppose if there is any acute angle, definitely there is a chance of infection is more post-operatively. So and the another thing is, so nowadays a lot of doctors are doing a single incision technique. Actually, they won't prefer any flap. Actually, just okay. You want under microscope? Is this okay? Very clear.
Under microscope is better because the
Better?
light reflection it makes a little bit
Okay,
more
okay.
brighter
So
and glaring.
use a microscope.
Yeah, top light a little bit angulation here, but
You can use a 15 number blade. So little depth like this.
Dr. Anand,
Yeah.
can you make the light angulation little bit so that the glaring will be avoided?
Okay.
If you are okay, you continue.
Okay,
Otherwise,
we
you
are
can use
changing the microscope. Just wait, sir, and
Yeah.
also we'll change the angle.
Yeah, yeah.
Okay, it's
Right.
clear?
Okay.
Okay, we can continue, sir. So just for you.
It's a little again, little back.
Yeah, no, it's okay. Raidu,
Sir,
may I know what is the microscope you are using?
we are using the Leica, sir. Leica 320.
Can you remove the mic spec?
Like a model?
320, M320.
M320.
Light on.
This is the simple and compact model, sir. Very simple head.
Okay.
For an ENT surgeons require the very lesser size of head. Why? Because we have to see here and there and up all the areas. For some of the bigger microscopes will hinder the view of the patient.
Yeah, 5 years back when I attended your first cochlear implant surgery, in the beginning you called me. You use a Sanma microscope only.
Yes, under Sanma we have completed 200 implants. But the not the microscope, the brain. Brain is the main thing.
Yeah.
We should know anatomy very well.
Right.
Then only we can operate with anything. Just like cars. Nowadays we are using Maruti and also we can drive the bench. So changing from Maruti to the bench means we are getting so much sophistication, but we should learn everything
The driver.
to handle.
So once the infiltration is very good, so we can easily elevate the flaps. So
What is see the movement of SARS knife?
So one of the audience is asking about the what is the price of that Leica microscope 320.
Microscope at the time I bought around 15 lakhs.
is now is 24 lakhs with the inbuilt camera.
Camera, this one.
And the recording facilities is now 24 lakhs.
HD. See the HD prompt is coming there. Now it is come with the 4K. 4K microscope available. All the postgraduates see how not seeing the surgery is greatness. How to handle the instruments also. How nicely sir using the knife to make a flaps, delineating the layers. Sir, speak yourself.
Yeah. That's why actually he won't allow us to feel. Yes. Okay.
The habit
That's why. Sir.
of my microphone.
Normally I use what is the power? So reduce the power. So, monopolar. What is 20 is okay.
20. Maybe 40.
So doing under microscope little difficult. It's also possible using a coagulation mode, not in the cutting mode. So reduce the power in 20, you can elevate easily. It's all time consuming procedure. So,
Raidu. Yeah, some surgeons they prefer to use the microscope, or some of the surgeons they may not acquire microscope for certain field. That means a certain exposure.
Sir. Because exposure, sir, we have to acutize for each and everything.
Yeah,
everyone.
Dr. Anand feels difficult with the microscope, I think so.
Because Anand trained in the bigger institute, sir, and also bigger setups.
so not like that, sir. Actually,
the high-end equipment.
whenever actually Mohan used to, so he asked me only one question actually. So you are going to buy a Mercedes-Benz or microscope? So like this actually. So he initial days. So without a proper instrument, don't do anything actually.
Sir, it's always a challenge, sir, whether ENT surgeon they can purchase the properties or equipment or cars compared to the anesthetists and other surgeons. Because ENT investment is always, it will be sky high. So it needs a lot of instrumentation at the beginning phase.
Central.
I don't know. It's scissors.
Yes, very good, sir.
I think I can use a headlight. You can focus like this. Hmm. 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 Yes. Give me my specs.
The microscope needed to be centered. Raidu, are you able to hear?
Yes, sir. Yes, sir. Ask me.
Yeah, it needs to centralize microscope.
You can ask sir, sir. No, ask sir directly.
Yeah, Dr. Anand.
Yeah. Yes, sir.
The microscope needed to be centered.
Microscope.
It needs to be centered in the field. Image.
It's okay.
Yeah, center picture. Yeah.
Why, image is clear?
Now still little bit focus.
It's
Yeah.
okay.
Yeah, it's okay now. It's good.
Okay, right. So actually, I'm not using the microscope for elevation. Actually, the depth perception is little.
Yeah, it's a little bit difficult.
So that's why.
So in PAP also, Excel camera in PAP.
So the flap elevation is very important. Suppose the flap is very thin, that is also a great problem. So before going into this thing, you go to assess the skin thickness. Suppose skin thickness is, there is a separate gauge is there. So for pediatric age groups, no problem. Suppose, so it's adult as well as some chubby child, the skin thickness is very thick. We have to reduce this also. It's, they have it actually. You got to assess this thing. Here is okay. Suppose it's more than that, definitely we have to reduce the thickness of the skin also. Otherwise, your external implant won't stick properly. So we have to increase the magnet strength actually. The only problem with the magnet strength is the chance of post-operative pain actually. Sometimes a lot of you able to encounter a lot of kids used to come with redness over the implant area. So we have to reduce the magnet at that time actually. Normally the flap actually I won't use a post-auricular follow flap like Raidu I used to elevate superior based flap always.
Okay.
Yeah, you want to flap? You want to live? So then okay, then I will do one thing. Ask me to take a two flap. This is the Mastoid tip actually. So no. The only problem is sometimes this is not a vein. The emissary vein is a real troublesome. Okay. Now it's increased. Increase the coagulation little bit. Yes. So always I used to make a horizontal cut from, okay, 1 second. So can I have Alice? Alice? You have Alice? No? No problem. Otherwise better but take Alice is a better. Okay. One more. Otherwise you go by stay switcher 10. Silk. Yeah, it's there, no? Give me. Check this out. Like I do tell, the exposure is very important. Suppose you feel little this thing, you can stitch the posterior flap to your drape actually. So then it won't come inside. Like this, you can easily tooth process. Hold there. So. Yes.
సార్ సార్ కాక్లియర్ ఇంప్లాంట్ గుంటూరులో ఉన్నాను. వాట్ వర్క్ సార్?
So
రేపు మార్నింగ్
people have,
వచ్చేస్తాను సార్. చెప్పండి సార్.
please ask some question, then only it will be live actually. Otherwise,
అవును, వరల్డ్ హియరింగ్ డే ఉంది సార్. అది మనకి
well, I've already tried to explain everything.
ఎగ్జామ్స్ వచ్చాయి.
So why do you using expensive retractors? I am using only silk to retract actually. Is very.
Sir, Anand sir, how to select the layers for these layers?
Layers.
Wow, what are the flaps? How will you select?
It's all so tailor-made, sir. Actually, he told no. There is a first you actually there's a skin flap, then the musculoperiosteal, then up to the only periosteum flap is there. So you can make a two flap. So normally I won't take my two flap. I will usually make only one flap. It's the inferior and superior base. Inferior incision, superior base flap is completely cover the implant. So there'll be no the skin suture line won't come in the normal external line. Actually, it's always will be in the down. It's only one line close to this area. So I make a vertical horizontal incision over here and one incision over here. I will elevate like this. It's a posterior superior base flap. I will show you next. I used to make like this up to the bone depth and one horizontal incision here. Always here our so now the tooth forces. Elevated. Little difficult always over here. It's a very adherent. Once elevate, it will like it's like a banana. It will go very easily. The incision lines should be very deep. Elevated. Sometimes difficult. I used to elevate this. Yeah. Yes. Yes. Now you have to make a periosteal pocket for your this thing. Where is the template? So I was using a knife actually, so this is not correct actually. So you can use a 15 blade. This here. So like easily because of the infiltration, so we can elevate the periosteal pocket very clearly. But don't lot of surgeons actually juniors they are making it a huge periosteal pocket. This huge periosteal pocket is not advisable. Only actually this template snugly fitting periosteal pocket is enough. Suppose you are making very loose periosteal pocket, post-operatively I used to see a lot of cases coming with actually anteriorly displaced, I mean posteriorly displaced this thing. That's why. So make a snugly fitting periosteal pocket. See, as well as position also very important. Suppose very anterior is not acceptable. So this is a little bit posterior placed. Okay, this is a ideal position as well as the mastoid cavity must be here. Gospel. Okay.
Anand sir, can you show me the landmark for the pocket, supramastoid crest and other thing?
Yeah, I will show you. I will show you. This is elevator. So you have to elevate. Is our posterior canal wall. So this is a supramastoid crest. Always your pocket must be above the supramastoid crest. So this is a tight attachment over here actually. Don't elevate below this level. Suppose you elevate below this level, the chance of posterior dislocation is very common.
Okay.
Sometimes actually it may be dislocated and landed in very deep actually. So this tight attachment, don't lose it actually. So this elevate this periostal pocket just above this, as well as don't go very anteriorly also. Just this direction is so it's enough actually. This direction is enough, and so keep this flap, and this flap also you can stitch with the silk. Take a bite and almost less instrument. So only 2 or 3 silks, that's all. Now, so our mastoid drilling, actually this is a mastoid tip. So this is a supramastoid crest. This is where periostal pocket. So this is where posterior canal wall is very tight attachment is there. So you can elevate the attachment over here. Don't elevate too much actually. So you can see the tip as well as the Henley spine. Okay, this is the area. Okay, so there is a little bleeding posteriorly. Okay, now we'll go for the drilling part. Actually, so far any doubt actually? So I'm actually not explaining everything because Rai to explain everything very clearly. So now cutting. They'll still come. Okay. So always, where is the drill? Here. I have it down actually. So I'm what? Yeah, same. I don't want to stick those.
Regarding one point, drills also. Drills we are using, one drill is NSK. This is only the costlier one, cost around 1 lakh.
Drill is
Another is the Incision, around 40,000.
Is a drill.
Previously, they have prescribed the drills, Benner drills. Those are all mostly costlier things, more than 7 lakhs. But I didn't use that in my hospital.
So keep the like this.
Subbarayudu sir, what is the size of the drill you are using now? Burr
The
bit.
burr or drill?
Burr bit.
No, this is a burr bit is a bigger size, is around I think so 5 number.
5 number.
Probably 5 actually. So I normally not like Raidu. I start with the normal routine irrigation here, and another line is here, another here. So then I'll drill like this. It's all cellular mastoid. Normally, sometimes I used to collect the bone dust actually to fill the cavity, sometimes to full cover the electrodes. My voice is clear or not clear?
Oh, it is clear.
Yeah. So you can use a little bit elevator. I will into the plan. No. So retracted. Some retracted. What's the retractor?
For the sake of the posters, can you show me the spine of Henley there, sir?
Yes, so spine of Henley is here.
Yeah.
Spine of Henley is here. Okay. This is a mastoid tip actually. This is a supramastoid line. So sometime actually you're able to see able to feel some translucent area. The small person. Small person. Like a thing. Just look. Just a little bit. Right, go this way. Yeah. This one is. Okay. Yeah. Solve cellular mastoid, so we can finish the work very easily. Oh my God. It's very long, no? So, used to the high sophisticated. Medium size? Medium size, no, okay, that's okay. Go to the microscope.
Regarding the gloves, what we are using the non-powdered gloves, the thin gloves. Why we should have the palpatory sensation? As an ENT surgeon, here we should have the palpatory sensation. That's why we used the thin gloves and also non-powder gloves. The powder may cause as a foreign body reaction. That's why always in cochlear implantation, we use non-powder gloves only.
Center the drilling area.
Pardon?
Center the drilling area.
Area and center. Yes, sir.
Okay.
Okay. And also, as a surgeon, we should have all the senses are working in a proper way. We see the sound of the burr. Why? Because the burr going from one place to another place, from one area to another area, the sound will vary. It's drilling on the bone, drilling on the vascular structure, drilling on the neural structure. The sound should change. That's why below we have to identify.
Mastoid, actually, so once you're able to see the antrum, then you can widen up to the additus level. Actually. Once you're able to see the incus, so there's two ways of schooling. Actually, one actually create a very big mastoid cavity to keep the arc electrode inside. In another way, Raidu told actually very small cavity, so as well as keep the electrode, make a 2 or 3 coil and keep it inside. So I always used to make a big cavity, a top light forward, switch off the top light and take out my specs. And the picture is clear, microscope picture?
Yes, sir.
Okay. And reducing the posterior canal wall, make it very thin actually, like normal cortical mastodectomy, because actually sometimes for angulation, this very thick posterior canal wall obstructing your vision of the posterior tympanotomy. That's why, like you saw, Raidu use some instrument to fracture the posterior canal wall and push it anteriorly. So that's why make it very thin. Is it clear?
It's clear.
Yeah. Okay. So now I'm working towards the mastoid auditors.
Pass on questions from delegates and post graduates. Any questions? Any doubts?
So and widen the mastoid. Always this angle is important because actually always you are this angle of insertion is like this. Always that's why. So reduce the tip as much. And irrigation is important. Sometimes we used to collect the bone dust. I told you, so we collect the bone dust to cover the electrodes post-operatively. Okay, now this part is okay. Then we'll turn little bit that side. So if possible, turn the head towards anesthesia machine. Tilt towards. Yeah. So this is the advantage of having luxurious machine. So I am increasing the dimension now. Okay. Still I'm not able to see. Hmm. Yeah. Tilt towards user. I need a small bird. Is enough, sir? So microscope picture is clear?
It's clear. Just
Clear.
a focus.
Little focus you need?
Now it is okay.
It's okay now?
It's
Okay,
okay
right.
now.
Small bird. Yes, okay. Okay. So this ridge, we got to take it out. Water.
What is the high power view you are using now?
Pardon, sir?
High power view.
Power.
Power.
Microscope power.
Magnification.
What is that? So voice is not clear.
Magnification.
Magnification.
Yes.
One
10x
second, sir, I will
above.
tell you. So, power 16.
16.
So that's why you have to keep on take it out and you keep on put again. So that's why I used to always prefer suture as well as some skin hooks actually to retract the skin as well as the flap.
I hope all the famous ear surgeons, they might have changing the master retractor every 2-3 months, because whatever the cost it may be, but still again it will go. The blade and the what slotters, they will go, and there is a failure of retraction with the master retractors. Every time you have to use this new master retractors.
So it's nothing will come inside. Actually, you can use it, use your do your surgery very peacefully. Keep on changing your master retractor. It will waste of time as well as sometime very difficult. Suppose not central, let me know, sir. The picture is not clear. Let me know.
Okay.
So now I am
Okay.
reducing and going to see the incus. Yeah. Thanks. Thanks. What? Okay. Small bit.
Does it need much thinning of the posterior wall?
Yes, a lot of air cell. So, no, what I'm asking, so.
Thinning of the posterior wall.
Yeah, yeah. So it's needed. Sometimes actually I used to thin, otherwise sometimes post-operatively, not post-operatively, during your insertion, sometimes you have to reduce as well as you have to fracture the posterior canal wall.
Oh.
So thinning sometimes is really useful to, at that time actually insertion, you can easily break it.
Try to avoid that the drilling which we are drilling in the
Sir,
sciatic
I'm
area.
not able to hear. Voice is not clear, no?
Is my voice is not clear?
Not clear. That's why I'm not able to.
Again?
Yeah, now it's clear.
Okay. So here in the dissection in the Tegman antri.
Yeah.
Tegman antri. Here where you are sucking just near to the altar. So why do you try to keep that? Yeah, that bone, that
Which one?
area.
Here.
Yeah.
No, that's why this depends upon surgeon. I won't keep it actually. I will use to sometime use a Royd technique. Royd inserted actually there's little bit of electrode inside the incus also.
Okay.
So it will actually obscure the aeration. Definitely the chance of getting post-operative infection is very common.
Okay.
So always we have to keep the adductors free.
Mhm.
So otherwise these guys are growing actually, they used to develop actually eustachian tube dysfunction, a lot of cold and these things. Suppose any foreign body in the adductors obstruct the airway, definitely leads to this infection. That's why I always keep the adductors free.
Right.
So we're not able to see the incus so far. It's very deep. Yeah, now able to see it little bit. Now air cell.
Almost like a simple cortical mastodectomy. Hello, Anand.
Yes, sir.
Almost the drilling is like a simple cortical mastodectomy.
Yes, sir. Yes.
Exactly.
It's a little bit towards you, sir. Another small bit. Another small bit. It's clear, right?
Everything clear. Everything
Small.
clear. Perfect. Like my hands also working outside.
He's waiting. He's giving a talk or sorry?
Not 3:30 start.
Yeah, okay. So what is the time now?
Reach there.
No, I will finish it actually. Little bit towards user. Retract them. Tilt towards. Okay. So now everyone able to see the round in case?
Yeah. No, it needs focus. Much.
It's now clear. Okay. So clear, no?
Still not clear. Oozing there.
One second, I will adjust my eye field. Not able. One second, hold it, hold it. So. Yes. Switch off the light.
Because కనిపిస్తుంది అలా వ్యూ రాలా.
It's a small mastoid cavity actually. So, picture is clear.
Oh, it's clear, but Inca's not seen that.
It's not seen very well. Able
Yeah.
to see now?
No, little bit.
Now?
Needs magnification and fine focus.
Okay, 1 second.
Yeah. He cannot see that.
Okay.
Little bit hidden, right? Okay now.
So that's the incus.
But it needs fine focus
Yes, 1 second.
to make a difference of the bone
Now?
from the Incus.
Now. Yeah, keep on asking. Focus, focus, focus.
Now we are able to see nicely.
That's fine. So. No, the same microscope. It's okay?
Okay.
Okay, yeah, clear. They're asking, so I need a little bit smaller, otherwise, okay, I will see. It's a cutting, a small cutting. Small cutting. Yeah, it's okay. It's only this one, no angle handpiece.
Angle handpiece is there, sir.
Okay. No, not now. So now now we are planning posterior tympanotomy now.
Right.
Already mastered it. So this is the fossa incudius. So this is our actually dome of our latest encephalic canal. So this is the posterior canal wall. So this is the area of facial now. This is the area of facial now. Always draw a line, straight line from the fossa incudius, thought process of incus, go straight towards the mastoid tip. Able to see the perifacial cell?
Yeah.
This is the perifacial cell. Once you're able to open the cell, we're able to, so give a pick, straight pick. This is a cell.
What is that?
This is a perifacial cell. Able
Okay.
to see? Once you're able to see this cell, now you're able to see this. Put a water, put a water. Now I am putting my suction over here. Able to see?
Postgraduates, please look for the perifacial cells.
So always look for this perifacial cell. So very clear. Once you're able to see the perifacial cell, widen the perifacial cell.
Sir, is it called as Herald cell?
Pardon?
Yes, sir. Yes, sir.
Herald cell?
Herald cell.
Herald cell. Yeah, same one.
Yes.
Same. Yeah, same. Already.
One saying is that is a posterolateral extension of the
Now this
facial
is big
recess.
one. So you have to change the small burr. Little bit small burr. Once you go anterior, definitely you injure the cara. Once you come posterior, definitely you injure the facial now. So always, so it must be small one.
Without having any fear, you can directly go into the
mesotympanum
with that cell.
cell. Yeah. Straight perpendicular down, you enter the middle ear.
No, is the perifacial cell is seen in all cases and certain cases only.
Almost all 90% of cases you're able to find out in normal anatomy.
Oh.
So widen you can enlarge the perifacial cell.
You can see that cell in the radiology also, sir. The wave path also we can see in the CT.
Still you are using cutting burr here?
Yes,
Anand?
yes, sir.
Are
Cutting
you
burr.
using cutting burr?
Yes, sir. Cutting burr.
Yeah.
Now you can go perpendicular.
So what is the
down.
size of the cutting burr you are using?
What is the size for?
Anand?
One is a 1.5, I think so. 1.5 is not a,
Okay.
so 1.5, 1.2.
Can you define the again facial nerve anatomy there? The vertical part?
This is actually semicircular dome.
Yeah.
This is the fossa inculatus. Always facial nerve comes and goes like this.
Okay.
So this is the facial nerve area. Okay. So this is a cardiac tympani. So you can drill straight away down, perpendicular down.
Okay.
So can have a small suction. So normally we have to use a contangular handpiece over here, but still we are using a straight handpiece. Yeah, better. Okay. And it has small burr also. No, the thing is actually suppose poor surgeon we can start a cochlear implant. I'm not saying no, but suppose you go with facilities, buying a car, buying a house is not important. Buying an instrument is very important actually. That's why I used to tell actually my junior. So I have a fellowship, my 4 juniors are working with me. So I used to tell them, suppose you want to invest in a car, so no, it's not ideal. Invest in your, it's not going. It's not going. So okay, you can use a straight handpiece. So instead of buying a house, so instead of buying a car, better you buy a instrument. Definitely you can buy more than 5, 6 cars and buy 6 houses. So precise is important actually. So you can do a surgery, you can master, you can be a very good surgeon, everything, but even a single complication can spoil your whole name. That's why actually suppose really needed, you can invest in very good instrument. I'm not telling no. But actually with the cochlear implant is not we discussed, no, Royd also told very clearly, is not a very, Himalayan surgery, everyone can do with a simple instrument actually. It's a little big burr actually, but it's okay. Hello, I need a small burr. It's a big one. Where I had to open? Yes, okay. A small burr with the long soft. This soft must be soft little bit. One thing I want to show you, this burr actually, so this is a very small one, but this soft is actually, the thickness is width is very big actually. You can't use this burr.
Can you magnify that? Can you
This not like
magnify
a
that burr?
skater actually only
Hello,
the.
Anand. Can you magnify that burr?
Yes.
Under microscope, can you focus, make a fine focus of that? Okay. Right.
Yeah. This burr actually, scream a tip. Pick. So able to see the difference, no? Actually, so see the difference between two burr.
So still, it needs much focus. Yeah.
Now?
No, still.
No.
Yeah, it's okay. The right side is the diamond bar and left
Yeah,
is
this
cutting.
diamond burr, this is a cutting burr. See the width of the soft actually. So
Right.
now the cavity posterior tympanotomy is very small. Suppose you use this type of burr actually. So this soft can injure the facial now. So last case actually little bit facial bulge because of this soft injury. Suppose you use a very thin and elongated burr. So it will actually we can save the even little bit injury to the lateral wall as well as the medial wall. But even exposing the facial nerve is not this thing, because a lot of our European colleagues actually they used to expose complete facial nerve. Sometimes they
displace the facial nerve and then they're entering the posterior tympanotomy to see the round window. They used to see the round window very clearly, completely. They opened the posterior tympanotomy, very extensive posterior tympanotomy. Then after that, they will entering into the round window. So, but we are doing actually limited posterior tympanotomy. So this selection of burr is also very important actually. The thick, soft definitely injure the lateral wall. This is very thin, soft, as well as the width of the soft of the burr is also very important. Suppose you are doing with the conventional burr. Okay. So now we almost enter the middle ear. Water pump? Water. Can I guess a small section? Yeah, small section. I'm enlarging my posterior tympanotomy to expose the round window. Small section pump. What you are seeing is a incudostepedial joint. State, are you able to see some movement? No, it's an incudostepedial joint. So you have to come inferiorly to expose the round window. So little bit tilt your microscope and so come inferiorly. Once you're able to see the incudostepedial joint, you can actually easily drill downwards and see the round window very clearly. Sometimes actually you open the perifacial cell, we're able to see the round window very clearly without any difficulty. It all depends upon the anatomy. All this middle ear mucosa. Yeah. So here, so what you have to do is you have to rotate the head a little bit towards you. Yeah. Now rotate the head towards me.
The IS joint is already in the view, I think, Anand.
Yes, sir. Yes, sir. So rotate towards me. Yeah. Right. Yes. Center. No. Clear?
Yeah, clear.
Yeah. Now, so come little bit posterior as well as inferior. You able to see that? Like, can I get a straight?
There is a small depression like fluid collection just below the IS joint.
Yes.
That may be the area of the round window niche.
Maybe, sir. So, because of this thing, so I'm enlarging the posterior tympanotomy.
Maybe out of subject, but I always get very surprised. Most probably in 16th century, where the great anatomists from Europe, they excavated buried bodies in thousands. And even with, you are magnifying at almost 1.6 means 16 times magnification, and we are finding difficulty to know what is a round window, what is this thing.
Yes.
16th century, no electricity, no bursts, no magnification, no light, no equipment, but they have traced the greater superficial petrosal. lesser superficial petrosal, auriculotemporal, round window, oval window, utricle, saccule, vestibule. I don't know. Really great people. We doing all these things is okay. Anatomists, the main why we are doing all these procedures is because of anatomical dissection. You are going very low down. Is it necessary?
Yes, sir. Actually,
Okay, right.
able to see, no, now.
Now, I think I was a bit confused. The
yes, yes.
depression of the oval window,
Yes.
and there was a fluid. There
Very
is a bit
low, actually.
distance is also more here.
More here.
From incudostepedial joint to the round window niche,
It's a
there
very
is a
inferiorly
bit
placed.
more distance. From here, I think everybody are seeing this is the time and this is the area where if there is facial nerve after its second genuine vertical segment and travel are getting prone for injury or whatever it may be. Even you may not be able to see at this juncture, but something with a burr tip, if you feel like something I'm touching, a soft one, not a hard substance, we have to first think that it is a facial canal. Now see how the angulation of the right hand. Anand is going in a almost like 45 degrees angle and drilling and keeping the everything in his view. This is certainly a bit longer distance of
Yes, sir.
exposure.
Actually,
Not
it's
as
very
usual, not as a
inferiorly
routine.
placed.
Yes, now we are slowly getting, yes. See that round nebula shaped dark circumferential visual finding is round window. That's all.
Yeah. Able to see now?
Yeah. Sometimes it may confuse the hypotympanum cell in the same dimension. Sometimes you see a dark hole.
Yeah.
When-
No, there's two ways there. Once, suppose you find difficulty in down window, better always look for an incrocipedial joint. Once incrocipedial joint you're able to see, then
Yes.
drill downwards, definitely you're able to land in a round window only.
Right.
A lot of our juniors straight away looking for the round window. Definitely they can't see the round window. So that's why.
Can you center Anand? We are totally missed the picture.
Yes, sir. Yes. Yes, sir. Sorry.
Yeah.
Able to see the round
So
window?
first identifiable in posterior tympanotomy is your IS joint. You have to identify. Then only you have to search for round window.
I think it's probably my pen. Now it's okay? It's clear? Okay. Yeah, okay. Yeah, now it's very clear. No? Okay.
Very beautiful visualization of round window.
Actually, 25th February is a World Cochlear Implant Day.
Implant Day, yes.
And 3rd March is World Hearing Day.
Now, so we'll compare.
So these two are
Keep
for a year.
Can I drill? So here actually, so the periosteal pocket is very strong. So keep a template.
So what Anand? Periosteal?
Pocket is, I
Yeah,
made a
yeah,
periosteal
okay.
pocket is very, so keep it there, gel foam over there. Yeah. So here
So
I'm not going to drill
you
any.
just identified the round window area and you just stop shop there.
Yes.
You
Now I'm
don't do
going to,
any widening of round window niche and all these things.
Not now, sir, actually,
now,
because actually I'm going to create a bed for the implant.
Yes.
Yeah. So two-way, now actually this suppose is very tight. So just we are fixing the implant alone, so without making any drill.
Okay.
Here I used to see, so it's not protruding outside the skin. The skin thickness is adequate, so I'm not going to drill any major bed for the implant. I'm going to drill only a small this thing as well as for the, so this for electrode.
Okay. So what you mean, you don't want to make a almost a 2 centimeter square
Yes, yes. I'm
bony
not going to
pit,
give a
you don't
big,
make
this
osseous
thing.
pit.
I'm not going to get a small this thing to avoid the implant come forward, as well as for the electrode. I'm going to make a drill and gutter for the electrode. After actually I place the electrode, I used to cover the gutter with the bone wax actually.
Okay,
So the
okay.
bone wax will hold the electrode inside. Actually, it won't allow to the implant move, as well as not like Raido. I used to always make a periosteal stitch to hold the implant, this thing. So
But all these years, the osseous pit is made to make the implant not to migrate or
Migrate,
move all around and stick over there.
Yes.
But
Nowadays-
if the thickness of the periosteal flap is good, you mean you need not make a pit at all?
Yes, actually, no, not
Right.
necessary. Actually, this periosteal pocket is a very thick one.
Okay,
So
right.
it won't actually allow the implant to migrate actually. So give me the. Okay.
I think all of the delegates should make it a point. The days are going to come. You'll be just taking like your visiting card in your pocket and put it there. So the same way the implants are going to become thinner. Pass your client's septal elevator and just push like a visiting card into the subperiosteal tunnel and put the electrode and come out maybe 25 minutes or 30 minutes, the implant surgery.
Able to see me? Okay.
That pencil marking, I think it's a
wonderful
actually the
one. No, so
lower
the
segment.
first time I'm learning from him actually.
Okay. The topographical anatomical size, he says that the only for the demonstration Raidu is taking the pencil. But in his mind, the engineering civil marking is already there. So he makes the pit like that.
Anand sir, the marking is below the suture line, sir.
Pardon?
The marking is inferior to the suture line.
Here,
Yeah, it will be
so
above the suture line,
actually,
no?
so I'm calculating here. So I'm going like this actually.
Okay.
So the suture line is here.
Yeah.
So this is depends upon actually this more than as 1.5 centimeter.
Okay.
So I'm going to post little bit. So my well is little posterior.
Yeah.
Marking is little over here, but well is little posterior.
Okay. If you are superior to suture line, it's fine, sir. Okay.
So a lot of bone waxes, no? This bone material you can collect and you can fill the cavity post-operatively. Not once you inserted the electrode, you can cover the cavity with this. Washburn. It's not my case. That's why I'm creating a little bit well because I do. So definitely will worry about some. I'm not giving this thing. So that's why I'm creating a well. It takes only 1 minute to create a well. It's not bigger thing. My hospital is also nowadays we are not creating any well. So it's take periosteal pocket as well as this periosteal stitch will take care of the implant. Here. Hold the this here. Yes, as well as here.
What should be the depth for the cochlear bed, sir?
This actually we have to use the this thing. The template is there, no? The model template. We have to use it and assess the depth. So once you're able to see the dural, then you stop it.
We'll continue the surgery in Professor give his lecture. We'll switch on to him. We'll hand over this Mike. Before that small welcome.
Not adequate. We have to create little bigger. Well,
Audio.
each case is different. See, the first case, actually, once you open the posterior tympanotomy, we're able to see the round window very clearly. In this case, actually, so it's a very much inferiorly placed, posterior place. That's why, so always look for the inclusepidal joint, and suppose difficulty to locate the round window, always look for the inclusepidal joint. Now it's clearly, so it's not moving, so you can make a little bit deeper over here. So they able to hear me, or is Hans, Dr. Hans' presentation started?
We're about to start, sir.
Okay, okay.
Can you hear me, sir?
Yeah.
Yeah, we're going to start the next session, which is
Okay.
presentation by Professor J.M. Hans.
Okay.
Just brief introduction about Professor J.M. Hans. Sir is a Padma Shri awardee. He's a MS ENT and topper and medalist from PGH Chandigarh. Dr. Hans has done pioneering work in the field of cochlear implant surgery and has done over 4,000 cochlear implant surgeries across SAARC countries. For his accomplishments in the field of ENT and cochlear implant, Professor J.M. Hans was awarded Padma Shri by Honorable Ex-President of India, Dr. APJ Abdul Kalam, in the year 2005. He is currently Chairman and Director of Dr. Hans and ENT and cochlear implant. He is honorary consultant to ex-Prime Minister of India. Dr. Hans is government member to the Ali Yujub Young National Institute of Deafness in Mumbai. He is also a government appointed executive member of All India Institute of Speech and Hearing, Mysore. Sir is a visiting cochlear implant surgeon to the medical colleges of Chhattisgarh, Andhra Pradesh, Madhya Pradesh, PGH Chandigarh, etc., and performed cochlear implant surgeries on deaf and dumb children, hard of hearing children. He is also advisor, cochlear implant surgeon to Pingalwara Trust in Amritsar. There are quite a lot of accomplishments by Professor Hans. Professor Hans, are you ready, sir?
I'm ready, but I'm not able to share the thing. How do I share? It is writing, what do you want to share?
Professor Hans, if you're ready, you can start, sir.
Yeah, but I'm not able to share my, this thing. Hello? Yeah, Harsha, how do I share my PowerPoint?
Okay.
We can hear you, sir.
That. But when I say share, okay, I think but my PowerPoint is not coming. It is coming workshop, JM Hans Gmail. Then
so we can hear your voice.
I've opened already. Okay. I think I've got it. Sorry, my dear. Getting old. Thank you, my dear. Okay. Can you see my PowerPoint? Hello?
Not yet, sir.
Now? It is being shared here. Hello? Hello?
Can you hear us, sir?
Yeah, I can hear you, but and here it is being shared on my laptop.
It is being shared now.
Okay, can I start?
We can see your PowerPoint, sir, now.
Okay, thank you very much. Thank you. So I'll start now. Thank you, Dr. Raidu, for a lovely conference. Thank you, the AOI Andhra Pradesh, for giving me this opportunity. Thank you, all the people who are now at the moment seeing my lecture. So my lecture today is Cochlear Implant Surgery, Preserving Nature in Technique and Technology. I will take this opportunity. I was before this seeing a posterior tympanotomy being done. And can you believe the great doctor? He was a very nice doctor. He made a beautiful cortical mastodectomy and then a posterior tympanotomy. But, there was an unnecessary, what I feel, a big surgery and a very small, passage to the real area where we have to do the round window insertion or cochleostomy and put the electrode inside. Now that is through that small little posterior tympanotomy. And what I started 25 years back was that instead of this posterior tympanotomy, I would raise the tympanomeatal flap as we do it in a stay-piece surgery, have a panoramic view of the promontory, and do whatever I want in different situations which came across to me in the last 25 years. So I named this lecture as Preserving Nature in Technique and Technology. Thank you again, Dr. Raidu, for giving me this opportunity, and I'm starting it. My journey in cochlear implant started in the year 1993 when I first visited the House Ear Institute for 6 months, and I was there, and I saw a lady being operated for cochlear implant, and I said I was doing cancer surgery after I came from PGI, and all those from PGI would agree with me that the only thing which was done there in PGI was cancer surgery. Then I visited all these places till the year 1998, met all these great people, learned a lot of cochlear implant and the posterior tympanotomy technique from them. But my inspiration was none other than the Professor Graham Clark. I was with him for a very long time, twice, once in 1993 for 3 months, and then in 1996 for another 3 months. And he was a great guy, inspired me. But in 1998, I met my soul, and that was Dr. Trifon Kiratzitsi, who told me that posterior tympanotomy is physiologically not the right technique to do. And that's how everything which I had learned in the last about 6-7 years got wasted, and I had to start all over again, learning on a temporal bone how to do a transcanal technique. And that's what I'll tell you, and I'll tell you also why I feel this is important. I mean, there are great surgeons who do this technique in about a very little time, but then those for beginners, I think they should also try this technique, and I'll tell you why. Anatomically, physiologically, and embryologically, this technique is the right technique to do. So, cochlear implant surgery and what we need to do. See, for a cochlear implant surgeon, it is not always the normal cochlea that he comes across. Normal cochlea, as you grow and you get difficult situations like a cochlear aqueduct with a CSF gusher, you will have cochlear malformations, again with a lot of connection with the interauditory canal and gushers again. You can have ossified cochleas of different nature. So every time you will have to actually sit down and think how to do the electrode insertion inside the cochlea, because these ossifications are at different places, not just at one place, but different places. So we will have to keep changing our strategies while doing these techniques. Nature, can you guys see me? Hello? Hello, am I visible there?
You're not, your slides are visible, sir. You're not visible.
No problem. Though I am on this thing video, but if I am not visible, no problem. But if my slides are visible, then this is better. Can you see the cursor?
Yeah, we can see your cursor, sir.
Oh, it's good. So in nature, in surgery, or in nature, we have to respect that nature. You know, man has not been respecting nature, and that's the reason you see catastrophe everywhere. You know, carbon dioxide emissions and global warmings and, you know, everything. And that is because we utilize the nature, but we don't respect it and we don't preserve it. So if we have to utilize the nature, we'll have to see that we respect it and preserve it. So that's very, very important. So if you can do that, that will be the most important thing to do. Okay. Now I'll use this thing in both my technique and technology. So in technique, what will happen is that you have to preserve that organ you are operating on. You have to preserve that organ you are operating on. And for that, you will have to do a minimal surgery, but you will have to have an adequate exposure. So it's a very minimal surgery you have to see, but the exposure has to be adequate and good. I'm getting a phone call from your side that the screen is not coming. Is that right? I can't get that. What is that? No, the PowerPoint is not coming. No, after that, none of the slides have been shown. So how do I do that? In this, I mean, every time I give a presentation, it is like this only. Something wrong from your side, because my this thing is running, and I can see a thing called. Okay, I'll stop sharing and then share again. Okay, I'll do that. Stop sharing, and just a minute. Now I'll share entire screen. Can you get it now? Is it okay now? I'll just wait. There is some problem. They're calling me and saying the slides are not coming. Yes, please.
Hello.
No, do you want me to start all over again?
Sir, you can start where you have actually stopped.
No, but I'm already sharing it.
Yeah.
F5. F5.
Function 5.
Function. Is it okay?
Now we got your brief biodata now.
Uh,
Biodata slide. And we are able to see your picture, sir. We need your PowerPoint to be shared. PPT slides.
the entire speaker. Share. Yeah, can you see now?
Yeah, we now got your PPT slides.
Is it okay?
Yes.
And can you see the other slide?
Yeah.
Okay. Can you see that?
Yes.
Okay.
We are now able to see.
So do you want me to start all over again?
No. Where you have stopped.
Hello?
Go to that slide, sir. You need not start.
Is somebody there?
Yeah, sir.
Okay, I'll start all over again then.
No, sir.
Or should I go from where I'm doing that? I'll take you there.
Yeah,
See,
okay, sir. Wherever, sir, whichever is comfortable, you start from there.
Okay, I'll just take you there. That in my lecture today, I'm not talking about the goodness of cochlear implant. I'm talking about what difficulties I faced and what my children should not face. So that is what I feel is preserving nature in technique and technology. So from 1993 to 1998, I traveled all these places, met these great people, Professor Graham Clark, and then met Dr. Trifon, who told me posterior tympanotomy is not scientifically the right thing to do. And then I started doing cochlear implant by the other technique. Now, we will all know that as surgeons, normal cochlea is not the thing we will always get. We will have different situations like malformed cochleas, we will have ossified cochleas, and we will have to change our strategies every time to complete these situations or do these situations. But every time it is important that we get a very wide exposure. So what nature we are utilizing, we have to respect that nature and preserve that nature. That is very important. And in surgical technique, the most important thing is to preserve that organ we are operating on, do a very minimal surgery, but with a very good and adequate exposure. That's what we want. And this is what the transcanal technique is all about. And I will try to tell you why I feel, in my opinion, this has been a fantastic technique for me. And I could do every kind of difficult situation very easily. Now, for that, you will have to not only know the anatomy. What we do is we are made to do a posterior tympanotomy without realizing that how this, how the mastoid air cell system functions, and that is the physiology. You will understand that when we do in smaller children, we have a very small, wide, and straight eustachian tube. Any infection from the nasopharynx, from the nose, from the adenoids can get into the mesotympanum and cause problem. And if you have already opened up this mesotympanum to the mastoid air cell system, what nature created was the adductus, the attic, the antrum, the honeycombing of the hair cells, and then supralabyrinthine cells going into the petrous apex. So it was a great pathway which would restrict infection going easily into the mastoid air cell system. But here we will immediately start putting that infection into the mastoid air cell system right from the adenoids or the nasopharynx of the child. For this, we will also have to understand what embryology is all about. Please understand that 100 years back, he told us, the gentleman, that facial recess means the facial nerve cannot be in this area, because embryologically we understand that the facial recess is formed by the union of the tympanic plate to the mastoid bone, and the facial nerve is the portion of the petromastoid part of the temporal bone. So it will never ever come. It might go anytime medially, but it will never come laterally into the facial recess area. And it is this facial recess that we can easily, use for our technique. Now, just see, this was a child I had operated about 10 years back. And this is the whole air cell system which has been preserved. The electrode is in the cochlea beautifully. You can see the electrode coming out of the facial recess. That's the facial nerve, so beautifully seen. But this child went to another very good doctor. Believe you me, he's a very good doctor. I'm not saying that the doctor is bad. And he did such a beautiful wide posterior tympanotomy. Can you see that? But within a few months, the whole thing got infected. Infection went into he got a severe bout of otitis media, and the infection was right there next to the implant. I don't say it happens in every technique. It can happen in our technique also, but that restricts the infection in the mesotympanum only, and very rarely would it allow to even go through the adductors and the attic and into the antrum. So, but here, because of such a big posterior tympanotomy which has been done, you can have the infection going straight inside. This is just the surgery. You have this perforator by which you create a tunnel 1.4 millimeters. Why 1.4 millimeters? Because metal electrode is the thickest at the ring, which is 1.3. And if you can put the metal electrode, you can put actually any electrode in 1.4 millimeters of the tunnel. So we are actually using 1.4 millimeter of the posterior tympanotomy area only, and that is how I'll tell you how it is. So this is the perforator. You are going parallel to the posterior canal wall without touching it through by the guard. The guard remains off the posterior canal wall, and this is the actual time which takes to form the tunnel. This is the suprameatal well where the extra electrode would be, and you don't have to create such a big cortical mastoidectomy and then go through this tunnel, small little angle of the chorda with the tympani to reach the area, which is the most important step. By raising the flap, you get a panoramic view of the whole thing, and you can actually shape your cochleostomy to the size of the electrode. You don't have to create a bigger cochleostomy, just the size in which the electrode snugly fits. You can see I've made the tunnel in line with the cochleostomy, or first you can actually see the area where the cochleostomy would be, and then you create a tunnel in line with the cochleostomy so that the electrode goes straight inside and you put back the tympanic flap. So this is all the surgery. So you can compare a big cortical mastoidectomy and going through this small little posterior tympanotomy vis-a-vis, that is the only surgery, vis-a-vis a large exposure of the promontory where you can do whatever kind of situation which I'll show you just now in my further slides. And this is what it looks like. You can see the tunnel, 1.4 millimeter. You can see the facial nerve far behind, and you can see vis-a-vis the large cortical mastoidectomy which was done to do the posterior tympanotomy. Now, I do an end-oral incision. I was just seeing a post-oral incision, and the problems with post-oral incision is that, that the transcanal incision is in line with the end-oral incision. So this can be one incision. And the advantage of this is that you can raise the flap. You have a beautiful exposure of the squamous part of the temporal bone where you have to fix the receiver stimulator. And both these are arterial based flap. The skin and the temporalis muscle are both arterial based flap, and you can see the implant has been well kept below the firm sutures of these two flaps, and it doesn't absolutely move from there. And you can see that in future, maybe 10 years, 20 years down the line, if there is a problem, we don't have to go in that region and give an incision in the posterior auricular area. We just go there and do our surgery, and I'll show you how. This is what the posterior flaps can do, the posterior auricular incisions, that if you have to correct something and do something, multiple surgeries will lead to the electrode coming out and the implant coming out. It can happen in the end oral incision also, but there was a bad scar which had some fluid collection. We removed that portion of the scar, and without even going in that area of the electrode, we could do it and stitch it back again without any problem. So the implant area or the electrode area in an end oral incision will not be disturbed at all. So that I feel end oral incision is better, and you can have a panoramic view of the middle ear through the tympanometal flap that you raise. And just a comparison, that this is what the transcanal tunnel is, and this is what the exposure is all about. And here you have a beautiful exposure of the round window and the promontory. I again and again say it is the promontory which is important. You can see the basal turn coming and touching the round window region, and that is where the cochleostomy has to be made, vis-a-vis a large cortical mastodectomy as compared to the posterior tympanotomy, a small posterior. See, here you will not even see the area where you have to do either a round window insertion or a cochlear insertion. Rather, many a time I joke that we should do a stapedectomy or a stapedotomy through the posterior tympanotomy, because at the incus bar you have a base of the posterior tympanotomy, and that's a very wide area. So you can make actually do stapes through this rather than. Now, any kind of cochlear rotations which will happen in a child, particularly with abnormal cochleas, you can see this through this very beautifully rather than through this small little angle of posterior tympanotomy. And you can do a cochleostomy, which I feel is more physiological, because first of all, if this is the round window niche and that is the crista, you can't go easily. You'll have to kink your electrode and go like that, and it will be very difficult to drill off the crista from inside the round window. You have to, if you create a cochleostomy here, you can drill the crista down as I have done it. Now this is the crista, and you can put it down and bring it parallel to the outer wall of the cochlea, so that when the electrode goes inside, it doesn't get kinked right in the beginning of the area of the cochleostomy, in the area of the cochleostomy. So difficult situations, all which could be done very easily. You have a very anteriorly placed sigmoid sinus, almost touching the posterior canal wall. I just had to drill that tunnel, and which I did it, and did the cochleostomy through the permeatal approach. There was a ossification of this cochlea here, so we did a drill out, the drill out technique, as we call it. The whole basal turn was exposed, and we could find the scala tympani right anterior area where the internal carotid artery is there. Now, this was a small little area of fibrosis, and I had to do a distant cochleostomy, and that could be done very well. This was a decent facial, a decent jugular, almost covering the round window, but still a cochleostomy could be done. And this is the gusher. Many a times we will have this bad gusher coming, and we can use a three-hand technique. So your junior or your assistant can hold the suction, and with two hands, you can plug the cochleostomy right when the gusher is on. You can see we've already put the electrode inside, and now with two hands, two straight needles, I will put periosteum inside the cochleostomy, so that the leak gets blocked right there. If you dry tap the whole CSF and then pack it, you are not sure whether you have packed it properly, and next day you'll see all that soakage of CSF, and then you'll have to do a lumbar puncture and give Diamox and all those problems. But if you are sure that you have plugged the cochleostomy well, and the CSF gusher is stopped on the table, then a three-hand technique is very important, and this is possible only when you have a lovely exposure of the middle ear cleft. So this is possible only when you raise the tympanomeatal flap. Now, these were difficult situations we were done. After 19 years of doing this surgery, one day the Cochlear people called me. They were not very sure of the technique and they called me to Sydney. They said, Dr. Hans, we want to do the histopathology of the temporal bone you operate. And I said, okay. And I did 2 temporal bone dissections in front of 50 odd people there. And then this is the tunnel I created and the cochleostomy. And then they did a histopathology. You can see that is the external canal. That is the tunnel very close to the canal and the electrode inside the tunnel. And you have the facial nerve far behind. Just imagine how anteriorly it is, just below the lateral semicircular canal, and how anteriorly from the facial nerve. So this also is possible because we should understand the embryology of the facial nerve. And this is how it looks like. You can see the facial nerve delineated and the tunnel far ahead of the facial nerve. And when you understand the facial nerve, never ever would it be injured, because we know that the branchial system, the stapes is the first branchial arch and the facial nerve is the second branchial arch. So it has to go behind the stapes and then form this big area, which we utilize as either doing a posterior tympanotomy or maybe creating the tunnel. The tunnel is made here. Just a fraction of the area of the posterior tympanotomy region is taken and to create this tunnel. And so that's why embryologically there can never be any problem to the facial nerve. So this was preserving nature in technique. And I think if we are preserving the physiology, the anatomy, and the child who has to live for another 100 years, and we have to put that implant inside, we should be sure that we have not injured or destroyed any of the organs we are operating on. And here it is the mastoid air cell system, the middle ear cleft area. Now coming to the ideal cochlear implant. In the last 25 years, I realized that what these guys are giving us, without even questioning them, without even asking them, we are putting that implant as if these people are more intelligent than us. But this is what has happened. And when the patient comes back to us with a complication, they are not there. We have to face the people. So I'll tell you why there are certain things which are very wrong, and what led to, of no fault of the surgeon and no fault of the patient, these complications occurred which we had to treat. And that was primarily because of the implant. Now, I do all the 5 implant systems which are available in the world. Rather, I did the Digisonic also. So, and now I'm doing the New Bio also. And I'll tell you a word about New Bio also, what is the beauty of New Bio. So all the implant systems, and I realized that every implant had a little problem which they have to rectify for us, so that when we put in our children, the children are not, put to that difficult situation in future ever in life. So what are the 3 things that we want to do to preserve this whole system we are putting? See, the beauty of cataract surgery is that we can remove the cataract through a pinhole and put the prosthesis from that pinhole only. And in the evening, the patient can go and roam about in the mall, But in our technique, we are putting in a 6-7 months old child such a big implant, and they have to do something about this implant so that in future these things don't happen, which I'm trying to show you. The first thing is that the receiver stimulator has to be anatomically aligned to the very convex bone of the child's head, the squamous temporal bone. And every time it is not like that. The implant sometimes is much bigger than the flat area of the skull in a child, and we have to compromise our technique, and I'll tell you what happens. The second is the MRI compatible magnet. That is very, very important. Now they tell us the older ones are not 3 Tesla MRI compatible. Sometimes later they will tell us now we have the 7 Tesla and they are not compatible. So they have to come out with something which we are sure that nothing will happen ever in life of the child, and the child would have a smooth hearing and speech facility all his life. The last is a very smooth electrode array. Please understand, I'm underlining this again. You have to see that what you are putting inside the cochlea has to be of adequate length. It has to be of smooth surface, because tomorrow, or maybe 10 years down the line, 20 years down the line, if something goes wrong with the implant or you have to upgrade the technology, you should be able to remove this implant and put a new one immediately without any much problem. And I'll show you how it happens. Now, if what they have done is that they have made the curvature of the receiver stimulator, that is the coil, rounded. Now, what happens is, if this surface is very sharply convex, there'll be a space between the surface and the coil, and you can see that it will be pushed up and the tissue would start growing down. And this is what happens. You can see that the tissue grew under that, and the coil came out. We had to put it back, but most of the time, once the biofilm gets infected, we will not be able to save this implant, and this goes waste for no fault of the parents, no fault of the child, and no fault of the surgeon. This thing has happened because they gave us something which was too big to be placed on the convex skull of the child. So it is none of our fault. They have to give us implants which are very small and anatomically aligned to the surface of the squamous temporal bone. Now, they were giving us all these things. They're still giving us, but yes, they have stopped, realizing that they did a blunder. Any small little injury or an MRI exposure would extrude that magnet, and we had to put it back. This was not the right thing, but now they have corrected, and they are giving us 3 Tesla, which don't come out, pop off like that, and we have to put them back again. Even 10 to 15 years later, somehow I've seen this hematoma forming because of certain, even slightest of injuries. These hematomas formed, and we have to immediately treat them by removing and aspirating and giving a pressure bandage. If we don't do that, these things would happen, and this is the end of the implant if infection gets in there. So that's very important again. So as I told you last, the electrode array has to be seen. It should not be very, very long as we have in some of the implants. Now that kind of electrode, if you put it, we are not able to put the same kind of electrode inside, and we will have to choose a shorter electrode, though the biofilm would be formed till that end, but still sometimes it becomes difficult. The electrode should be soft and malleable. So if it kinks, and if it is straight wire, the kinking would lead to increased resistance there, and the battery consumption becomes more, and there is degeneration of the wire and the metal of the wire in long term when the heating up of the wire occurs. And it should be a smooth surface. It should not be like this, what they were earlier giving us. Now, if you try to remove this electrode, the whole biofilm gets pulled outside, and you are not able to put a fresh one. So a smooth surface is very, very important, and definitely not the pre-curved ones. Many of us are putting these pre-curved electrodes. They should not be put, because we all know that the only reason if we are putting closer to the modulus, the electrode, we have to give bipolar stimulation. Now, bipolar stimulation, is not the right kind of stimulation, and most of the time we are giving monopolar stimulation only. And if in monopolar stimulation the electrode is a little away from the modulus, it really doesn't matter, because the current levels are flowing between the intracochlear active and the extracochlear ground electrode. So there is no problem even if it is a little away from the modulus. So if monopolar stimulation is to be given, we don't need the pre-curved electrodes to be put, because they have their own problems. They have scalar deviations, and scalar deviations can occur from 57.1% to 51.3% in a different electrode. In the lateral wall electrode, that is a straight electrode, the scalar deviation is only 4.4%. And then suddenly they realized that probably the electrodes, the pre-modular electrodes, the pre-curved electrodes they were giving us were too stiff, and they said, sorry, now we'll give you slimmer electrodes. They agreed that they were giving us something wrong. They gave us slimmer electrodes, and these slimmer electrodes had tip foldovers. So again, there is a problem. So why should we believe in these people and use our common sense and see when it is a monopolar stimulation, even if we put a straight electrode and it goes a little towards the outer side, actually you can do it. When you put a little extra and then pull it outside, it comes towards the modulus, and then you pack it from the lateral part of your cochleostomy or from the lateral part of the electrode. The electrode would then remain towards the modulus, but it is not needed. When we are giving monopolar stimulation, there is no need for the electrode to be close to the this thing, because if the electrical current levels are high, or if the stimulation rates are very high, then if it is close to the modulus, the chances are that it will lead to dendrite degeneration and the metal degeneration. So all these things are there, and we have to see that we don't do it. Now, this is a revision surgery in which a varia was used, a transcanal technique, and a smooth electrode was used. And you can see that this is the actual time taken for the surgery. I removed the earlier electrode, and now I'm putting the long 31.3 millimeter fresh electrode, which goes inside the same biofilm, and you just have to guide it inside through the transcanal approach. And you can see the whole electrode going in so beautifully. You just have to guide it inside with a forceps and don't push it there. Just keep guiding the whole thing inside, and you will see the whole electrode till the ring goes. But there is no need for such long electrodes, and they will have to come out with electrodes which are not too long, not too short, and adequate for the size we Indian structures are. So you can see that the whole electrode will go in, and that was the actual time taken for insertion and for doing the surgery. Revisions are very important. Please understand, one day you will have to revise all these cases you are doing. I don't think all of them would live for 100 years, that's for sure. So you can see the ring has come, and the whole revision has been done properly. The whole electrode has gone in properly again. So in a traditional implant, what happens is that you have the processor, which, due to its digital signaling process, converts the acoustic signal picked up by the microphone to digital signals, thus reducing the noise. So the outer structure does that, and the inner structure, which is the receiver stimulator, is the major electronics which converts the sound waves into bioelectrical current. And here lies the problem. So if you have, and most of the time, these the implants are using DC current, and DC current, because of the toxins released and the corrosive products formed, there is a chance of tissue damage and metal corrosion. So that is very high, and that increases if the DC currents are more and the stimulation rate is very high. So we are gradually not only destroying our dendrites, we are also destroying the metal of which the electrodes are made, and gradually they will fade. Now, by giving these two things, DC current and high rate of stimulation, there is warming up of the electronics and warming up of the receiver stimulator, which leads to situations like that. I'm sure each one of you has seen this situation, the skull and the skin of the child, this child saying it is too hot and it's paining, and the skin getting eroded. All these we have seen, and if it goes beyond a certain limit, it becomes very difficult to save the skin and save the implant. So we have to be very careful. But this is all because of the electronics inside the skull. And today I'll also talk about a little of the bio implant. Now, there is no electronics inside. The inside thing is inert. There is no problem. And every time it will never fail because there is no electronics. It will never get heated up because there is no electronics inside. Everything is done outside, and the DSP then gives the the impulse to the FSM, which is the full spectrum modulation, and that converts the digital sound into electric analog sound. Please understand, and the electric analog sound is then given to the inner device, which then gives it to the rest of the the dendrites and the cochlear organ of Kotai there, the dendrites. Now, this is what it is. It looks like a one-penny coin. very light, and you can just put it, no beds to be formed. The total time which I take to do this surgery is about 30 minutes from the skin, and it is one of the most passive implants inside, no electronics. It is the thinnest implant, it is the smallest implant, and it is the lightest implant. So there is no problem, no situations. I've done over 60, 70 of these with very good results and no complications whatsoever. The last little line in this is that the human brain is analog, and this device gives us analog sounds, which is very welcome to the human brain because it is an analog sound, analog brain. And in the other implant system, what we are trying to do is we are trying to do that as early as possible, because we want to convert the digital analog brain to the digital brain so that the child can hear that. So if it takes time, the brain would forget. So here we can even do it a little later, and I've seen that the results are very good. We have presented this paper already with 100 implants done, and the results are really, really good. So 25 years, I am happy today that I could do more than 8 to 10 implants in a day because of the Varia technique. But I am very unhappy for what I have put in these children. I have taken away one handicap and given them the another handicap of not getting an MRI done. You know, all these complications are occurring from time to time, which really saddens me. And I want something which to be given to me by these implant companies where all these things are not there. And once you put the inner device, you just forget about it. We have this yearly workshop where people doing the Varia come and learn further finer details. I have it in my clinic. I have a temporal lab in my clinic where you can come and do and learn. And I was the first one in 2002 to be visiting the Dead Sea, Israel, a part of the transcanal technique surgeons. And today we have over 100 surgeons using this technique, and even Bhaiya Srinivas does it in Guntur. And there is another place in Guntur where I just went, and they are also learning. So all these places, Pakistan, Nepal, Bangladesh, Afghanistan, people are doing and now in Kazakhstan and other places. So it was difficult. It was very difficult, to pave the path for the others. But I'm happy that today, Varia, the more scientific technique of cochlear implant is taking shape, and people. I'm again very grateful to Dr. Raidu, who gave me this opportunity to talk to his delegates about the preserving nature in technique and technology for cochlear implant surgery. Thank you very much.
Sir, thank you very much, sir. Myself, Raidu, thank you for honoring, asking our questions. Sir readily accepted our invitation.
Thank you.
Very much,
Thank
sir.
you.
Tomorrow morning we are going to demonstrate the media technique, sir. Your technique.
Oh, thank you very much, Raidu, and God bless you. Thank you.
So thank you, sir. Coming to our next speaker, Professor Mohan Kameswaran. Sir, we'd like to give a small introduction regarding Padma Shri, Professor Mohan Kameswaran, sir. So Mohan Kameswaran, sir, is a distinguished ENT surgeon, and he's a pioneer in cochlear implant surgery. Professor Mohan Kameswaran is the managing director and senior consultant of MERF Foundation, an honorary distinguished professor at Tamil Nadu, Dr. MGR Medical University, and honorary professor at SRM Medical College Hospital and Research Center. He also serves as an honorary senior lecturer at Edgehill University, UK. A recipient of Padma Shri National Award in 2006 from Dr. APJ Abdul Kalam. He has received numerous accolades, including Dr. B.C. Roy Award in 2008 and the Indo-Australian Award for Meritorious Service in the same year. His honors include awards from Rotary Club, the President of Sri Lanka, and the Tamil Nadu Scientist Award in 2007. Professor Kameswaran has pioneered cochlear implant surgery in India, establishing programs in 45 centers nationally and internationally. He was the first surgeon in South Asia to perform auditory brainstem implant and total implantable hearing devices. He has edited textbooks, published over 190 articles, and presented at more than 600 conferences. He gave mammoth contribution to the field of ENT and cochlear implant surgery. So over to Professor Padma Shri, Dr. Mohan Kameshwaran. Sir, warm welcome, sir.
Thank you so much. Thank you for this kind words of introduction. First of all, let me thank Raidu for this wonderful opportunity to share my thoughts with all of you. Let me, without wasting time, share my presentation. Yeah. Are you getting my presentation on the screen? Raidu?
Yes, sir, we are getting your presentation. Please.
Okay, right. Thank you. So the topic I have been given is the challenges in cochlear implantation. Now, first of all, before I say anything else, let me say that by and large, cochlear implant surgery is a safe surgery. And the following slides may look a little, daunting for the new surgeon. But the idea is not to be frightening anyone. The idea is just to share with you what are the possible problems that we can be facing. But these problems, I must say, are not very common. They're quite rare, so you don't have to be too worried about it. And generally speaking, it's a safe surgery. Especially now, we have access to excellent preoperative investigations, especially imaging. This will help us tremendously to anticipate the problems and plan the surgery. Also, let's not forget the new frontier, which is genetics. And a lot of information can be given by genetic profiling also, which will help us to understand not only the problems we could face during surgery, but also subsequently the prognosis as well as the habilitation challenges. And based on this, we can give proper preoperative counseling regarding expectations of the outcomes. Now, challenges could be either in the surgery itself, in fact, even before the surgery, in the indications and the surgery itself, as well as in anesthesia, and then subsequently in the audiology and habilitation. So I'll try and cover all of them in the time given to me. Now, today, the indications are growing by and expanding by the day. When we started cochlear implantation in the 90s, in fact, somewhere 96 we started, the indications are pretty straightforward. You wanted to take only children who are profoundly deaf, who would not benefit from hearing aid, and who are all at that time older than 2 years old. But today the indications have changed quite a bit, and those days we were not taking any abnormal cochlears. Any cochlear malformation was considered a contraindication. But today all that has changed, and we are all doing implants on more and more children with cochlear malformations also. Now, and also today we have started to do children who are much less than 1 year of age, much younger even as young as 9 months. Now, in fact, the newer indications have come down to 6 months. So, we really are looking at much younger children. And the reason, of course, is that we have had much better access to diagnostic facilities. Now we can confidently diagnose profound hearing loss in a 6-month-old child today. We are also doing in older adults, much older adults. We know that the cognitive decline, is a very major consideration in profoundly deaf adults. So we are now taking even much older adults. In fact, the oldest adult I have operated upon was 86 years when I operated, and I don't think I'll have any reservation even operating somebody older, as long as they need it and they're fit for surgery. And we are also doing people with considerable residual hearing today. The reason is that our techniques for preservation of hearing have improved. And of course, we'll talk about it a little later also. In very young children, when we are taking children as young as 6 months, so we have to understand what are the risks that we may face. First of all, we have the risk of intraoperative blood loss. Now, these children, they have, let's say, an 8 kg baby. the total blood volume is going to be somewhere around 500 to 600 ml. Now, for them, if you have a 50 to 60 ml blood loss during surgery, which isn't much really, that would represent about 10% of the blood volume, which is a significant loss in blood volume. Add to that, the problem is that in these very young children, the hemodynamic reflexes are not very well developed. So, that you can't depend on tachycardia and fall in BP and things like that in these children to know the blood loss and the subsequent hypovolemic shock. So therefore, you really have to be on the lookout for blood loss and minimize the blood loss. Of course, the facial anatomy could be a little different. The fixation of the receiver stimulator, because the skulls are very thin, could be a problem. Device migration with skull growth may become another unique. So in these very young children, they have their own unique set of problems that we have to be aware of. Today is the era of bilateral simultaneous cochlear implantation. But more and more, we now advocate bilateral simultaneous cochlear implantation because we do know that the 2 years are definitely better than 1 year for various reasons. Now, I shall outline some of the reasons. When you have a bilateral hearing, you have much better hearing in noisy environment. You have also directionality, which is better localization of sound, improved sound quality, and they have certain advantages in difficult situations. They can have uninterrupted hearing. Even if one device fails for some reason, they can still be using the other device. Music perception, I put a question mark. Many of the bilateral implantees feel that they have better music perception when they have hearing in both ears. And of course, but there is also a negative side to it. When you're doing a bilateral implant in a very young child, the risks of blood loss are even more, and you have to be aware of the duration of surgery. It must be done by a fairly quick surgeon. At any rate, you don't want really extended periods of anesthesia. I usually tell my colleagues when they start, I said, if you are confident that you can do the 2 sides within about 3 hours, then you should go ahead and do it. Now, congenital anomalies of the inner ear can pose their own challenges. And radiographically, we know that about 10%, 5 to 15% in various series, but about 10% of all congenitally deaf children will show some anomalies of the inner ear. And what are these challenges which you can come out of it? Well, you can have a problem with complete insertion. You may have CSF gusher, and almost up to 40% of malformed cochlears run the risk of CSF gushers and subsequently risk of meningitis. And sometimes even identification of the cochleostomy site or the round window could be a difficult problem because sometimes the round windows or the whole windows themselves may not be developed in some of these symptoms. Aberrant facial nerve can happen in about 15% of malformed inner ears. And there also is a risk of decreased ganglion cell count, which can affect the outcomes. Today, we have access to the genetic gene technology, where we can do a genetic profiling. We can do a next generation sequencing, which will tell you that certain genes we know are associated with decreased spiral cell ganglion cell count. So therefore, it is possible to predict this to some extent even before surgery, and this will help us to prognosticate regarding the outcomes. Inadvertent penetration of intra-aortic canal electrodes can happen. This particularly happens in IP3, and if you have IP3 abnormality, migration of the electrode into the intra-aortic meatus, and even up to CP angle may happen and lead to vigorous facial twitching and so on. And anomalies of the round window may also restrict access to the cochlear implant. Now let's take the most common IP2 or Mondini deformity, where the cochlea has 1.5 turns instead of the normal 2.5 to 2 3/4 turns. There is a normal basal turn development, which is key to the imaging diagnosis of IP2. Many of them are associated with a dilated vestibular aqueduct, and this you must pick up during this, prior to surgery when looking at radiology, as you may have a brisk perilymph leak or even a CSF leak during surgery and risk of meningitis. Also, you have to be sure that there is a cochlear nerve, which is well developed, and it is more than that, it is connected to the cochlear. Now, this can be an issue because you may have a cochlear nerve in the CP angle, but if you follow it, you may find that the cochlear aperture near the modulus is fully closed. So the nerve may not be actually making contact with the modulus. So this is something that to be aware of. Now, look at this round window. You can see the pulsation in the round window. So this tells you that there is going to be a high pressure and that is going to be a leak. So during surgery, you can actually predict that you're going to have it even before you open the round window. Now, when you have this kind of situation, it's probably a sensible thing to do a cochleostomy rather than try and go through the round window, because when you have a cochleostomy, the advantage is you have an opening with bone margins all around. Now that's easier for you to plug than when you have a partial membranous margin. So in this one situation where cochleostomy may be a slightly easier, better option. Also, when you make a cochleostomy, make it a little bigger than the electrode, because paradoxically, if you have a bigger cochleostomy, it's easier for you to plug around it than if you have a very small cochleostomy. Of course, there are certain special electrodes also which are designed. The one electrode designed by Inaugural is one such electrode, known as the form electrodes. Now, when you're dealing with a common cavity, of course, you can open the common cavity anywhere. Of course, it can be opened the usual site near the round window, but you can also open it through the vestibules or the labyrinth. And here I'm doing exactly that, opening into the position of what's the lateral semicircular canal, because there's no lateral canal in this patient. It's all one single common cavity. But the way we do it is slightly different. You want to make a linear opening rather than a circular opening. And then when you insert, you want to insert the electrode not at the tip first, but somewhere in the middle to form a loop. So this loop goes in because the reason is that in a common cavity, the neural elements are spread out over the outside wall or the outer wall. There's no modulus. So there's no point in trying to push the tip first. You want to have full banded electrodes, and these electrodes have to be lying on the outer wall of the cavity. So you want to go and insert it in such a way that it will form a kind of a loop, and this loop will lie along the outer wall. And once you've done that, you can have a little bit of soft tissue which can be inserted inside and packed like I'm doing now. And this helps you to keep the electrodes pressed against the outer wall. So this will make sure that the electrodes are lying in alignment with the neural elements which are spread over the outer wall. So this is the technique for a common cavity deformity. Now, the other challenge that we could be facing is the post-meningitic ossification. And this is quite a difficult problem. It can really be a difficult problem. And we have to, of course, the advantages, we can always pick it up pre-operatively based on these scans. There are several techniques that we can use, and this is a partially edited video. And I deliberately left it with the partial editing so that you understand the problems that we may face. So I started off with a basal turn, and I'm trying to do a basal turn drill out. We know that in a meningitic ossification, the texture of the bone is quite different from the texture of the aortic capsule. So it's more a softer bone, it's flaky bone. You can slowly take it out layer by layer, so one by little, and try and make the basal turn open up. So this is, you have to be careful about one thing though. The basal turn goes and takes a turn at the anterior most limit, and the carotid, internal carotid, is not very far from this. So you have to be very, very careful as you go on, keeping in mind about the position of the carotid and tentative position. So don't go and damage the carotid. So here I am slowly taking it little by little. Use a blunt instrument like a blunt pick or so, pick out the bone and keep an opening always eye on the lumen of the basal turn. So once I've done that, and I think that I have done a reasonable amount, then the next step that I'm doing is to assess the length of the basal turn that I have been able to open up. And this is done with an intraoperative depth gauge or a test device, which is inserted. It's a dummy electrode, and I'm pushing it in to see how much I can get in. Now, the rule of thumb is that unless you have at least 2/3 of the electrodes inside the cochlea, it's not going to be really, giving you good performance. So here I've just checked up. It's not enough. Not even half the length has gone in. So the next step I'm going ahead is I'm removing the incus and the incus buttress to expose the second turn of the cochlea. So I'm now going to opening to the second turn of the cochlea to do a second turn cochleostomy, and then try through that. So for that, we know that the second turn is in front of the old window and immediately below the processor's cochlear formis. So here I have to remove the stapes, the superstructure, and then I expose the position, the location in front of the oval window, below the process cochlear formis and above the promontory. So just at the upper end of the promontory, slowly opening, and I have now slowly opened into the, I can see the second turn opening. Now again, I tie the test electrode. Now this time it's going much better. Now you have two possibilities. It may be going antegrade or retrograde. More often antegrade than retrograde. And once this goes in, you can check out how much of it is gone in. So the second turn ossification is always much less than the basal turn, because you must remember, ossification always starts from the basal turn and then proceeds. So here I'm able to get the full length of the test device inside. So there's a marker there that you can see, which will tell me that if the marker is reached, I can get in a compressed electrode to fit into the second turn. So now that I've done that, so now I get the actual electrode going in, and this is the compressed electrode, and this is specially designed for this kind of situations, and I'm able to get the electrode fully into the second turn. Of course, this poses certain questions. Since you have gone into the second turn, you have completely ignored the basal turn, which is a high frequency. And we all know that high frequency information is very, very important, particularly for consonants, and that's for speech understanding. It's important. So what will this child do? Well, actually, it's not so bad, because initially, of course, there is a difficulty, but later on, there is a reallocation of the cochlear frequencies, based on the electrode. You can do that. The audiologist can do a reallocation of frequencies. And with time, the children will learn to get information in the high frequency also. So once I have now plugged the second turn cochleostomy, a bit of soft tissue in the original basal turn drill out that we did, and we are now ready to close up. Let's look at the next situation. This is a situation where a double array has been used. So this is an older video. And today we don't do much of this double arrays. But anyway, I put it up to show you that there is another option, which we are all doing. Here, the advantage in a double array is that you may get some electrodes into the basal turn and some into the apical turn. And then you can try and stimulate both. That way you maximize the number of electrodes going. But in actual practice, we found that this is not showing any great advantage. So today it's not a very popular device. The other challenging situation, of course, is an enlarged vestibular aqueduct. And this is usually associated with the mutation in the gene SLC26A4. And it is seen in almost 40 to 50% of these individuals. And here, please look at the stapes, and you will see that you'll see the stapes is pulsating. I've dislocated the urocepial joint just to show the sign. We already saw the round window pulsating in another patient, but this is a pulsatile stapes, and that tells you again that this patient is going to have a perilymph gusher. I can see that gusher coming out. So as I said, preferably in a situation like this where you anticipate a gusher, it's better to have a cochleostomy than a round window insertion, because with a bony margin all around, it's easier for you to plug around this, leak you can get. But whatever you do, it's absolutely essential that before you leave before you close up, you must have an absolutely dry field. So normally we use a lot of soft tissue around it to seal it, get a watertight seal, and then use a bit of tissue glue also on top of it. And this will generally stop the situation. As I said that about 15% of anomalous cochlear are associated with facial nerve anomaly. This is one such situation. Now here you have a facial canal, but you see the facial nerve, the whitish band, which is actually going from the process cochleariformis directly in front of the round window to the position of the stylomastoid foramen. So it's actually in the way of the round window. So I was curious because there's also a fallopian canal. So I opened the fallopian canal to see what if there's a part of the fibers are going through it. In actual fact, it is just fibrous tissue in the fallopian canal. So you have to be cautious about this. This can be picked up by preoperative imaging if you look carefully and you have a good images. But you have to be always cautious that this is one possibility that may happen. So we have actually, in a situation like this, we have had to even go in front of the nerve and then make a cochleostomy. And after that, of course, there was no such problem. Chronic otitis media, patients who had canal wall down mastoidectomy, both sides, ending up with profound hearing loss in both ears. We are increasingly seeing this as an indication now. And these patients need to have a subtotal petrosectomy with a blind sac closure. And that's what you saw me doing. You need a 2-layer closure, and then you can go in and put the implant. This is again a partially edited video in a patient with a Meniere's disease in whom I'm doing a labyrinthectomy with a cochlear implantation. But this is a very high jugular bulb. You can see the jugular bulb right up here and going and covering the round window. So that caused a lot of problems. So I kept it deliberately to show the possibilities of problem. So you can see the round window there. I'm just dissecting out and you can see the bleeding coming from the jugular bulb. There's nothing to get worried about because I probably know that this is a venous bleed. So you need to be prepared for it though. So what I've done is I immediately keep a bit of gel foam there with adrenaline and put pressure on it. So that will stop the bleeding there for the time being. And then proceed with the labyrinthectomy. Because of the very unfavorable contracted mastoid and contracted anatomy, I decided to do a subtotal petrosectomy in this instance again. So I'm removing the canal wall. I'm removing all the epithelium from inside, and then going ahead with a blind sac closure and subtotal petrosectomy. So now I have a very good view of the jugular bulb. You can see the jugular bulb going right up to the round window. So if this is jugular bulb and it's a round window, and again you see the moment I touch it, it starts bleeding. But now I have much better access. So in a very, very unfavorable anatomy like this, don't hesitate to proceed for a subtotal petrosectomy. It's one of the good indications for a good access in very unfavorable anatomy. But that should be rare. I've hardly done a few of them, but they were all well indicated. So a blind sac closure has to be meticulously done, 2-layer closure, and supported with a muscle flap, which will cover the 2-layer closure. So it reinforces the 2-layer closure. So that's the blind sac closure. You see the whole field is so bloody. Remove the gel foam, give a good wash. Now labyrinthectomy proceeding. So 3-canal labyrinthectomy. You see the lateral canal, then the superior canal getting opened, posterior canal. So complete destruction of the labyrinth in these patients. I do not proceed to do a vestibular neuronectomy in these patients because you don't want to in any way cause any trauma to the cochlear nerve. So for that reason, I normally would proceed in a patient with vertigo would proceed for a vestibular nerve section. But here we stop with the 3-canal labyrinthectomy and then go ahead and do the cochlear implantation. That's a subarcuate artery bleeding from the. So it tells you that you are almost completely destroyed the labyrinth. You're very close to the intraartery meatus, although you've not opened the intraartery meatus. So this is the laparoscopy getting completed totally. And now, of course, it's a time for the insertion of the cochlear implant. Because of the very high jugular bulb, I'm doing a cochleostomy. It was an entire round window membrane was covered. So just exposing it's actually an extended round window. So opening up the round window and doing a cochleostomy. And then put the implant inside that. It's very easy because it's all wide open for you. Cover it up with a little bit of fat or muscle, and then your closure. And don't forget, you have to plug the station tube in these patients when you're doing a subtotal fetusectomy. So that's the implant going in, and once the implant goes in, nicely cover it up with a bit of abdominal fat, or you can cover it up with a muscle pedicle, or the fat is better. Here it's completely inserted. So that's just to show you the challenging anatomy in a situation like this. Cochlear far advanced otosclerosis is another very good indication for cochlear implantation. We have quite a big series actually of these patients, and they have very good outcomes if you do cochlear implantation. Of course, there are certain postoperative challenges, particularly facial nerve stimulation may happen in some patients, but it's not as common as it is outlined. The reason why it happens is because the otosclerotic bone is porous to electricity. It leaks electricity, and it may go through that and stimulate the facial nerve. What is not very much highlighted is it can also stimulate the tympanic plexus. In some patients, because of the tympanic plexus stimulation, they may complain of deep-seated pain. And this is something that is not highlighted in literature. So some of them may also have this pain. The facial nerve stimulation mainly happens from the second turn electrodes because they are very, very close to the geniculate ganglion. And the bone between the two could be as thin as 1 or even 1.5 or 1 millimeter. And that is the area where you generally have the stimulation. You can close the electrodes or shut off the electrodes. There are various strategies that the audiologists will implement. They may lower the current, or they may close the electrodes, and you can actually deal with the facial nerve stimulation. Now, this is just a video to show you the actual surgery in cochlear otosclerosis. I'm making a cochleostomy here. Again, you can see that the bone is texture is very different from the bone of the cochlea. So it's very soft bone, it's porous bone, and you can actually pick it up. It'll just break away. So you use a blunt pick and or a very fine curette, and you can pick away the bone till you reach the lumen. So here I've done that. So I am getting a little bit of leak also. The reason why you get leak is because the bone is porous, and through the cochlear aqueduct, you can have quite a bit of perilymph and even CSF leaking out. So you should be prepared for that. So in these cases, we've done about more than 70 cases. We've had this kind of leak in only 2. Facial nerve stimulation, hardly about 7 or 8 of them. And we've always been able to deal with that. But the end result in hearing is very good in these patients. They're very, very happy. And they'll be very, very grateful for what you've done. So it's well worth the effort. This is regarding the cochlear otosclerosis. Another challenge that you may have is an aberrant internal carotid artery. And you can easily pick it up pre-operatively. And also intraoperatively, you see the pulsation of the internal carotid artery. So I've shown you already pulsation of the round window, pulsation of the stapes, and now the pulsation of the big monster, the internal carotid. But it's not a problem because it's quite far away from your round window. It's lying on the promontory. So you can actually go in through the round window and insert. A bigger challenge really is the septal artery. This persistent septal artery can be a real problem because it passes through its course under the mucous membrane, or when it's passing over the promontory. It only emerges close to the oval window. So in front of the round window, if you make a cochleostomy, you can easily hit the artery. And that is a real nuisance because it can really, be a very troublesome bleed. You can always pick it up preoperatively. If you look at the scans, the foramen spinosum will be absent in these cases, and that gives you a clue that the stapedial artery may be persistent. You have to really, have very fine instruments to deal with this, and sometimes it may be quite difficult. You need very fine bipolar forceps, which will be helpful to deal with this situation. Now, the situation today is for us to think about hearing preservation. This is a patient who has a ski slope audiogram with very good low frequency hearing, but beyond 500 hertz, the hearing completely drops, and mid and high frequency, there is total loss of hearing. So in this situation, I have to think about preservation of hearing. Preservation of hearing. So you have to use soft surgery. I'm just showing you what I do in this patient. Pre-operatively, patient is started on intravenous medial prednisolone. Even as soon as induction is done, anesthetist starts 1 gram medial prednisolone. You can see the round window nicely exposed to the posterior plot. We have a good exposure. And then you harvest a bit of temporal fascia, and you dissect out the fibrous tissue over the round window membrane, so it's nicely seen. And you need to get a full exposure of the round window membrane. You see, I made a small little opening in the middle of the fascia and form a cuff around the electrode. Specially designed electrodes, just soft electrodes, are available, and they are required for you to preserve the hearing. Make an incision in the antero-inferior quadrant of the round window membrane as what I call a secondary tympanic membrane meningotomy. The antero-inferior quadrant, just like you do for a regular meningotomy in the primary tympanic membrane. And the important thing is the speed of insertion. You have to go millimeter by electrode. You need at least 2 minutes, the minimum time for you to go with the electrode inside. The reason is every bit of electrode which goes in increases the hydrostatic pressure inside the cochlea exponentially. You're creating a tsunami inside. And you have to allow time for the pressure to equalize and the fluid to egress out. So go very, very, very slowly. Today we have special devices which are coming in, like auto drive and so on, which can actually regulate the speed of insertion. Once you've got in, then the soft tissue is used to completely seal off around the electrode, so that you get a complete watertight seal that not even a little bit of fluid will come out. And then, once that is done, you can actually, then close up and come out. I don't use a steroid lake. Some people use steroids on the cavity to insert. It actually causes a parallax and refractory, refraction. So you may have difficulty with very fine insertion. So I only stick to intravenous medial prednisolone. So in anesthetic challenges, there's quite a lot of challenges which can happen, like in JLN syndrome, Jervell-Lange-Nielsen syndrome, and congenital rubella syndrome. That we've isolated cardiac anomalies. We have a publication which is a very major publication on all. You can refer to that. There's a lot of renal issues which can also be, interfering with your surgery and the choice of drugs, and neurological issues like the Chudley-Mcculloch syndrome, where you have an absent corpus callosum. But despite all this, it's well worth taking up this multi-handicapped patients, because they can, if you have a multiple handicap, even if you reduce or the one handicap, you're reducing the overall burden of habilitation. Of course, outcomes may not be comparable to a normal child, but normal child and a child without any other handicap. But still, if you can't compare the two, it's a different group, and they definitely benefit from, restoring hearing in this group. But you must counsel them, regarding realistic expectations. And if you're doing it, do it early. So this is important, and they need intensive rehabilitation. Now, Jervell-Lange-Nielsen syndrome is the one syndrome which you have to be very, very aware of, because you can actually have a cardiac arrest and you can lose the child intraoperatively. This is a syndrome where you have a long QT, and usually the QTC is more than around 400 to 450 milliseconds. And these are children who have cardiac conduction defects and with profound hearing loss bilaterally. They can have syncopal attacks, torsade point type of ventricular arrhythmias, and even syncope and death may happen. You have to get a good history of the family if there's any unexplained deaths of siblings or parents, siblings, and so on. The management starts even before the surgery. You put them on preoperative beta blocker therapy, and then any drug which will interfere with the QT is avoided, particularly antihistamines, which is very common for many other children to be on long-term antihistamines. So this has to be stopped. And during surgery, you have to avoid adrenaline. Obviously, electrocautery is not used, and defibrillators and antiarrhythmic drugs have to be kept standby. The inhalational anesthetics, like Severain, Influrane, and so on, cannot be used. You have to only use intravenous anesthetics. And the life-saving drugs are two drugs. One is intravenous magnesium, which is usually started at the very beginning of the procedure, and esmolol, which is an ultra short-acting beta blocker. These two can revert the rhythm and can be life-saving in these children. The other syndrome is branchioautorenal syndrome, where you can get branchial cysts or fistula, and there may be preauricular pits and facial anomalies. You can see the video here. Basically, these children have very large antrum, and you can see the entire middle ear through this. Surgery can be challenging, but it's not all that difficult in branchioautorenal syndrome. You can view the area, but you need to support with a lot of cartilage and so on to avoid retraction in these children post-operatively. The other syndrome, which is a bigger challenge, is golden heart syndrome. Interestingly, only yesterday I had another golden heart syndrome. They have epidermal epibulbar dermoids, auricular pits, and then they may have micrognathia and anomalies in the external ear and middle ear also. In the middle ear, they may have no window, so you will have no landmarks at all. You will have a flat promontory, no. In a patient yesterday which I did, there was a monoportal staypiece which was not connected to the whole window at all, just hanging loose, and no round window. So you can really have a challenging situation to identify the area. So it's one situation where you have to do also an anterior tympanotomy. You can see that the promontory is completely there, but there's no real bulge in the promontory. It's just a flat table kind of thing. So you have to assume come from the hypotympana up into the possible location, and then go in with your implant, and then close the anterior tympanotomy with support with fascia. Habilitation challenges, multiple handicap can be a real problem, and particularly Usher syndrome, where you have progressive blindness coming in due to retinitis pigmentosa, progressive retinitis pigmentosa, with hearing loss. Now, there are different types of Usher syndrome, but particularly the type 1, which is an accelerated form, is a real issue because children can become very, very rapidly blind with very tubular vision. And habilitation, since it's mostly dependent on visual support, can be a real challenging situation for these children. So you have to, without delay, take them. It's actually a neurological, neurocognitive emergency. So you have to go in and do them as early as possible. This is one child. She's almost blind, but she's able to manage with her hearing. Revision cochlear implant happens in a small percentage of all implantees, but remember, every implant that they've done is going to need revision at some stage in their life. No implant lasts for a lifetime. So you have to be prepared, and in the lifetime of a child, if you are implanted at 1 year of age, it may go through 2 or 3 implants by the time the child is lived its full life. The various challenges can happen. You can have device failures, and this is one other problem where the magnet has migrated, and this I've seen in about 4 or 5 now. So you can in this situation see the magnet is like completely outside the pocket. You can reposition it; it will stay in place, and then you can once again insert, or you may change the electrode. But I've never had to change the electrode. I just put the magnet into where the pocket which is there, and invariably it goes on without any issues. Cholecystoma in a cochlear implantee is almost always iatrogenic. This is a 15-year-old implantee done my own patient 2003. Usually it means that there's been some microfractures in the annulus and that you missed it. If it happens, you have to support it with cartilage. Otherwise, they may go in for retraction pocket and later on form a cholecystoma. So if you have a cholecystoma, then the implant will be working. That's a tragedy. So what you have to do is you have to open up, remove the implant, deal with the cholecystoma, and then later on, second stage, 6 months later to 1 year later, go back and do a blind sac and do the fresh implant. Normally, what I do in a situation like this is, and I'm dealing with the cholecystoma on this side, I take out the implant. I do another opposite side. I do another implantation, and then 6 months later go back to this side, so that the person is not is not without any hearing support during this intervening period. Okay, so now the another challenge we see nowadays is you have a cochlear nerve deficiency. So should we do a cochlear implant, ABI? One of the useful tools that you have is transtympanic EABR, where you have a J-shaped hockey stick electrode which you keep in the round window, and then you can stimulate and record from the brainstem. And in this situation, this is our algorithm that we follow in MUF. So your child is evaluated preoperatively, imaging with a 3 Tesla MRI minimum. It shows a cochlear nerve deficiency, let's say. Then we can do a particle evoked potentials also to give additional support. If the EABR is done in these children and shows good responses, then a cochlear implant is advised with confidence. We tell them that they'll have good prognosis. If the EABR is not good or the morphology is not good, then cochlear is still implantable. Then we can go ahead with the implantation, but with very guarded prognosis. We tell them that we will watch for 6 months, and if after the implantation the outcomes are not good, you may need to be converted into an auditory brainstem implant. Finally, auditory dysynchrony is again a very, very challenging situation where the option for treatment is today a cochlear implant, but you have to be sure that this is going to be beneficial. And once again here, transtympanic EABR is a very useful tool to tell you if in this subgroup a cochlear implant is going to be useful. So to conclude, cochlear implant is generally a very safe surgery. Of course, you can have challenging situations, and the more you do, the more you're going to be seeing. Now with more than almost 5,000 cases, we have seen almost all the complications that you can possibly see. But preoperative evaluation helps us to avoid the vast majority of these complications or even anticipate these complications. So I'll stop there. Thank you very much for the patient listening. If you have time for a few questions, maybe I can take this. Stop sharing.
Thank you, sir. Thanks very much. This is a great occasion. Guru and Sisha at the same time performing. Guru is presenting now. Sisha is doing surgery here, sir. Just Anand sir completed his surgery.
Oh,
here.
wow.
We have shown in PAP also, sir, some of the steps. Thank you very much. Also, so kind of. Sir is always trying to deliver anywhere, anytime to lectures regarding cochlear implant.
Thank you for the opportunity. Thank you so much.
I'm very much grateful to you, sir. Thank you. Thank you.
Thank you. Thank you.
Next, a little change in the program. Next, the lecture by Dr. Shankar Medikeri, one of the legend in ENT. And later on, what we missed in the previous surgery, Radhu Anand will explain everything in detail while surgical staff demonstrating the video here. Now we are going for the next lecture by Shankar Medikeri. Sir, by data, sir. శివరెడ్డి గారు ఇది ప్రజెంట్ చేయండి ల్యాప్టాప్.
So warm welcome to Professor Shankar Madikere, sir. Dr. Shankar Madikere is widely regarded as one of the leading ENT specialists from Bangalore with an impressive career spanning 39 years. Sir has extensive experience in the field of ENT and cochlear implantation and has established him a trusted authority in otolaryngology, offering patients high quality care for a wide range of ear, nose, throat conditions. So, Dr. Madikere is a recipient of DNB ENT certification, demonstrating his expertise through rigorous examination and training. He is an examiner. Dr. Madikere's commitment to professional development is highlighted by his achievement of the Fellowship of the International College of Surgeons, FICS, which reflects his dedication to the highest standards of surgical practice and education. Dr. Shankar Madikere combines decades of experience with solid educational background and a committed doctor to patient-centered care. His expertise in the field of otolaryngology along with state-of-art facility makes him top choice for those seeking ENT care in Bangalore. Sir, a very warm welcome to you, one of the very senior ENT surgeons in India. Sir, please proceed, sir.
Just 1 minute. I'm just sharing my screen.
Okay, sir.
PowerPoint delay. Are they able to see? Are you able to see my screen? Hello? Hello?
Yes, sir. Yes, sir. We are seeing the screen. Yes.
You are able to see the screen. Okay. Shall I start now?
Yes, sir. I'm seeing you also, sir.
Okay. Thank you. At the outset, I would like to thank Dr. Subbarayudu for asking me to be a part of this second cochlear implant workshop. So I think you have heard about difficult situations from Dr. Mohan Kameshwaran. Now I'm just going to speak my experience of revision surgery in cochlear implantation. Okay, mainly I am to touch upon the etiology, surgical issues, and selection of electrodes for reimplantation. So revision surgery in cochlear implantation. The first cochlear implant surgery, of course, it was a single channel electrode which was done by Dr. House and Edgar Train way back in 1961. But the first revision cochlear implantation surgery was done by Ockmer and Desoyer in 1985. The incidence of revision surgery varies from 3% to 15%. It is less in adults and more in children, almost double. The usual main indications for revision surgery in cochlear implantation can be of two groups, where either it can be device related, where it is majority of the times 3/4 of the revisions, and whereas it could be a non-device related indications.
Sir, sorry to interrupt you, sir. Can you make it full screen, sir, your presentation?
Here it is full screen. On my laptop, it is full screen.
Okay.
Any issue? Anand, on my laptop, it is full screen. Reduce. end the show and then again magnify?
Yes, sir.
Now?
Yes, sir. Now, okay. Start the presentation button, sir.
You want me to go like this?
No, sir. You can press the presentation button, sir. Yes. The screen.
That slide is or slideshow. Yeah, now?
Harsha?
Okay.
Harsha.
Now?
Harsha?
Slide is not moving. It's moving here.
Here, the only one slide is visible, sir. Other
Oh,
slides
is
are-
it?
Yes, sir. Harsha, how to change,
I
sir?
don't know.
Matlad, sir. He's making call, sir. He's making a phone call.
Oh, can I? Otherwise,
Wait 1 minute.
I will
sir.
just 1 second. I will ask my son to just check this.
దీంట్లో మాట్లాడమ్మా గౌరవ్తో మాట్లాడు గౌరవ్ ఓకే స్పీక్ విత్ గౌరవ్ సార్
Gaurav. Gaurav has come here. Just 1 second. 1 second.
Yes, sir. We can see your picture full screen.
Yeah.
The slide presentation needs to be shared.
Yeah. 1 second. Has it come now?
Yeah, it is good, sir. It's come.
No,
full
1 minute. 1 minute. Sorry. Is it
Right.
moving now?
It's moving now, sir. It's good. It's clear.
Okay. Okay. Shall I continue then?
Yes, sir. Please do.
Were you able to see this slide earlier?
Now we are seeing full.
Now you're seeing full screen. Okay. So as I mentioned, the first revision cochlear implantation was done by Hockmer and Desoyer in 1985. So though the incidence varies from 3 to 15%, it is more in children than in adults. So the indications for revision surgery will be either non-device related indications or device related indications. So our cochlear implant program is almost 2 decades old, and we are close to about 1,000 implants to our credit. And the number of revision surgeries I've done is about 30. So giving an incidence of about 3% in our series. So mainly we had a pediatric implants and only one adult reimplantation. So in our series, our non-device related indications were about 44%, 12 out of 30, whereas the device related indications were 18, that is 56%. So when I divided these non-device related indications, though infection, mainly the scalp infection was there, because of which we had to revise or explant and do the reimplantations when we were not able to control that infection with the antibiotic treatment as well as the local debridement and flap closures. Whereas in cholesteatoma, case of cholesteatomas, we had to do it in 2 cases. We did test one of our patients who is suspected for allergic reaction to silicone allergy, but we didn't have any of the patients requiring reimplantation. And we had extra cochlear electrode placements, misplacement of the electrode array in 5, this is high, and extrusion of the electrode array in 1 case. So as you know, I have been mentoring, till now I have mentored about 45 ENT surgeons in different parts of the country. So this revisions also include some of the implant revisions which I have done in my mentorship centers also. Out of these 5, 1 was mine and the remaining 4 have been in the Menti centers. Whereas the device related indications, we had none of the patients with facial nerve stimulation. We had to do a reimplantation. They were managed with frequency transposition and remapping. Whereas we had about 14 hard failures of different companies and soft failures in 4 cases. So coming to the scalp infection and device exposure, this is what where in 1 case where only the electrode array was exposed, where the other case the receiver stimulator body was exposed. So initially we tried with all antibiotics and opening the wound, exploration and debridement and removing all the surrounding tissue of the receiver stimulator where there was a bacterial bioflora. So then did a relocation of the receiver stimulator and covering it with a periosteal rotation flap. So this worked about 7 to 8 months, and then again the patient came back with wound breakdown. So then we had to ultimately explant those implants and later on re-implant them here. So the bacterial biofilm formation in these cases is a major threat. So the most of the etiopathology or etiopathogenesis in this infection is the infection surrounding the implant because of biofilm production. Because they form a biofilm which consists of these exopolysaccharides, and it happens on adheres to the implant surface both laterally as well as medially. So the body also forms, even the body of the receiver stimulator also forms some foreign body granulation reaction surrounding the implant, which also hampers the recovery of infection. And usually the common microbes are the MRSA or a staph epidermidis or even Pseudomonas. So any antibiotics initially, when it is immediately noticed, may be treated with amoxicillin, clavulanic acid, or even piperacillin and tazobactam. But what we have found very effective is the rifampicin, which is given 10 milligram per kg body weight per day for some cases for almost 6 months. We were able to save the implant in one of the cases where we did not have to do an explantation, whereas the other cases we had to do explantation and do the reimplantation. So surgical debridement, as shown earlier, has also been tried. When this doesn't work, then we had to explant the implant. So this is one of the such cases where we had done the explantation, and at a second stage, we did the reimplantation. So this patient we had, because the infection was only in the surrounding the receiver stimulator, the electrode array, the mastoid part was not involved. So we had left behind the electrode array within the mastoid and the cochlea. But as you can see here, the mastoid portion is already closing here. I had to do a revision mastoidectomy, open up the cortical mastoid and do it. At the same time, take care of this electrode array, not to pull it out. And we had to do a sharp dissection of the connective tissue surrounding the electrode array without pulling out the electrode array till the end. So both with scissors or Irish scissors or even sickle knife, we had to dissect it carefully and without disturbing the intracochlear part and without pulling out the electrode accidentally. You can see here even the posterior tympanotomy was obliterated with bit of connective tissue. So that also has been dissected out. When you are doing this, one has to be careful if in the previous surgery, the first surgery, the facial nerve, whether it has been exposed here in posterior to the posterior tympanotomy. If there's something like that, if you find in the notes, one has to be very careful when you are doing this dissection. At last, we'll do the dissection of that connective tissue within the middle ear till we reach the site of the cochleostomy and find it loose, a checked ear. In this case, this was a Freedom Contour Advance electrode from Cochlear. So then I fill up the middle ear and the adductus with an adrenaline gel foam and go to the bed. Even the bed was partly obliterated, so I had to little bit redo the bed till I get a proper size bed and with the vertical edges. Then I took the silastic template and marked the tunnel for the electrode array, as you can see here. And where the tunnel joins the mastoid, I always leave behind a ledge of bone so that my electrode array goes underneath that so that it doesn't come out easily from the mastoid. I also used to do initially these tie holes on either side of the bed and used to use Prolene for anchoring the implant. So once this has been done completely, and once you make sure that we have exposed the proximal ring of the Contour Advance electrode, then I take the new implant and place it in the bed and anchor it first before trying to do any manipulation of the electrode array. Once I anchored, so as you can see here, with the left hand, I am pulling out the first electrode, and with the right hand, immediately I am going to do the insertion. That was a Contour Advance electrode, whereas a new electrode, what I am inserting now, is the straight array from Cochlear. So preferably whenever you're doing a reinsertion, either you should use a similar electrode or you use a thinner electrode compared to the first electrode. I was able to get a good complete insertion and then plug the cochleostomy, in this case, with the periosteal tissue. The next, coming to the silicone allergy, just to mention, this is due to device extrusion can occur due to reaction to the liquid silicone rubber. The different companies use a different liquid silicone rubber. Advanced Bionics uses LSR 70, Cochlear LSR 30, and Medal LSR 40. All these companies, they will have these allergic kits with which you can do a patch test, prick test, or an intradermal test. We had an occasion in one case to do this test, but the test was negative. Then ultimately we had to explant that and do with a revision implant, which you saw. So if this test becomes positive, then we have to explant the earlier implant, and about 6 weeks later, you can do a custom-made CI for that particular, or a ceramic receiver stimulator can be used in these cases to avoid allergic reaction to the silicone. These are different cases where there was an electrode placement in the one in the internal auricular eustachian tube, or even the third very interesting case where the mentee surgeon had gone through the cochlea, first basal turn, then come out of the turn cochlea, then the electrode array tip had gone into the crotch area between the carotid canal and the jugular bulb area. As you can see, the rest of the whole cochlea is empty here. There is no electrode there. So this, I will show you the which I did a revision, that particular case, the third one, what you saw. So it was 1 month after this surgery. They didn't find any neural responses on the table, and then they did the scan and sent it to me. So here, after 1 month, I'm doing the explantation. I cut the electrode array, both ground electrode and the active electrode, removed the receiver stimulator. Here again, you can also see again there is an obliteration partial of the mastoid cavity. So I had to redo the mastoidectomy and thin the posterior canal wall as much as possible, identify the posterior tympanotomy area. I had to a little bit redo even the posterior tympanotomy, especially the inferior part and posterior part, and look for the round window. Because in this particular case, the surgeon, the first time, had done a cochleostomy insertion. So then I wanted to identify the round window, and after dissection of this granulation tissue and fibrous tissue surrounding the electrode, I was able to identify the round window and confirm that it is a round window by movement of the ossicular chain and looking for the round window reflex. So here, this extending inferiorly, it is very important, posterior tympanotomy. Here I am removing the upper lip of the round window. You can see I'm moving there. You can see the round membrane movement. I don't know whether you can make it. And then we decongest the whole cavity with the gel foam with adrenaline. Then I'm pulling out the first electrode array. You can see multiple kinks in the electrode array. There was no point we can use that again. So now needle, I'm puncturing the round window membrane. You could see a little bit of perilymph coming out there. So then, because here the earlier implant array had transgressed the cochlea, I wanted to use a dummy electrode first. I'm putting a dummy electrode first now and checking it with a C-arm picture, whether it is taking the path of the earlier path or is it going into the cochlea. So we could see the electrode array going into the cochlea and taking a turn here. Once I'm sure that I'm able to go, then I open the new implant, anchor it in the bed, and pull out the dummy electrode. In the same way, I'm inserting the new electrode array. This was again a straight electrode, which I was able to slowly and gently use the same intracochlear path, not that earlier wrong path which had gone out, but into the cochlea, and we were able to put the ground electrode underneath and check again for the position of the electrode array which was within the cochlea. And these were the NRT responses we couldn't get for 6 and 7, and that may be because partly we had that portion of the cochlea, lateral wall was damaged. Those were the impedances, and these are the neural responses which we got after reimplantation. So this was a patient where CI surgery was done in CI 24 REST in June 12. and switch on was done in July 12. And in 2019, her first 3 electrodes were open and they had to be switched off, 1, 2, 3 electrode. So this patient went for the nucleus 6 switch on in March 2019. They went for an upgrade of the processor. But here again, when we use the 4th and 5th electrode, were switched off since the stimulation of these electrodes was causing a lot of discomfort. So as one by one electrodes were going out, so we were worried about whether the electrode array is getting extruded partly. In 2020, but though we had done a frequency transposition with the available electrodes and managing, then in 2020, again we had to switch off another 6th and 7th electrode. So there are already 7 electrodes being off. We took the X-ray when we could see that there was partial migration of the electrode array in January 21. Then we had to revive this patient and do the reimplantation. So this electrode migration is identified when you see a significantly increased impedance values or non-auditory stimulation of basal electrodes during the mapping sessions. So all the extruded electrodes, both of them were lateral wall electrodes, that is the straight electrodes. So this electrode extrusion or migration of the electrode may occur long time after surgery, not necessarily that it will happen in the first few years, maybe 8 years, 10 years down the line. Usually a moderate amount of fibrosis was found in the cochlear loop. And sometimes even osteoneogenesis makes the reinsertion of the electrode array challenging. So, but if you can do the electrode reinsertion with a depth comparable to the initial surgery, then the speech perception abilities are maintained even after reimplantation. We had some cases of facial nerve stimulation. The incidence of facial nerve stimulation again is 1 to 15%. Usually this happens not in the area of posterior tympanotomy, even if the nerve is exposed there. Usually this happens in the outer wall of the cochlea. Hence, because this is common with full band electrodes, that is the straight electrodes, not the perimodular electrodes, which are hugging the modulus and they are away from the lateral wall. And this is more common in cases of otosclerosis, malformed cochlea, or an ossified cochlea. So in these cases, because it is the stimulation is common with the lateral wall electrodes, so usually a perimodular electrode is preferred. That is the half band and modular electrodes are preferred in these cases to avoid facial nerve stimulation. These diagrams are showing exactly, you can see the placement of a contour advanced electrode in the left hand side. On the right hand side, you will see a lateral wall electrode. So you can see where the facial nerve is running, how these lateral wall electrodes are close contact with this facial nerve which is outside, whereas the perimodular electrodes are a little distance away. So usually from 8th to 13th electrode in this diagram we can make out. So that is the place where the nerve comes in contact, and any auditory sensation when they are eating, it can pass and stimulate the facial nerve. That is how the facial twitching can happen. So managing these cases is usually because it is noticed during the post-operative mapping sessions or therapy sessions. So usually the twitching appears on stimulation of particular electrodes. So if we can reduce the current levels on these electrodes and still if we can manage, then these can be helped to avoid the facial twitching. But in our case, we were not able to switch off these offending electrodes because there were only few electrodes which were switched off, and the remaining part were managed with a frequency transposition with the remaining electrodes and reprogramming. None of our patients with facial twitching required explantation or reimplantation. So coming to the device failures, the device failure can be either a hard failure or a soft failure. Hard failure is the one where usually there will be a loss of sound and telemetric lock, and there will be atypical tinnitus or intermittent function, shocking sensation. Sometimes the impedances can be fluctuating, and sometimes you lose some of the electrodes, stop functioning, and sometimes you will have open circuit of the electrodes. Whereas in soft failure, though there is no telemetric lock is there is lack of progress and intermittent function can be there. And during the programming session, you might have difficulty in programming these patients and mapping. And these patients can hear an aberrant sounds, or there could be sometimes increased loudness, or sometimes they may come with non-auditory symptoms like pain, giddiness, or headache. So in our series, we had in Cochlear, we have a Nucleus 5 series, 4 implants which were revised. These were the cases with a hermetic seal issues, because of which the company had to recall these implants. And another was the Nucleus CI24 REST and one Nucleus Freedom Contour Advance. Whereas in Advanced Bionics, again, there was a 1J electrode, 3 cases were there with hard and soft failure. And one of these patients was a mentally retarded child who had sustained blunt head injury and then severed the electrode at the exit point from the receiver stimulator. So this patient was reimplanted. Company was kind enough to give another implant, but because we had noticed a good progress of the child after the first implantation, company, I should say thank you to them, because they gave another implant also to implant this child both the sides so that the child can do very well. So in of course there were another 7 HB advanced bionic high-res ultra V1 failures. These V1 failures were again because of the hermetic seal issues, and this batch of implants were again recalled by the company. So this we had to remove and then implant them with the Ultra 3D V2 series implants. And we had 2 Sonata implants in the DIP scheme, which had to be reimplanted because of the soft failures from Metal Sonata. So this was a video which I want to show one of the advanced bionics implants, where I'm cutting this electrode array in the mastoid and removing the receiver stimulator. If you can keep the electrode array along with the implant body and remove it completely, that will be good, because company would love to have the whole implant also. But if you're scared of the electrode array being pulled out when you're trying to manipulate or handle the receiver stimulator, one can cut the electrode array in the mastoid or close to the posterior tympanotomy and leave behind the intracochlear part of the electrode till the end and remove it only just before the reinsertion of the electrode. Here I have done again a mastoidectomy, little bit completed. I am dissecting the electrode array within the posterior tympanotomy and mastoid and thinning the posterior canal wall further to have a good access to the posterior tympanotomy. And even posterior tympanotomy, as usual, again, I had to little bit redo, especially inferiorly, to expose the middle ear very well and see the location of the cochleostomy and the round window, whatever has been done, and where the electrode array is entering the cochlea. The final dissection in the posterior tympanotomy and middle ear is done with the help of fine scissors after you widen the posterior tympanotomy with the help of fine scissors without disturbing the electrode array from within the cochlea. So make it loose completely. So till the opening into the cochlea, either a cochleostomy or round window, as it may be. And then here again, the bed had to be a little bit redone in this case. And even you can see even the electrode array tunnel also was partly closed. I had to redo it again. And then only we open up the new implant package. Here the Advanced Bionics new implant has been put here in the bed. And because we have made a tight packages, I am not doing the anchoring now. So I remove, you can nicely see the sheath, the intracochlear sheath through which the electrode array had gone, this tunnel. So I am introducing a new slim J electrode through the same intracochlear tract, and majority of the times, most of the time, I've been able to do a complete insertion. This case, so do the complete insertion and then repack that area surrounding the cochleostomy. And the loop of electrode array is tucked into the adductus, and then the connective tissue is packed here. So this tucking, this also prevents the electrode array coming out of the mastoid cavity. So this was another patient of Medel. So where we had to revise, I am dissecting the periosteum above the mastoid cavity, and I was able to see the receiver stimulator. There was a capsule form surrounding the receiver stimulator, I just opened up with the knife, and I want to retain this capsule because there was no infection or nothing. It was quite clean. But as you can see, even the electrode array which was jetting out from the body of the receiver stimulator, that initial part where we had done the tunnel was closed because of bone growth. So I'm just drilling that bone to expose the electrode array, the beginning part of the electrode array. Then I mobilize the receiver stimulator. Then I'm pulling out this receiver stimulator and putting it aside. Here I'm not I'm not cutting the electrode array here. I'm leaving it behind. I'm going to take out the whole receiver stimulator and the electrode array in one piece. So after keeping the receiver stimulator aside, so your assistant has to keep track of that and see that it is not pulled too much. And then we do the final dissection of the electrode array. Soft tissue is all dissected out with a sickle knife and as well as an iris scissors. So here again, the anterior part of the posterior tympanotomy had to be little bit drilled away to expose, have a good open posterior tympanotomy to have a good access into the middle ear. So I'm using a diamond burr here. So then I start dissecting the connective tissue surrounding the electrode array within the middle ear till I reach the site of cochleostomy and then dissect it out and make the electrode array completely loose so that I can easily pull it out. So then I take a new implant. This is a metal implant. So as you can see here in the same socket, I am putting this new implant receiver stimulator. So it is sitting nicely in that pocket. So there is no need to anchor this again. So now again, with the left hand, I am pulling out and you could see the opening there. And with the right hand, then I am reinserting the new electrode. In this case, I am using the Form 24 electrode with the stopper here, and slowly and gently we inject, making use of the same intracochlear tunnel, so sheath. So I was able to do a complete insertion, and the cork was going to seal nicely that opening in the sheath. And apart from that, I also could put some connective tissue seal surrounding the cork so that it is nicely packed. So in this way, we were able to do a complete insertion and reimplantation. So the surgical tips for reimplantation is always one has to use a bipolar cautery when you're doing reimplantation. And the electrode array should be dissected out from the surrounding fibrous tissue carefully. And the new electrode array should be of the same length or shorter length and a smaller diameter. So in case of device failures, use the intracochlear part of the electrode array is left there and use the same intracochlear tract for reimplantation. So whereas in case of extracochlear electrode placements, round window or an extended round window cochleostomy can be used for doing the reimplantation. And in these cases, always it is better to use a dummy electrode first and check the position of the electrode by C-arm before doing the reimplantation. Always keep in mind that improper technique can lead to incomplete insertion or traumatic electrode insertions, which will affect the performance of the child. So one should aim at doing a complete insertion so that you will get an equal amount of performance as it was there before the first, after the first surgery. So again, some things to keep in the challenges of reimplantation are the new tissue formations, such as this could be a bone or connective tissue around the electrodes, and the extraction of the electrode and reinsertion of the new electrode array is always a challenging task. If the electrodes with a larger diameter shall be inserted, sometimes the complete insertion may be difficult. Whereas if the new electrode is not completely inserted, the hearing results may be poorer compared to after the first implantation. Whereas if the same implant type or the electrode is used and with the identical electrode positions in the cochlea, the hearing results after reimplantation are as comparable to the results after the first implantation. So whenever we have to remove the original device safely, and we should ensure that we don't encounter any issues with local structures. Once we have replaced the electrode, we should perform an X-ray or a neurological test to confirm the position of the implant. And whenever we remove a very thin electrode, the challenge will be to get a new device back into that only tiny opening. So that one has to be careful, especially when you are using the slim electrode in the first place itself. And revision procedures can lead to similar clinical outcomes as the original implant. So surgically finding the right size and fit and getting the electrode back into position should be our main goal in cases of reimplantation. And whenever you're planning for reimplantation, these are some advices. The key point should be you should know the whole procedure for reimplantation is to get the whole surgical sheet back. If it is your own implant, it's fine. If it is from some other centers, you must get to know that what implant was used and whether there was any exposure of the dura or any exposure of the facial nerve during first surgery to help you to be careful during the reimplantation. And whenever we are planning for revision surgery, you must always make sure that you have the correct or the right implant type present in the operation theater. If you don't know or if you are in doubt, it is better to have different types of implants present so that the decision of the implant type can be made during the surgery. And whenever a straight electrode array is being removed, so it should be replaced with an electrode of the same dimensions. Whereas when you replace a straight array with a perimodular array, you risk that it will get stuck somewhere halfway. Maybe one has to be very careful. In such cases, better to use the perimodular electrode with the stillet in place instead of doing off stillet technique. So with the stillet in place, you insert till the end and then you withdraw the stillet. In this way, you are able to make sure that you do a complete insertion. Whereas when replacing a perimodular electrode array with another perimodular, so obviously the dimensions are the same and the electrode should go without too many difficulties. So in conclusion, management of implant failures, including revision surgeries, is becoming an increasingly important part of cochlear implant program activity. So reimplantation appears to be a safe and effective procedure. Patients and parents should be counseled that performance is expected to equal or surpass the child's best level of performance before revision surgery. Although this may take some time, and sometimes, of course, exceptions do exist. So revision surgery in cochlear implantation should be considered when longitudinal clinical assessment reveals an unfavorable trajectory in the development of receptive communication skills. So we strongly emphasize the need for close monitoring and special attention regarding follow-up of babies and young children, especially during their initial years of implant to use. These are my references, and thank you very much for your patient listening. If there are any questions, I'd be happy to answer.
Thank you very much, sir, for this excellent lecture and sharing your enormous experience with cochlear implant surgeries.
Yeah.
Any
Thank
questions
you.
from audience? Thank you very much, sir.
Okay. Thank you. Thank you once again to the organizers as well as all the delegates.
Thank you, sir.
Okay.
Thank you, one and all. I think this concludes our session today. One of the lectures that is supposed to be next, Dr. Rajesh Vishwakarma's, is postponed to tomorrow. So tomorrow we have two lectures from eminent cochlear implant surgeons. One from Professor Milind Kirtane, which is a 1 hour lecture, and Dr. Vishwakarma is also going to give his talk tomorrow. Sir? No, sir. Sir, can we? One surgery we missed earlier. We could only see half of what sir did, Dr. Raju. If everybody is okay, we can just go through that and discuss. Yeah, thank you, sir.
It's better for your memory sake now only. Tomorrow we may forget. Okay. And also two more announcements. please join by 7:30 for the delicious Guntur specials or the live counters. And also standing comedy by Mansudan Rao sir. Last time also we have enjoyed very well. Can refresh out of the scientific load for ready for tomorrow. And also tomorrow morning we'll start by 8:30 sharp. The lecture by Dr. Arun Kumar from the candidacy criteria. Then 9 o'clock sharp we'll start the surgery of the varia technique. I will demonstrate the varia also. Very simplified manner. After that, we have the lecture by Rajesh Vishwakarma and also in between and Radhu Anand lecture. Later on by 12 onwards, Professor and Padma Shri Milind V. Kirtane lecture. That is the complications and how to manage the complications in the cochlear implant surgery. That's why everyone join. Please come by sharp 8:30. If those who want to have the breakfast, please message me. We'll arrange for that because we are not providing for all. Those coming from out of stations, those who are want, please send the numbers to me. We'll provide the breakfast to them. Thank you. And also lectures and coffee continuously available. Thank you for joining. And also just pardon me for the morning.